Okay. Good afternoon, everybody. Good afternoon, Sandeep sir, Secretary of POSI. Good afternoon, all the delegates and faculty who have logged in for this virtual meet. On behalf of Kolhapur Orthopaedic Association organizing team, I welcome all the delegates and faculty for this virtual POSICON 2022. Before we start, just a brief as to why the Kolhapur conference was cancelled. We had taken a lot of efforts, and the organizing team led by Rajiv had done all the hard work to organize this event in Kolhapur. Once we had to postpone it last year, and this year also, all the people enthusiastically worked to make this conference a great success in Kolhapur. We had 4 stalls of 50 capacity each, keeping into mind the social distancing norms and all the other formalities which were there in this pandemic, which were there given by the local authorities. The scientific program was well laid out. We had made arrangements for the physical meet, as well as, unfortunately, those who could not attend the meet, we had made arrangements for the virtual mode. But unfortunately, on 11th of this month, that is only 3 days ago, we got a letter from Maharashtra Medical Council stating we had to cancel all the physical meets. So with a heavy heart, we had to cancel this conference. We regret any inconvenience or hardship caused to all the delegates and faculties who had made their arrangements to travel to Kolhapur and for their stay in Kolhapur. Lastly, I would like to thank on behalf of the organizing team of Kolhapur Orthopaedic Association, the President of POSI, Dr. Dhiren Ganjawala sir, Sandeep sir, the Honorary Secretary, the entire EC of POSI for their continuous support, encouragement and guidance which they have extended to us in last 2 years. We had a lot of Zoom meetings with these guys and a lot of phone calls with them. Thank you all. Anyway, some things are beyond our control and we have to move on, and hence we are logged in here for this virtual meet. So once again, I welcome you all on behalf of organizing team of Kolhapur Orthopaedic Association and POSI for this virtual conference. I wish this meet a great success, and I hope you will all enjoy this academic feast. Thank you.
Thank you very much. Thank you, Deepak. And on behalf of POSI, let me place on record that we have moved from Goa to Kolhapur to our bedrooms and living rooms and offices for this POSICON 2022. But it's like man proposes and COVID disposes, and the government nowadays. So with those few words, I wish POSICON 2022 virtual conducted jointly by KOA and POSI a grand success. And I hand over to Cherry and Ashish Ranade to conduct the first session on limb lengthening, and Alaric and Jayan to be the experts. Thank you very much.
Thank you, Sandeep. Welcome all for this meeting. Unfortunately, we could not have the physical meeting. We were looking forward to it. Without much ado, we'll start with the first talk, that is causes of limb length discrepancy by myself. Ashok, can we have the recording? Good afternoon. I'm Dr. Cherian Kour. I'll just give a brief outline of causes of limb length discrepancy in children. Greetings from Kochi. Limb length discrepancy can be either due to a short limb or a longer limb. It's either congenital, developmental, or acute. Always, whenever you see a limb length discrepancy, always check. What is the severity of the discrepancy? Is the limb well formed? Are the thigh and length of normal relative proportions? Is the shortening in the thigh or the leg segment or the both? Is there any angular deformity? Ask the parents if the discrepancy is increasing. Is there any history of trauma or infection? Are there any neurogenic problems? Check. See for any muscle atrophy. See for the gait, whether it's short limb, Trendelenburg, antalgic. Range of motion of hip, knee, and ankle should be checked. Most of the time, limb length discrepancy can be well assessed by a radiography. Occasionally, you need ultrasound for unossified regions, and of course, to check for visceral anomalies, especially in case of hypertrophy. There are various causes. One of the causes is deformities, either coxa vara or in the leg, congenital posteromedial bowing of the tibia or the anterolateral bowing of the tibia. Both can cause shortening. In the hip, the common dislocation is DDH. Notice many a time when the child starts walking, or a teratological dislocation, sometimes post-infective. Sometimes sequelae of infective arthritis, either due to an adduction deformity or the distraction of the head without dislocation, also can cause the same problem. Congenital limb deficiencies, either femoral deficiency due to proximal focal femoral deficiency or a congenital short femur, or a fibular deficiency, either total, partial, or a fibula hemimelia syndrome, or the unusual tibial deficiency, either total or partial. Trauma is one of the common causes of growth arrest, either trauma or infection or malunited fracture, again causes limb length discrepancy. Paralytic disorders, poliomyelitis, hemiparatus, asymmetrical peripheral neuropathy, all this can cause limb length discrepancy. Tumors, especially osteochondroma or enchondroma or bone cyst near the growth plate, again can cause the same problem. Hemihypertrophy, the affected limb is shorter. Again, hemihypertrophy, it can be idiopathic or Bennett syndrome. In these cases, always do an ultrasound or refer to the pediatric surgeon to rule out any other intra-abdominal tumors. Again, local gigantism with neurofibromatosis, where you have a relentless progression of the limb length discrepancy and size. So in summary, identify the cause, relevant X-rays and investigations, keep in mind other associated conditions, decide what line of treatment depending on either ignore or sole raise or amputation, extension processes, limb lengthening, epiphyseal disease, either ipsilateral or contralateral. Thank you.
Thank you, Terry. That was a nice brief overview. Next talk is by Kirti. He's going to tell us about the natural history of limb length discrepancy. What happens if it goes untreated? I'll hand over to Kirti's talk, please.
Good afternoon all, and thank you, Posi, for giving me this opportunity. Today I'll try and make sense of what we know about the natural history of leg length discrepancy till date. So during this topic or during this talk, I'll brush up upon the incidence of leg length discrepancy, how much of it is clinically significant, compensatory mechanisms used by KID and their effect on gait, and the secondary effects on hip, knee and spine and other joints. So contrary to popular belief, leg length discrepancy is very common. In fact, 10% of the population only has a equal leg length, and 90% of the population at least has a leg length discrepancy of 1 centimeters or less. And if you increase it to 2 centimeters or more, so 1 in 1,000 population is affected. To the extent that world's fastest runner Usain Bolt also has a leg length discrepancy of 1.3 centimeters. So Bolt has scoliosis, which causes his right leg to be shorter than the left leg as a compensatory mechanisms. And researchers, they concluded that correcting this asymmetry will lead to unnatural gait for him, which highlights the importance of compensatory mechanism in our body and gets us to the next question: how much of a LD is actually clinically significant? So most of the surgeons believe that less than 2 centimeters is clinically insignificant. However, Tolroth in 2017, he followed up 194 patients over 29 years with a full-length radiograph, and he found out that 70% of the patients who require total knee arthroplasty had a leg length discrepancy of greater than 5 millimeters, and that longer leg was more affected than the shorter leg. Harvey and Murray also found out increased incidence of knee osteoarthritis and degenerative spine disease with LLD of as little as 0.5 centimeters. However, the literature becomes equivocal regarding when the intervention is necessary and what is the optimal modality, mainly because these natural history studies, they have their own limitations. So following up of minimally symptomatic or asymptomatic patients over a longer period is difficult. There is little control over the amount and the source of leg length discrepancy. Compensatory strategies used by different patients, they differ, in fact, by the same patient, because we are talking of a pediatric age group. So at differing ages, a child will use different compensatory strategies. So these compensatory mechanisms, they start appearing as little with as little as 5 millimeter of LLD, and they increase as the LLD increases. On the shorter size, the kid will use equinus or increased plantar flexion along with pelvic obliquity, while on the longer side, knee and hip flexion along with pelvic obliquity is usually used to compensate for the LLD. Kids, they compensate so well that Escott and Kelly, they found out that knee height asymmetry of less than 4 centimeter is very well tolerated by children, and it does not lead to any significant cosmetic or functional deficit. However, this will affect the gait of the child. So gait deviations, they start appearing with LLD of as little as 1 centimeter, and they increase as the LLD increases. In fact, for leg length discrepancy of greater than 7 centimeters, patients will use a combination of compensatory strategies, and for less than 7 centimeter, they can use either of the strategy in isolation. Euna, in his gait lab study, found that most children with LLD will use a gait strategy which places more work on the longer limb. Predominantly, femoral shortening resulted in increased work at the ankle over normal, and tibial shortening, it resulted in increased hip work on the shorter side. Along with changes in gait, LLD also causes secondary changes in joints. Stress fractures have been associated with LLD. Majority of them would occur on the longer limb, and tibia and femur are the most commonly affected bones. It may be a causal factor in development of non-specific low backache and sciatica. It imposes a structural malalignment on the lower back, but does not unequivocally relate the asymmetry to back pain. Pelvic tilt, it shifts the center of the gravity, thereby it increases the joint load on the hip as well as the knee joints. Also, it causes uncovering of the joint, reduces the contacting area, thereby leading to hip and knee osteoarthritis. So take home, mild leg length discrepancy is very common. LLI as low as 5 millimeter may cause compensatory mechanisms to kick in, as well as gait changes. Although not proved conclusively, mild LLI can lead to degenerative changes and stress fractures. Thank you.
Thank you, Kirti. That was a good talk. Now we'll move on to the next talk, that is prediction of limb length discrepancy at maturity, assessment by conventional methods. Mandaracharya will be talking. Over to you, Mandar.
So, good afternoon, everyone. I'm Dr. Acharya, and I will be talking on prediction of limb length discrepancy at maturity by conventional methods. Epiphysiodesis of distal femur and or proximal tibial physis is commonly performed in children and adolescents to treat lower limb discrepancy. It is important to determine the amount of growth remaining in the physis. The various methods that are described are White-Menelius arithmetic method, Green-Anderson's growth charts, Moseley's straight line graph, and Pelly's multiplier method. So first we will take a look at arithmetic method. It assumes that adolescents over 9 years of age, the distal femur grows 10 mm per year and proximal tibia 6 mm per year. In boys, the growth ceases at 16 years of age, and in girls at 14 years of age. Now, this method uses chronological age. The preoperative length of normal femur or tibia and that of the shorter segment are measured, and the limb length discrepancy is calculated according to the chronological age. Final discrepancy of 1 to 1.5 centimeter is considered to be a good or excellent result. Coming to the Green-Anderson growth remaining charts, this method requires at least 2 interval measurements separated by at least 3 months by a scanogram, the growth difference between the involved limb and the normal limb is multiplied by 100. Okay. And that result is divided by growth of normal limb. So again, the next bullet shows that the growth of the normal limb minus the growth of the involved limb is divided by growth of the normal limb, and that is multiplied into 100. So that gives us the percentile. Now these graphs indicate the growth remaining from the skeletal age of 8 years in girls and 10 years in boys until maturity. They recommend skeletal age. Now the criticism for this method is that it uses only certain determination of bone age for timing of epiphysiodesis. It does not consider socio-economic status, generation, ethnicity. It does not include estimation of foot height. The next method is Moseley's straight line graph. Now, Moseley simplified Green-Anderson charts by mathematically manipulating the original data to fit into a straight line graph. It avoids mathematical calculations of growth inhibition and provides a ready prediction of the results of epiphysiodesis. The reference slopes are provided for predicting future limb growth. The difference between the slopes of normal leg and the shorter leg is the growth inhibition. Now, this also has a criticism that it does not include estimation of foot height. Then comes Dr. Paley's multiplier method. He also used Anderson's database for calculating the system. This data was originally presented by Anderson with 2 standard deviations of femoral and tibial lengths at different chronological ages for boys and girls. Now, Paley converted this data to a length at skeletal maturity multiplier. Now, I am not going to talk more about this because Dr. Ranade is going to talk about this in the next talk. Now, we are going to have some comparative studies. These are latest studies wherein comparison has been done between previous methods and various methods. And these are studies from 2013 to 2019. So the comparison of Green-Anderson growth remaining graphs and White-Menela's prediction of growth remaining in the distal femoral physis and proximal tibial physis. This study was published from Texas Scottish Rite Hospital. Now, this study observed no relationship between length percentile at the time of epiphysiodesis and the amount of growth that actually occurred. Growth in distal femur, they got the results that it is 9 mm per year and proximal tibia 6 mm per year, and that was relatively constant. And they compared in both the methods and come to a conclusion that skeletal age was better predictor for both methods than chronological age. This study concluded that, now this was a study, first it was conducted by Dutch group and with Dr. Moseley's group, and this study concluded that straight line graphs provide a generally more accurate prediction of leg length at maturity by virtue of multiple preoperative evaluations. But this needs multiple preoperative evaluations, that has to be noted. Now, skeletal age resulted in more accurate predictions. Now, coming to the another study which has been published in Children's Orthopaedics. This study compared accuracy of growth remaining method to assess limb length discrepancy using various methods. Previously, they used primarily Green-Anderson's method to plan the timing of epiphysiodesis. Okay, so they primarily used this method, and then they assumed that we have to calculate it using multiplier method for bone age, using bone age, multiplier method using chronological age, and Moseley's straight line graph. Now, these comparative studies, and they studied 4 factors: expected limb length discrepancy without treatment, effect of epiphysiodesis calculated by all these methods. Okay, expected limb length discrepancy at maturity with surgery, difference between expected limb length discrepancy without treatment and with treatment or surgery, the final limb length discrepancy at maturity, which is the real limb length discrepancy after maturity. And they came to these conclusions. Closure of epiphysiodesis was within 12 months in almost all the cases. And the final limb length discrepancy, about 1 centimeter, was in 47.7%, 1.1 to 2 centimeter in 40.9%, and more than 2 centimeter in 11.4%. Okay. So the conclusions they derived was, generally all these methods gave an overcorrected value. So this is the graph which they have given with various methods. And you can see on this line that most of the methods gave overcorrected methods. You can see these are the overcorrected values and these are the undercorrected values, and few are on the straight line, which means that they are the actual values. So they came to a conclusion that none of the current methods are accurate at predicting final limb length discrepancy at maturity with surgery, although they are clinically effective. So the take-home message is, White and Milanio's arithmetic method is easy to apply in clinical practice. The multiplier method has become easier to use with the multiplier app. Thank you. Thanks for the opportunity.
Thank you, Mandar. And we'll move on to the much awaited prediction of limb length discrepancy, which we all use nowadays, is the multiplier app. And Ashish will be talking about that because Ashish has worked with Orthopaedic also.
Good afternoon. We are going to discuss about the multiplier method for the assessment of leg length discrepancy. This 6-year-old who had left distal femur physial arrest presented with this deformity. It is important to know what is the leg length discrepancy at skeletal maturity. This baby with fibular hemimelia, this child with physial growth arrest, it is important to know the LLD at skeletal maturity so as to ascertain the treatment plan. But we need to know how much the difference is going to be. That will decide whether the limb can be salvaged or limb lengthening operations can be offered. It will also help us to decide on the number of lengthenings that are needed and also to determine the timing of physiodesis if necessary. Multiplier method is a system of calculations to predict the height and bone length at skeletal maturity. It is based on Anderson Green growth charts, and there are other databases, 21 databases which they have used. For this, the information that you need is the sex of the child, date of birth, the chronological age, and bone length in centimeters. It can be used to determine the timing of physiodesis, to predict the LLD at skeletal maturity, to predict growth remaining and height at skeletal maturity. The mobile app is freely available for both Android and iOS systems. It is applicable to Shapiro type 1 proportionate progression pattern. It can be used in congenital anomalies as well as developmental causes such as physial growth arrest or Olier's disease. How it works? So for every age in boys and girls, there is a number called multiplier, as published in paper by Dr. Paley, and that multiplier number tells us how much the bone length is going to be at skeletal maturity. It has been validated and the app has also been found to be useful. We are going to discuss few features of the app. The main menu will give you all these options. Let's go to an example. A child with fibular hemimelia. Currently, the right leg is short, toes are missing, and we want to know what treatment can be offered for this child. So, to determine this, we'll go to the LLD congenital, we'll go to the tibia, we'll put in other details, date of birth, previous lengthening 0, and we'll calculate. So, by doing this, for this girl with age 7 plus 3, the current LLD is 4.5 centimeters. The multiplier for this age 7 plus 3 is 1.405. So using this, the expected LLD at skeletal maturity is 6.4 centimeters. Also, we want to know the height at skeletal maturity. So based on this, you can determine the number of lengthenings, or whether you want to offer one lengthening with correcting the rest of the LLD with contralateral physiodesis. Another example, a boy 3 plus 4 with right congenital short femur. Current LLD is 3.2 centimeters. The multiplier for this age for boys is 2.153. So considering that, the predicted LLD at skeletal maturity is 6.9. So that will help us to determine the decision. The developmental LLD will require 2 sets of X-rays, and it is based on assumptions that the inhibition of growth of the short leg compared with the long leg remains fixed. So for this, the current LLD and the LLD which was present few months back, at least 6 or 12 months ago, should be known. Then that information is put in the app, and that will give us the necessary information. It takes into consideration that the distal femoral physis contributes 71% of the total growth of femur, and the proximal tibial physis contributes 57% of the total growth of tibia. By using this information, you can determine the timing of epiphysiodesis. One need to give in information how much is the desired amount of shortening, and whether you want to achieve it in proximal tibia, distal femur, or both. This complex formula, which is shown over here, the app takes into consideration of that. Here is an example: a 14-year-old boy who had distal femur physial arrest leading to valgus recurvatum deformity. And it was important to know when to do the surgery and when to do the contralateral physiodesis to achieve equal leg lengths. That's how it was done, and at 1 year follow-up, he remains, his leg lengths are equal. So timing of epiphysiodesis was determined using the multiplier app in this child. Another example, 8-year-old girl with sequelae of right knee septic arthritis with varus and shortening. The current shortening is 4 centimeters, and expected limb length discrepancy at skeletal maturity is 7.3 centimeters. So in first instance, she underwent deformity correction and lengthening of Y, and at later stage she will undergo second lengthening. Another example, a girl with hemihypertrophy with lengthening of the left leg. Based on multiplier method, her current LLD is 2.7. It is expected to grow to 3.4 centimeters. Her current height is 122 centimeters, and predicted height at skeletal maturity is 154 centimeters. So here we have two options. One can offer her contralateral physiodesis, or one may consider shortening of the long leg, depending on the discussion between the patient and family. So to take home, multiplier app is an easy to use in OPD. However, one should use multiple methods such as the arithmetic method to assess skeletal maturity at multiple occasions. Thank you.
Thank you, Ashish.
May I call upon the next speaker, Dr. Wilfred Disa, to tell us about the clinical assessment of limb discrepancy.
Hello, good afternoon. I'm giving this talk on on behalf of Dr. Wilfred D'Souza, who could not make it. Basically, we are going to talk about what you already know: clinical assessment of lower limb discrepancy. Any unusual gait, suspected lower limb length discrepancy. It can be either due to a true limb length discrepancy or an apparent limb length discrepancy due to a pelvic obliquity, either due to a scoliosis, or there may be a compensatory scoliosis or a compensatory shoulder tilt. Assess the patient carefully. 3 common steps to assess clinically the limb length discrepancy. One is Gillespie test, the block test, and the measuring tape. The Gillespie test, I don't need to explain how it is done. View from the front, view from the side, view from above, and see which segment is shorter. Or you can keep the patient prone and have a look to confirm your findings. Coleman block test gives you a reasonable idea about how much is the limb length discrepancy, keeping the pelvis square. View from front and view from behind. Measuring tape for apparent limb length discrepancy and true method. And the radiological evaluation. If you have a digital radiograph with a scale attached, that is the best. Otherwise, you'll have to put a magnifier and with stacked radiographs. I think that's all. Ashish, you'll be talking about radiological assessment of limb length discrepancy.
Hello, good afternoon. We are going to discuss the assessment of limb length discrepancy using radiographic methods. We want to do this assessment so as to know exactly the amount and location of the discrepancy, to formulate a treatment plan, and to choose the correct bone segment to address the discrepancy, and also to decide on shoe lift or prosthetic prescriptions. So the difference in leg length discrepancy could be in the pelvis, femur, tibia, below the malleoli in the foot, and it could always be one leg being long, hyperplasia or hypoplasia. So clinical methods such as use of tape measure or blocks are useful. They are good as screening tools. As you can see that here the radiograph helps us to determine where the discrepancy is. So various imaging modalities or imaging methods have been described, such as orthoröntgenogram, standing teleröntgenogram, scanogram, CT scan, USG, and MRI. Which method to use? Well, if you are using clinical methods, the block method is very good, and if you are using radiological methods, then the standing EP full length radiograph is the method to choose. We'll look through some of the methods that have been described. Scanogram. Actually, scanogram is a supine film where 3 images with a ruler are taken. So the beam is parallel to the joint and 3 shoots are taken: hip, knee, and ankle. And it is done in supine position. The patient needs to remain still. So here you can see an example of a scanogram. It is not possible to assess the associated limb length discrepancy or the changes that are happening because of standing position. Orthoröntgenogram, 3 exposures of the extremity on a long cassette. The standard is standing AP full leg X-ray. Teleröntgenogram, where the lengths are measured digitally, where one can exactly assess the contribution from each segment. One can assess the associated angular deformity, and this is the weight bearing radiograph. It has been shown that the intra and inter-observer reliability is excellent with this method. Certain prerequisites that knee should be in full extension, equally distributed body weight, There should be block under short leg to level the pelvis and keep the knee in extension. Sometimes it is not possible to obtain radiograph in single cassette, like this child with severe deformity. In this case, 2 radiographs are necessary, one extremity in each radiograph. There is a standardized technique for this. The cassette size is determined, it's pre-decided. The beam should be centered on the knee. The beam source should be at least 10 feet away. And as you can see in these radiographs, first the child is made to stand, then the knees are facing forward, the patellae are facing forward, which look like this, and then the radiograph is made. The assessment of leg length discrepancy starts with a line joining inferior aspect of each SI joint. Then 2 points are drawn which are placed directly over center of the femoral head. Then a horizontal line is drawn joining the 2 points on the SI joint, and the distance between the horizontal line of the acetabulum and the horizontal line on the SI joint will give us the total leg length discrepancy. As you can see in this child with congenital short femur, that's the line over the SI joint, and that's the line from the acetabulum. Another way to know the discrepancy is the distance between 2 distal ends of the tibia, and to this difference the height of the block used underneath the short leg should be added. Then the lengths of individual segments are measured. The pelvic segment, the distance from SI joint to roof of the acetabulum, the femoral segment, the tibial segment, and the foot segment. Here you can see that this radiograph is showing measurement of the femoral segment and the tibial segment. CT scanograms are useful when there is associated knee flexion deformity. Here magnification is not an issue. This is a non-weight bearing, hence one cannot measure contribution from the foot. Well, it needs availability, technical expertise, and also cost could be a problem. In this excellent review, various methods have been compared in terms of their reliability, accuracy, magnification. The leg length discrepancy could be combination of both, could be the adduction deformity with shortening. So here, as you can see in this example, the adduction deformity with supratrochanteric shortening was leading to scoliosis, which got corrected. Here is an example, 8-year-old girl, blocks are used to square her pelvis, and then radiograph was made, and then the contribution from each segment was measured. Another example, a girl with Klippel Trenone syndrome, vascular malformations on the left side. The right side was short and there was hyperplasia of her left side. That's how a radiograph looks. So in summary, correct technique is important to obtain the correct radiographs. Always consider the amount of magnification. Use correct anatomical points to measure the lengths. And of course, do not throw away the clinical methods. They are certainly supplementary to the radiographic methods. Thank you.
Thank you very much, Ashish, for the wonderful talk. Now let me introduce, welcome Mr. Durai Nayagam, who is a consultant pediatric orthopedic surgeon at Liverpool. He has kindly consented to give us a talk on treatment methods, indications, and options. Over to you, Durai.
Hello, this is Durai Nayagam. I'm a retired orthopedic consultant who used to practice in Liverpool. I'm going to cover the treatment options in limb lengthening. Surgeons often choose a treatment method because it is their favorite because they're familiar with the technique or they have increased expertise. Sometimes it's because of brand or device loyalty. But the choicest method is one that is optimal for the presenting problem. And to make that optimal choice, you need to have a clear understanding of the functional and psychological impact of the structural anomalies on the patient. it is key to appreciate and acknowledge the variations in the underlying responses to lengthening depending on the etiology of the problem. And as this is pediatric orthopedics, always think ahead. You are going for the long run and not the short term. 3 important pointers I would like to share with you are that equalization, complete equalization that is, or a reduction of the difference in length are both valid objectives of surgery. Beware of increasing the original length of the segment by over 20%, as this can increase the risk of complications. And always think firstly of the soft tissues. Bone complications are usually easier to rectify. There are several key influences on treatment choices in limb lengthening. The etiology will determine how the soft tissues respond to surgical lengthening. Post-traumatic, post-infective causes of limb length discrepancy respond generally more favorably to lengthening than congenital causes. Look at the state of the joints. Are these normal, stable joints, or are there present some anomalies that are congenital that render the joint unstable when subject to the forces applied during surgical lengthening? Is the condition for which you are performing the surgical lengthening carry a greater likelihood of refracture or deformity? This needs to be considered. And finally, affordability. Is the treatment choice one that is affordable to the patient? If it isn't, are there alternatives you can offer? Let us look at the differences between the options. Fixator-based treatments are the most common. They achieve multi-level and multi-segment corrections without too much difficulty, for instance treating the tibia and femur simultaneously. You are able to control joints by spanning them, and any axial deviations that occur during lengthening can be addressed without return to theatre. However, they carry the disadvantage of a refracture risk, as once the device is removed, the limb is no longer protected. Intramedullary lengthening devices present a different mix of advantages and disadvantages. Multi-level and multi-segment treatments are possible but much more difficult. Joint control has to be through bracing, and this is largely dependent on patient compliance. Axial deviations during lengthening can be accommodated for by anticipation and use of poly screws. And refracture risk is unlikely, as the device is usually maintained within well after consolidation. And finally, you have the option of combining internal with external fixation. Here, the refracture risk is addressed, the patient experience is improved, and the functional recovery enhanced as the fixator is removed early. However, there is a deep infection risk. So how do we choose wisely? Well, create a problem list, one that addresses the current problems and one that addresses predicted problems. What do you need to address at this time, and what do you need to address in the future? Can some aspects of the problem be treated differently for equivalent outcomes? Do not exclude growth modulation for deformity correction or even growth modulation of the length of the contralateral limb. Be aware if you are treating a congenital longitudinal deficiency of the femur, possibly one of the most challenging surgical lengthenings. You would have to consider including soft tissue releases, reducing your target length to 15% of the original, controlling joints, and anticipating refracture. And finally, ask yourself, are the patient and family fixator negative? You do not wish to embark on a 6-month journey of regret to discover that the choice of fixator-based treatment for this was inappropriate. Intramedullary lengthening devices are becoming more popular in affluent societies. They provide a markedly improved patient experience, and axial deviations can be prevented by judicious use of poly screws. However, the circumferential regenerate quality in some cases can be inhomogeneous, and this may be to do with the device or osteotomy, and the soft tissue behavior during lengthening and the problems thereafter are the same as with external fixator-based treatment. In summary, complete equalization or simply a reduction of the difference in length are both valid objectives of surgery. You need to employ the treatment method which can achieve the objectives from your current problem list and accommodate the anticipated problems associated with the etiology of the condition. All this without interfering with the anticipated future plans you have for the patient. Thank you for your attention.
Thank you, Durai. Now we'll have Ashish, shall we have a short question answer session now?
Okay.
Ashish, please unmute yourself.
Yeah, any questions are welcome.
Yeah.
So if there are no questions, we move on to the next
Ashish,
session.
can
Yeah.
I make a little comment?
Yes, please.
Yeah. Only thing which I wish to add here is that this X-ray based limb length measuring is actually more useful when you are doing a lengthening, especially using the external fixator, where you want to stop the lengthening at an appropriate time or want to see whether the limb length is equalized or not. That's the only thing which I wish to add apart from the preoperative evaluation, because tape measure sometimes with a circular fixator is not possible.
Would you repeat that again, Parmanand?
Yeah.
Your last sentence.
Tape measure with a circular external fixator may not be appropriate with the fixator on.
Yeah, you mean the clinical assessment?
Yeah, clinical assessment.
Yeah, I agree. 100% agree.
Yes.
Can I ask one question?
Sure.
Yeah. So what is the youngest age would you like to start the limb lengthening?
No, I usually start at around 5, older than 5 years only, because I prefer not to start earlier, because the child needs to understand what he's going through. So generally around 5 years is my age when I start limb lengthening.
Yeah. And if the child is having more than 5 centimeters between 3 to 5 years of age, how would you like to treat him, or what advice you want to give it to the parents?
I would advise to wait.
Yeah. Do you give any support, anything?
No, most of the children don't need that. That's what we noted. They're quite happy without that.
Cherian, can I add something here?
Yeah.
If the limb is too short, especially in the congenital ones,
Yeah.
I would wish to give a sort of orthosis.
Yeah.
I mean, compensating the limb so as to help the child with ambulation.
Yeah, what I've noted is that,
I mean, some of the limbs are really, really short.
Yeah.
So once the child starts walking and has difficulty in walking.
Yeah, only if they have a difficulty in walking, I do give. Otherwise,
Yeah,
I don't.
only then if they find it too difficult to walk.
Terry, can I ask a question?
Sure.
Since all of the people who are experts in limb lengthening, I want to ask them really how many times do you really use that multiplier method, and how reliably predictive has it been in your practice? I see Mangal here must be doing quite a lot of lengthening, and somehow I haven't been able to get the hang of the whole thing.
I use that more to predict and sort of reassure patients as to what the final length is going to be. I have not used it to assure, to let's say if I'm doing a lengthening at age 11, and then the multiplier says this is going to be the predicted discrepancy at maturity. I will not usually use it to over lengthen for the predicted discrepancy at maturity. I would prefer to equalize or a little more and warn the patients that at maturity we will do the final lengthening. That's how I do it. But I
So you leave it open and yeah, because I have found that if you pull out an app which is supposed to be accurate and it doesn't match up to the educated parents' expectation, what are the medical legal implications? Because biology may not follow mathematics.
True. I agree with that. So I will go with final equalization at maturity based on what is there. But from what the papers show, what work Dor has shown, it seems to be pretty accurate. I wouldn't place my bets on it though, in terms of.
Yeah, but that's why I ask you, how many of the Indian people are actually relying on it heavily and giving prediction? Milind?
Milind, unmute yourself.
Yeah, so thank you for having me with you guys. Yes, you're right. It's a very interesting question. So it gives us a guideline because it's based on the White and Anderson's charts made in 1948 in white Anglo-Saxon Protestant children in a certain area of Boston. So how well is going to apply to our race, caste, ethnicity is a big question. So it's a starting point, and it's not the be all and end all. It has a stated inaccuracy of 10%. So, and then we find that there is much of a slip between the cup and the lip. Just like I think Mandar Acharya was showing that there is a 40% has a discrepancy of up to 1 centimeter by epiphysiodesis, and 11% have up to more than 2 centimeters. So that's a starting point. So, we take that as a starting point. We take the ballpark figure of whatever the discrepancy is present in the girl child at 3 years is going to double to convince the parents and for us to understand how early to start the lengthening. So our paper in, JPO recently on congenital posteromedial bowing, we found that, when we are seeing a child coming to us at the age of 1.5 years, at a discrepancy of 2.7 centimeters, he's going to definitely develop a shortening of more than 9 or 10 centimeters. So we start the lengthening early. There's no fixed routine. So we go by the discrepancy that the child has, and we can start lengthening even earlier. And that, and we don't promise.
For the younger crowd, important to put a disclaimer at the end of the multiplier also.
Yeah.
Yes, very
Milind,
true.
one thing I want to ask you is, does the limb length discrepancy increase that much in posteromedial bowing?
Yes, Cherry, this is a very interesting question. Thank you for bringing it up. So recently, Gordon published a paper from the Washington University, St. Louis, in which he followed up 16 children to maturity with CPMBT. And he found the highest LLD was 14 centimeters. In our series conducted over the last 30 years at our hospital, we performed 28 lengthenings. We followed up 33 children. We found that the maximum discrepancy was 9.7 centimeters. So, Cherry, the notion that we have, that we cherish, that it's only 4 to 7 centimeters is a little bit outdated and it needs updating.
Okay,
so, a recent article by, from Washington University in Journal of Children's Orthopaedics in the year 2020, he has shown the range up to 14 centimeters shortening. So we have to be aware of this.
Yeah, that's interesting to know.
Milind, can I ask you something? Yeah.
Yes, sure.
Milind, I'm Dr. Yeah.
Yes.
So only thing which I want to ask you is that is 14 centimeters or 9.7 in your case, is it an outlier or is it a mean? What was the mean in your cases?
The mean discrepancy in our series was 7.2 centimeters, which is way above the 4 to 7 centimeters that you think, or that we are led to believe by the literature or the old literature. And in Warner's series also, they have said that they have a, it's a range. I told you the range. So very obviously, when I'm talking about 14, it is obviously the outlier, isn't it?
Yeah.
But so the lesson that we have to learn from this is we have to open our minds to the fact that a condition like CPMBT is not necessarily restricted to only 7 centimeters. That's the only message I want to give you. Do not be so sure that it's going to stop at 7. There are going to be some cases who will have much more discrepancy. That's the only inference that we can draw.
Okay, now, any more questions?
Cherry, can I ask you one question? I'm Dr. Vinod.
Yeah, yes, Vinod.
Does a significant limb length discrepancy affect the spine in the sagittal plane, whether it causes like exaggerated kyphosis or lumbar lordosis? Have you had any experience like that?
No, I don't have any experience about patients coming with kyphosis or increased lordosis due to LLD.
Because I have a couple of posteromedial bowing children. They have exaggerated lumbar lordosis. So I'm not sure whether it is related to the limb length discrepancy or it is just a different problem altogether.
Anybody wants to comment on that? Because I have no experience with that.
Yeah, so I would, if you take a full length X-ray, which includes not only the lower limbs, but if you go ahead and stack up all your cassettes on a wall mounted system and take an X-ray up to the shoulder, you'll see the dramatic amount of scoliosis, which is trying to compensate. And because ordinarily we are not used to looking at spine in the sagittal view, we would be forgiven for not looking at a lordosis. So the spine is not likely to, bend only in the coronal plane. Life exists in 3 dimensions. So the leg length discrepancy does have a dramatic impact on the balance of the spine. And the recent review paper by Obst in the JBJS in the year 2019 said that now they're revising their recommendation for lengthening at 2 centimeters, not at 5 centimeters. In as low as 2 centimeters, they're recommending lengthening. And these are limb lengthening reconstruction surgeons. And now they have found that we are doing our patients a disservice by saying that you don't need to equalize or you don't need to lengthen even if you are, say, 4 centimeters short. So the bar has been lowered to 2 centimeters now from that review article by Obst. And because of the discrepancies, it is about backache.
Brilliant. Does the height of the person make a difference? Does the height of a person make a difference in decision making as to what is the discrepancy? Like, for example, in a child who is around 4 feet and a person who is around 7 feet or 6.5 feet, will 3 centimeters of difference will cause different set of issues in both?
Yeah, PN, it's a really interesting question. So this is what happened in places like Norway and Finland and in Scandinavia, where they were very fond of performing shortening of the other limb. And limb shortening is a popular and well accepted method because overall height of the children, adolescents, can be very high. In India, the issue typically is, okay, but you are from Punjab, so you guys, you see a lot of tall folks. We guys in the Deccan are not gifted with such, tall and lanky people. So our patients are reluctant to undergo shortening of the opposite side. They squirm at the listening to this concept of shortening the opposite side or slowing down the growth of the opposite limb. But you guys are all what, 7 feet tall in Punjab or what? 6 foot?
No, it's not 7. It's around 5'10", 5'11".
Okay, now since there are no more questions, shall we move on to the next session? Now I would invite Professor Gamal Hosni to talk on limb lengthening external fixation with circular fixators.
I would like to thank the Indian Pediatric Orthopaedic Society for inviting me. It's a privilege for me. I'm going to speak about this circular fixator in limb lengthening. We all talk about the evidence-based medicine. Unfortunately, when we talk about limb lengthening, sometimes it's non-evidence-based medicine. And an example, people, they always talk about replacing the circular fixator by internal lengthening devices. But look here, so they call circular fixator a bad name. And this is true. But look to the truth. For the lengthening nails, we have serious nail complications. So we just have a few months ago, precise tries nail recall. And before that, we have ISKD nail recall. We never had circular fixator recall, but they call circular fixator, a bad name. Can you imagine? And this meta-analysis was published by my group just 3 months ago about the complications, and the incidence of major complications was the same between different devices. What's limb lengthening? When we talk about limb lengthening, are we talking about cosmetic lengthening? Cosmetic lengthening is about 6% of only. The circular fixator. The patient can walk immediately with the circular fixator. Again, when we talk about lengthening, are we talking the same language? I'm talking about this patient with 12 centimeter shortening, 90 degrees angulation, and 180 degrees rotational deformity. And that patient with 22 centimeter shortening and humeral lengthening with 40 degrees angulation, 12 centimeter shortening. And this deformity with proximal femoral focal deficiency. This is real lengthening. Our experience with Elizabeth fixator started in 1983, 39 years ago. And we published this last year about our experience with circular fixator and different types of fixators. The frame evolution. We have frame evolution. We have now more levels of fixation, different sizes of rings, more pins and wires, early removal of affected wires. And this is an example in a Charcot joint and lengthening. You see the levels of fixations, many levels of fixation. Hydroxyapatite half pins, wires. The tibial wire usually ended at the end of the fibula. We put the wire, transfixing wire, but to guard against the development of common peroneal nerve, we just end up flesh of the head of the fibula. The versatility of the frame. Usually when we teach the people, we put the frame vertical to the bone. And then you end up with the frame parallel to each other. So you have lengthening and the correction of the deformity. What about the opposite? You can end up, you see, the frame is not vertical to the bone, but look to the bone, the frame is displaced, but the bone is okay. This is the versatility of the frame. Weight bearing is allowed the first day after the operation. You see here, walking patient, swimming, walking patient, writing, doing everything with the frames, if it is stable enough. The magnitude of the lengthening. Do we have a limit, 8 centimeter or 6 centimeter? And we consider reaching 8 centimeters an advantage. Look at this patient with replantation and 22 centimeter shortening and deformity. 5 centimeter lengthening, 10 centimeter, 15 centimeter, 22 centimeter lengthening. Shortening for 15 centimeter with this and deformity of the humerus. Look, 100% lengthening, 100% lengthening with circular fixator. And cosmetic lengthening too. You see the distance, 10 centimeter. Chondrodasis, you can do chondrodasis also on this patient. And you have 15 centimeter lengthening from chondrodastasis with the severe deformity of proximal femoral focal deficiency. Complex deformity, 180 degrees rotational deformity, 12 centimeter shortening, 90 degrees angulation. You can do gradual lengthening and gradual derotation of the foot and the correction of the deformity. And this is the real aim of bone lengthening, not just cosmetic lengthening. If you have malalignment, because of the strong muscles, you see here the malalignment, you can correct the malalignment with changing the rods of the frame. You see, just putting hinges and distraction. Hospital stay, 1 day, costs very cheap. You can use the frame 10 times. So you cannot compare the costs. So limb lengthening is not just cosmetic lengthening. With the application of Elizabeth method, all deformities, including shortening, can be corrected gradually at the same time. The biologic advances through research to stimulate regeneration and reduce the period of treatment will be the rare revolution in limb lengthening surgery. Thank you.
Thank you, Professor Hosni. The next technique is by Dr. Mangal Pariyar. He's going to teach us lengthening with monolateral external fixator.
This is a 28-year-old patient where we have no obvious history or cause for shortening. He has 3.5 centimeters of shortening, 2.5 in the femur and 1 centimeter in the tibia. We are going to lengthen the femur 3.5 centimeters to compensate for the tibial shortening also. We use a monolateral fixator, the alpha fixator, which is manufactured by Pitker. The pins are inserted in an anterolateral orientation. The first pin is at the level of the lesser trochanter. In the AP view, it is perpendicular to the shaft of the femur. It is important to create this soft tissue tunnel as shown to avoid soft tissue entrapment by the drill as well as the pin. It's checked on C-arm to confirm that this is in the center of the bone, and then the drilling is done in a start-stop fashion to minimize any thermal injury. The Shan's pin is a tapered design and has a diameter of 6 mm at the base of the thread and 5 mm at the tip. It's important not to over-insert this pin because it cannot be backed off due to the tapered design. After this first screw, the last screw in the configuration is inserted. Both these pins need to be parallel to each other and in the same plane. Therefore, we use the fixator itself as a template. The two clamps usually have about 2 finger breadths in between them to ensure adequate space to do the osteotomy. The principle of soft tissue tunnel creation is used for every pin. We use a triple sleeve drill guide to ensure that the drill bit is well centered in the clamp hole. The drilling for the distalmost pin is done in the same way and an appropriate Shan screw is inserted. Now we have one Shan screw most proximal and one Shan screw most distal. The fixator is put onto these pins and we will use the 4 empty holes to guide our further drilling. The triple trocar marks the surface and then the fixator is taken off. Appropriate incisions are made and the soft tissue tunnel created as discussed earlier. This is really important, especially in the femur. Otherwise, soft tissues can get entrapped while you are drilling or putting the screw in. The fixator is now put on, and through each empty hole, the process of drilling and putting in a Shan screw is done. The incision for the osteotomy is midway between the two sets of pins, slightly above the plane of the pins. A curved on curved periosteal elevator is used to raise the periosteum anteriorly up to the medial aspect and posteriorly up to the linea aspera. We then use a 4.5 millimeter drill bit to make 3 holes in different directions to weaken the bone and make the osteotomy easier. Also, this reduces the chance of shattering. A thin osteotome with a light mallet is used to perform the osteotomy. The last part of the osteotomy can be completed by putting in an osteotome with a hexagonal handle and turning it 90 degrees in both directions. So if there is any cortex remaining, it breaks with this maneuver. The completeness of the osteotomy is confirmed. The clamps should slide without difficulty onto the pins that were inserted. Keep enough space to allow daily pinside care. If the osteotomy is slightly displaced, you can push the distal pins inward or the proximal pin set inwards to correct this translation. And then the rail is slid onto the clamps. The appropriate screws are tightened to clamp firmly onto all the pins and the proximal clamp onto the rail. The distal clamp is left loose to allow it to slide. This distractor can be moved or turned by the Allen key in femoral lengthening. It's useful to do a release of the iliotibial band and the lateral intermuscular septum as they get tight with lengthening and restrict movement at the knee. Patients are much happier with doing range of motion exercises and there is less restriction by the time the fixator is removed. This is a patient with a similar treatment operated earlier. With lengthening, her lengths are equalized and now has a normal gait and function. Thank you.
Thank you very much, Dr. Pariyar. That was excellent practical presentation. We move on to the next presentation, next technique by Dr. Ishani Shah from UK. And we are going to learn about limb lengthening by a TSF fixator.
Good afternoon, everyone. TSF is a second generation circular fixator that allows 6-axis correction. We will walk through the lengthening of this 14-year-old who has a 3 centimeter short left tibia with a TSF. TSF is a software-based fixator. These terminologies are used to communicate with the computer. To correct any deformity, one fragment remains stationary and the other moves. The non-moving fragment is the reference fragment. The reference ring is always on the reference fragment. In our case, this is same as the proximal ring. This is an example of distal referencing where you consider the distal fragment to be stationary. The 7-hole tab on the proximal ring is called the master tab. This is irrespective of the reference ring. The master tab is always anterior. It is through the master tab that the program understands the strut positions. All rings in TSF have 6 tabs for strut connections. 1 tab on each ring has 7 holes. The connection points on these tabs are marked with white circles. When a 2-ring frame is constructed, 3 alternate tabs are occupied on each ring. Alignment marker such as a long threaded rod helps position the proximal ring orthogonally. In the AP view, the rod should be in the midline, and in the lateral view, parallel to the anterior cortex. A stable ring construct should have pins spread out along the bone on either side of the rings and with a good spread angle. There are two types of struts which work in the same way in terms of distractions. They come in different sizes. One full revolution of the knob lengthens or shortens the strut by 1 millimeter. The fast fixed strut has a locking and unlocking mechanism. When unlocked, acute corrections can be done and draw up. They should always be kept locked in a patient. Rolling down the nut stops acute collapse of the strut if accidentally unlocked. Another safety precaution is the ID clip. The struts can be applied with the ruler facing the foot end or the head end. Start with applying 2 struts on either side of the master tab. Each strut is attached with a shoulder bolt, which has a smooth shank and threads that hold the strut. The smooth shank allows the strut to rotate even after it is tightened to get a 6-axis correction. The torque wrench is used to avoid over-tightening of the struts. The struts are always numbered as if the patient is looking down at his toes and go anti-clock from the patient point of view. A trick is to always use your left hand, form a V over the master tab and point to your toes. The index finger is strut 1, the middle finger is strut 2, and so on further along in the same direction. Lock the struts and note the numbers before performing the osteotomy. This will save you time and struggle to get the pre-op alignment after the osteotomy. Post-op radiographs need to be orthogonal to the reference ring. These are needed to do the measurements for the software. The reference ring should appear as a line in these X-rays. A technique to get good orthogonal views is to use the shadow cast by the light of the X-ray machine. When the shadow is a line, the X-ray will have the ring orthogonal. Next, you need to tell the program what the deformity is, what are the parameters of the frame, and the relation of the frame to the bone. The software then analyzes the deformity in the oblique plane for you and plans the correction. The software terminology includes 3 concepts. The blue dot here is the origin. You can pick this to be any point on the reference fragment. The green dot is the corresponding point, and this is on the moving fragment. This is the point that aligns with the origin when the bone is reduced. The software creates a path to correct the bone alignment using 6-axis correction. There are 2 modes of operating the software. Total residual mode starts with a crooked frame and ends with a crooked frame. The chronic mode starts with a crooked frame and ends with a straight frame. There are 6 steps in the software as seen in the panel on the top. The first step is to select the bone, the osteotomy level, and the operating mode. Next is telling the software which is your reference fragment. We will use proximal referencing. The deformity parameters are measured radiologically in 2 axes in each view. We have no deformity in the AP and lateral view. Axial deformity is reviewed clinically and we have no torsion. We have a shortening of 30 millimeters. With this information, the software analyzes the oblique plane deformity. The image panel has options of bone and dowel view. Dowel is 2 sticks simulating your deformity. Blue is the reference fragment and green is the corresponding fragment. Next, insert the ring and strut sizes. The frame and mount settings help the software understand where the bone is with respect to the frame. Mount settings are to tell the software where the center of the reference ring is with respect to the origin. In AP view, we have no offset. In the lateral view, the center of the ring is posterior to the origin by 2 centimeters. And in the axial view, the center of the ring is 2 centimeters proximal to the origin. On inserting the strut readings, images of the frame before and after correction are generated. The structure at risk here with regards to the deformity is the peroneal nerve, and with respect to the origin, it is 20 millimeters lateral, 20 millimeters posterior, and 30 millimeters proximal to the origin. We will lengthen at the rate of 1 millimeter per day. You can see that in all steps, we have a help section on the right to assist with the terminology. The software now makes a plan to correct the deformity and generates a prescription. The prescription start date can be changed. There are no strut changes in this prescription. The software generates an image simulating the bone and the frame at every stage to help avoid errors. The result at 30 days at the end of the program. If things do not go as planned and you have a deformity halfway through the lengthening, TSF bails you out and allows correction with the program, with the same construct. Hypothetically, if on the 17th day, patient now has 10 degrees valgus and 10 mm lateral translation, the software can be told to replan the path of correction to align the bone segments. Open the case and go to prescription. Scroll down to day 17. Click on TR to create a new total residual case. Fill in the deformity parameters. The frame and mount settings stay the same. The strut settings are auto-filled by the software. A new prescription is now generated. This contains 2 strut changes, which can be done on any of the highlighted days. The medium strut now needs to be changed to a long strut. To change a strut, a 7th strut needs to be attached parallel to the strut needing change to maintain stability of the frame. Once attached, lock and lengthen this strut until resistance before removing the concerned strut. TSF is a very stable construct. However, unlocking even one strut can make the frame completely unstable. Following completion of distraction, tape off the strut up to the threaded rod to avoid inadvertent deformities.
Thank you very much, Ishani. Now we'll go on to the next one, that is plate-assisted lengthening video by Dr. Ruta Kulkarni.
Hello everyone. Today I'm going to talk about plate-assisted lengthening or lengthening over plate. Well, Elisora fixata is a very good tool for limb lengthening, even long limb lengthenings. But there are certain disadvantages like long fixator duration, pain, pin site infection and scarring, which is quite common, soft tissue contracture and reduced range of movement, especially if strict physiotherapy protocols are not followed. And all these things lead to low patient compliance. So all the efforts were put in to improve limb lengthening and make it more acceptable to the patients. So majority of the efforts were directed to reduce the fixator period. Because the limb lengthening is divided basically into 2 phases, distraction phase and consolidation phase. For 5 centimeters of lengthening, the distraction phase lasts only for about a couple of months, but the consolidation phase lasts for minimum 5 to 6 months. So the efforts were done to reduce the fixator period only for distraction phase, and the consolidation phase was taken care of by an implant. And because of that, all the problems like pain, pin tract infection, scarring, etc. reduced and led to greater acceptance by the patients and of course faster rehabilitation. So I'm going to talk about plate-assisted lengthening or lengthening over plate. So if you compare LOP with lengthening over nail, LOP is technically easier. Then there is no disastrous complication of intramedullary infection, which is fairly commonly seen with lengthening over nail. LOP is very useful in children because it spares physis, so you can safely use it in children. So the initial plate that I used was an LCD-CP, but then I developed this slotted plate. The length of the slot is equal to the desired lengthening to be done. So it's available in 4 sizes. So the technique goes like this. First, we cut the fibula. Then we put the plate on the tibia and check under C-arm position of the plate and position of the corticotomy. Plate should be distal enough than the knee joint so that you can put one ring above the plate. Corticotomy site is marked. A small 1 centimeter incision just lateral to the shin, a vertical incision is taken. Periosteum elevated at the site of corticotomy. Multiple drill holes are done, and anterior, medial, and lateral cortices are cut with a sharp osteotome or a corticotome. And the posterior cortex is left intact. You only make 2 or 3 drill holes in the posterior cortex. So this is the position of the plate. There is sufficient room for one ring, and the corticotomy is done below the third hole, or if you're using a slotted plate, at the beginning of the slot. Then the plate is slided on the medial surface of tibia subcutaneously extraperiosteally. Quite easy. Once you slide the plate, with 2 or 3 stabs, put screws in the proximal holes of the plate. Then is the time to apply Lisero fixator. As I told you, 1 ring proximal to the plate and 1 ring distal to the plate. The middle ring is empty. Once the fixator is applied and the wires are tensioned, the bars are loosened, and with rotational osteoclasis, we cut the posterior cortex and complete the corticotomy. So the corticotomy is completed. Once the corticotomy is done, we put a screw in the slot. So this screw in the slot is in the distal fragment, and it slides in the slot along with the distal fragment during lengthening. So this is how the frame looks at the end of surgery. We start distraction after 5 to 7 days of latency period. Weight bearing is allowed throughout this lengthening. As soon as the lengthening is over, we take the patient in the OR and we put screws in the distal holes of the plate by 2 or 3 stabs. So we put screws, and we also put a screw from fibula to tibia and then remove the Lisero fixator. So this is immediate post-op X-ray after removal of fixator. So this animation is self-explanatory actually. So we slide the plate and put screws in the proximal fragment. Before we slide the plate, we cut the anterior medial lateral cortex and make drill holes in the posterior cortex at the site of corticotomy. Then apply Lisero fixator, 1 ring proximal and 1 ring distal to the plate. After that, we do rotational osteoclasis and complete the corticotomy. Put a screw in the slot and then distract after latency period. You can see the screw is sliding in the slot during distraction phase. As soon as the lengthening is achieved, we put screws in the distal fragment and remove the fixator. So the distraction is taken care of by the fixator, and plate takes care of the consolidation phase. After removal, we allow guarded weight bearing till we see good region rate. Full weight bearing is allowed only after the 3 cortices are seen. Syndesmotic screw has to be removed after 6 to 8 weeks under local anesthesia, and plate removal should be done preferably after 2 years. So when we use non-slotted plate, we had this problem. There was plate prominence because the plate left the bone and the bone bent into procurvatum. So to avoid that, we developed the slotted plate. So there are 2 advantages. The screw holds the plate close to the bone, so it avoids plate prominence and procurvatum of the bone, and it also gives added stability to the region. A case. This girl has congenital short femur syndrome. She has 12 centimeters of shortening. You can see the shortening. So I applied Lisero fixator and a slotted plate and did plate assisted lengthening in femur. I used a long 7 centimeter slotted plate in her because the shortening was huge. So I lengthened her femur by 7 centimeters and her tibia by 5 centimeters with the same technique of lengthening over plate. You can see the slotted plate here, and good region rate. So excellent region rate in both femur and tibia, and this is after implant removal after 2 years. So I have published this in Indian Journal of Orthopedics as original article. Thank you for your kind attention.
Jerry, unmute yourself.
Yeah, I'm sorry. Yeah. Now we'll go on to the last video of this particular session, that is lengthening over nail video by Milind Chowdhury. Milind, over to you.
Lengthening over nails is a safe, reliable, and most importantly, affordable technique for lengthening with or without deformity correction in children, adolescents, and adults. I have used lengthening over nails since 1994, and I wrote up my first early experiences in the Indian Journal of Orthopaedics in the year 2008. This technique was later expanded to have double-level fixator-assisted nailing to perform deformity correction as well as arthrodesis and other tasks of limb reconstruction, and was written up in the British Journal of Bone and Joint Surgery in the year 2019. Let us begin with this congenital short femur child who had lengthening with the Elizaro fixator. Note how diligently his father performed his exercises, and hence he could retain his range of motion. Notice the flexible IM rod at the end to prevent the deformity and a refracture. He had a tibia lengthening at a second stage, and when he came to us as an adolescent, we chose to perform a lengthening over a nail to reduce fixator duration. He had lengthening using a humerus nail and an LRS fixator which also spanned the knee joint. He got all of his 6 centimeters in a reasonably short time to regain excellent function in his knees. This young child has the mildest form of congenital fibular hemimelia. She had lengthening of the tibia in the initial stage and then a lengthening over a humerus nail and an LRS fixator for 4.5 centimeters without incident at a later date. The task becomes a little more interesting when deformity correction has to be added to the lengthening. This obese adolescent needed 3 centimeters of lengthening and correction of her significant valgus deformity. We chose to perform lengthening over a nail, and you can notice the guide wire and the initial starting instruments which have gone anterior to the half pins as well as the polar screws within the surgery. Acute valgus deformity correction with lateral translation of the distal fragment was performed by a distally inserted nail which was locked distally and kept free proximally. Her fixator came off in less than 6 weeks. She got all of her length and a corrected lower limb with excellent retained function in the knees. Adolescents may not tolerate the fixator for a very long time, especially if they are VIP patients, such as this child. She is a surgeon's daughter and has varus in the femur and the tibia due to a growth arrest and significant shortening. We corrected and lengthened her tibia with the Elizaro, but in the femur, we used the lengthening over a nail, and here the distal fragment is translated medially to comply with Rule 2 of deformity correction, and the LRS gave her a quick and easy lengthening. The femoral fixator came out in 6 weeks, which allowed her early range of motion in the knees and an excellent correction of the deformity and shortening. This adolescent had a malunited femur with a 1-inch shortening and didn't want an external fixator for too long. Here, the lengthening over a nail has corrected him well, the polar screw has corrected helped correct the deformity, and the fixator has come out really soon, hereby giving him perfect length, alignment, and function in the knee joints. With greater deformities and shortening, the story gets even more interesting. This 16-year-old has Ollier's disease with more than 13 centimeter shortening in the femur and tibia. There is 50 degrees of recurvatum and 38 degrees of varus in the lower femur. He had a double-level fixator-assisted nailing with a proximally inserted nail which stuck out of the piriformis fossa. 2 osteotomies were performed, one for the deformity correction and the proximal one for the lengthening. The nail slid inside the femoral canal with the lengthening. His deformity remained well corrected with the locked nail distally. No bone grafting was needed, and the femur consolidated very nicely over the intramedullary nail, which retained the deformity correction as well as the length. And most importantly, the function in the knee joint as well. Lengthening over nails is a little more involved than lengthening with external fixation, and hence complications can and will arise. This young man with polio had a double-level fixator-assisted nailing for a supracondylar osteotomy and femur lengthening. He developed knee stiffness due to a nail that jutted out into the cavity. A quadriceps plasty and arthrolysis completely solved his problem and gave him full satisfaction. The most significant of deformities and shortening needs a special treatment, and here I would like to end with a double-level lengthening performed over a single intramedullary nail. This radiology resident had fibrous dysplasia and 12.5 centimeters of shortening with a varus in the upper femur and valgus in the lower femur as a compensation. This is again a double-level fixator-assisted nailing with a proximally inserted nail. The proximal osteotomy corrects the varus, the distal osteotomy corrects the valgus. It is not locked in the center, hence we allow both the osteotomies to lengthen after the deformity correction using a single nail and the LRS fixator. No bone grafting is necessary to allow this femur to consolidate, and he did really well and got all of his length and his deformities were corrected. He has retained function in the knee joints and now works as a consultant radiologist and is happy with his result. Despite the recent advances of internal lengthening nails, lengthening over nail is a hybrid technique which is affordable, performable by most surgeons, and can give us excellent results in selected cases. I thank POSI for this very kind invitation to participate. Thank you.
Thank you, Milind. Now this session is open for questions. Mangal, can I ask you one question?
Yeah.
See, you put the fixator anterolaterally. Don't you think that is impaling the quadriceps?
Yes, it does. But that's why you create this soft tissue tunnel, number one. So you minimize, meaning in the region of the pin, you've created a sort of area which there is, free to move. And you do a resection of the
IT band.
IT band.
Okay.
With this, all patients get back 90 degrees of movement while they are doing the lengthening. And the actual sort of distraction is happening more proximally. So at the end of about 6 months or so, once the fixator is out, all patients get back practically full length. Keeping it dead lateral is a problem on a monolateral that the femur is bored.
Okay.
So your middle pins may not get good purchase. When you go anterolateral, all your pins get a good purchase. So that's the reasoning for it.
Thanks, Mangal. Any questions?
Yeah, I have a question for Ishani.
Yeah.
Taking those post-op radiographs can be sometimes very difficult. So how do you do that, and what are your thoughts on getting intraoperative images on C-arm to know those frame mounting parameters?
So instead of intra-op, you can do it just post-op. And one of the slides had a technique called as the silhouette technique. So what you can use is the X-ray machine has a light in it. So if you, there was an image which shows that when you turn that light on, if you see the shadow of your frame, and if you see the shadow of your proximal ring as a single line, then image taken in that position will have an orthogonal view of your reference ring.
Can I ask one question?
Yes, please, Rajiv.
Yeah. So depending upon your anterior bow of femur, will the option of lengthening over plate or nail or PSF may change?
Sorry, say again. Depending on.
Yeah. So if, the anterior bow of the femur,
yeah,
will the treatment modality will change?
Not really, because when you do even if there is a bow, when we are doing it with a monolateral, what we are doing is we are putting the bone onto an intact, we are putting the fixator onto an intact bone. So it becomes a little more difficult. Whereas if you want to do, say, lengthening over a nail, etc., what you're doing essentially is a big C, you're converting it into two small C's. And so, and you don't use the kind of fit that that you use in trauma, for example, where you want to have a nail which stuffs the canal fully. So I think Milind can expand on that. It's a slightly thinner size of nail comparative to trauma. Milind?
Milind? Yeah, so if you'd be kind enough to just repeat that.
His question was, do you change your technique? I talked about the bow of the femur.
Yeah, yes,
But
yes.
doesn't that come into play when you're doing a lengthening over nail or lengthening over a plate?
Yeah. So the lengthening over the advantage of external fixation is that it allows the curvature to be maintained if you use hinges. If you're going to use an LRS fixator, it's going to straighten out. All lengthening nails, as we will come to, are straight intermediary nails. If we do a lengthening over a nail, the nail itself is a straight nail. It's not like a curved trauma nail. So there is going to be a loss of the femoral bow, but not that it has any significant consequence for function or in the long term. We've studied this. We've tried to find out the etymological reasons why the femur has a bow, probably to accommodate the larger hamstring muscles and their important function. But it seems as though nobody has suffered because we've lengthened over a nail or an LRS frame or an Elizardo, and there is a little bit of a loss of a bow. So probably one of the lesser things to worry about, as long as we win the immediate battle. Let's do the lengthening without knee stiffness, without creating complications. Most of the battle is won.
Milind, one question. So yes, Sandeep, you have a question? Yes, please.
For you. When you are lengthening over a nail, especially double level osteotomy, with such a long rail, don't your distractors get jammed because you will be using a pretty long distractor, and I found they tend to bend.
Yeah, that's very interesting, Sandeep. Absolutely. So we ordered special 500 millimeter long rails from Pitcut.
How to manage that?
Yeah, and the other thing we did was we stacked 2 rails. We added a second rail to add to the stability. So so when they made the special rail for us, it had a bridge in between to prevent it from springing
Bending.
down. So yeah, bending. So yeah, it happens actually very often. Even in a normal lengthening, not in a very long lengthening, 400 rails, we feel that they fall a little short.
Sandeep?
Second problem I found. Yeah, sorry.
No, in relation to your question about jamming, what you can do is use dummy clamps in the middle, which act as staging posts. So then your distractor doesn't need to distract too long. That's number one. Or you use a clamp on the other side and pull the clamp rather than push it. So initially you push and then later on, so that you keep your distraction sort of CD unit in a reasonable range. If it goes to the extreme, to the end, it will always jam.
Because what happens in younger kids where we deal with lending, all your lendings are older adolescent and nearing maturity, where all the techniques are possible because you have a length of bone available, the span. In smaller 6 and 7 and 8-year-olds, I found that the LRS system, their distractor is either 40 or 80. They don't give 60 millimeters, which would be ideal. So with the 5Cs on either side, you are very restricted in where you place your pins.
Yeah, right. So the longer, if we put in a longer rail, and if it juts out proximally, it creates a problem, because as soon as they flex the hip, it touches the bed and it levers them. So if we keep it longer distally, then we could get away with a CD unit which is not necessarily perfectly sized for the limb as well.
To add to this, there is a dummy clamp which I think they have recently made. So after your initial lengthening, you can use that dummy clamp and your CD unit goes into that. And I found that to be very useful.
What you mean is normally you slide the clamp onto the rail, whereas this dummy clamp can be placed in the middle also, post facto.
Yes, that's very useful.
Deepak Kundana has his hand up.
Never fixed.
question. I want to ask.
Yes.
I want to ask one question with from Dr. Millen. Sir,
Yeah.
after how many days after the completion of distraction, after how many days of completion of distraction, you lock the nail and remove the fixator? One
As soon
question
as
is
possible.
this. And the second
As soon
question
as
is
possible.
when at the time of locking, you first remove the fixator, then lock, or lock it first and then remove the fixator? Because I think locking will be a bit of difficult task with the fixator on, because fixator is also, if we are using a LRS, it will be on the lateral side, and locking will be from the lateral to medial only.
Yeah, it's very true. We need to, of course, remember one thing. You need to lock the nail first before you remove the fixator. If you have a soft regenerate bone, and if you remove the fixator without locking the nail, what's going to happen?
It collapses.
It's going to collapse. And what's the worst case scenario? I do not want to mention it, but there is this paper from Ganel and Horozovsky in the year 1989 from Israel, where they had a patient with 12 centimeters of regenerate bone, and it collapsed for some reason, and the patient died from a massive pulmonary embolism. So for no way you can think about removing the fixator without locking first. It's a bit of a struggle, I agree with you, especially if the proximal holes are kept free and the nail slides in from proximal. The proximal clamp of the LRS fixator is exactly where the screws want to come. It's a bit of a fiddle, but we completely clean the fixator first and we drape it with roller bandages, sterile bandages. So, and we use long drill bits and we try to keep it as aseptic as possible, lock the screw holes, and then only remove the fixator. This is a sine qua non. There is no way you can think about removing the fixator first because it's not convenient to lock it. My God,
Obviously.
Don't even imagine.
Millen, one question. Millen, one question.
Millen, if that's okay.
Yeah, but yes, Durai.
Millen.
Yes, Durai,
Would
hi,
it be
pleasure.
possible if the nail you use does not have such a proximal bend? Because proximal locking is often done through a jig, am I not right?
Yeah, you're right. But in my...
If you rotate the nail very slightly, if it's a narrow nail, then your locking screws are not lateral to medial.
Yeah, you're right. Yes, of course. Yes, it's a very nice tip. A tip as of course. Yes, of course. Surely.
Millen, what is the diameter of the nail you use?
It depends. It's 9, 10, 11, and rarely we get to use 12.
And one more question to you and Ruta. Suppose you have a delayed consolidation of a regenerate after removing the fixator. What do you do?
Nothing. When you frequently are staring at the black hole of Calcutta when you remove the fixator.
Yeah.
And there's nothing going on. I've had to bone graft in only one patient, that too, the very first one I did in 1994. And that too, he had poliomyelitis. Since then, we've crossed 150 lengthening over nails, and touch wood, so far, we haven't had to do that so far. And you very rarely will see anything resembling those healthy streaks or a dense homogeneous bone. And you have to go on a wing and a prayer, but it does consolidate.
Okay.
Yes, same experience with me. Actually, I never ever had any bad regeneration with this technique. I have never done any bone grafting. At the time of removal, actually, as Dr. Millen pointed out, it really looks scary and black on the X-ray, but the regenerate appears, and it appears well. Never had any problem with the regenerate. And one more thing I wanted to suggest, Dr. Chaudhary, Paley has suggested to lock the nails from the medial side, so to avoid contamination. So he always lock
the very proximal end. It's a hairy thought from the very medial side in the
Dr.
proximal.
Millen, I want to ask you a question. Dr. Millen.
I hope you're not throwing a googly at me from Chandi.
No.
Go ahead, please.
My only question is that how much lengthening? Where is the osteotomy? Do you do it proximal as possible, because then you have a lot of length of nail available, or do you do it in the middle? And second question is, how much lengthening is averagely possible with lengthening on nail and plate? Because if you lengthen more, especially with a plate, you may end up in a little unstable situation.
Yeah, so
With a plate,
the advantage
you may
of
end
the
up in a
nail.
little unstable.
Yeah, so the advantage of lengthening over a nail is that you start with a nail which is rather long, and it's not very
You may
common
end
to
up in a little
have.
unstable situation.
Yeah, so where to do the osteotomy is a function of whether there is a deformity present somewhere in the bone, which is especially hidden and becomes obvious only on a very high quality lateral view, and surprisingly at times to our to our dismay on the operation table. It's at a slightly different level. So if you have a bowing and an apex of a deformity,
How difficult it is to identify a Monteja fracture in.
so you have to perform the osteotomy at the apex of a deformity, and because you will not be able to negotiate the nail. So that's the obvious place where and sometimes you have a bowing deformity. You have a double level, deformity for a straight nail. And if you want to use a trauma nail, so I must admit that from the Royal National Orthopaedic Hospital, Pete Calder and Dave Goodyear, and written by Davda as the first author, they described a double level technique for atrophic femoral non-unions in which they used a trauma nail. But the crux of the matter is you have to ream with at least 2.5 to 3 millimeters more than the size of the nail to allow the curved trauma nail to slide within the canal, so with flexible reamers. So if you want to avoid excessive reaming, which can lead to a tremendous amount of blood loss, not a problem in the UK and some places, but it matters to us because we have precipitous falls of hemoglobin levels and delayed recovery. So we use a straight reamer to convert the curved canal into a straight canal. And where the straight reamer jams in the bone is where you perform the osteotomy. And you can notice this, as you start the surgery on the lateral view. So, and you have to plan. That's why we keep the X-ray, the nail against the limb and take X-rays before surgery to determine what's the size, the correct, having the inventory of the right length and diameter of the nail. And in the case where we do the double level nailing, the exact locations of the holes is the real challenge. So we have to, measure them carefully and pre-order the nails well in advance so that we have the right inventory. So I sometimes have an inventory of 150 nails with me, at all times to be able to do this, even though it's not the commonest of surgeries.
Dr. Gupta, your question was regarding how much lengthening you can do with lengthening or plate also?
Yeah,
Did you
plate
ask?
also, because
Yeah.
considering the fact that if you lengthen excessively, one could end up in a little unstable situation and regenerate.
I agree.
How much do you?
Yeah, so the maximum lengthening I do is 6 or 7 centimeter is the maximum limit, upper limit. And anyway, my policy is not to do very long lengthenings and go for multiple shorter lengthenings. So my plate allows me to lengthen only maximum 7 centimeters, that too in femur. In tibia, I restrict to usually 5 to 6 centimeters, not more.
I think same with me, basically, because I was wondering if you could gain more length, because usually you are using 3 screws proximal and 3 distal. Am I right?
That's right. Yeah.
Yeah, because if you
Even then,
go to the length of the plane, which is unspanned, usually if it is more the length of the spanned plate, I think you tend to have a little unstable situation.
you mean slotted plate? Yeah. So you can't go for very longer lengthenings with that plate.
Thank you, Ruta. We'll just
Thank
move.
you. Yeah. So because of time constraints, we move on to the next session. We'll have more questions at end of this session. So in the next session, the first talk is by Dr. Cherry about complications and their management in LLD.
Good afternoon again. I'm going to talk about complications during limb lengthening and their management. When Professor Ilisara was asked about complications during limb lengthening, he said there are no complications. And when Professor Kathani, who is Ilisara's first Western student, started doing cases, he started getting plenty of complications. So what Professor Ilisara meant was there are no complications, only problems. because in Russian, the word complications is not there. Dr. Pillai has classified as problems, obstacles, and complications. These are the definitions for that, but for all practical purposes, we will go as complications. And we are going to talk about common complications, how to prevent them, and how to treat them. Complications can be minor, major, or permanent, and most are preventable. The most common complication is pain. The initial post-op pain gradually resolves. Some patients do have a distraction pain, which is quite dull, sometimes may need treatment. Whenever a patient complains of pain, check the pin tracks and frame instability, and you may need to reduce the rate of distraction. Occasionally, anorexia and depression can occur. The next most common complication is pin tract infection, and it has to be recognized early and aggressively treated. There is no point in discovering a pin tract infection at this stage, as shown in the picture. The causes are bad wire and half pin insertion, bone necrosis while drilling the wires or the half pins, poor pin tract maintenance, and frame instability. Preventing it is correct wire insertion, flush. It should be flush with the ring, and use plain washers if wire is away from the ring. Avoid bone necrosis. Again, teach the patient and relatives pin tract maintenance, and teach how the patient and relatives how to check for the frame stability. These are the various grades of pin tract infection, and grade 3 is the most dangerous because it is bone infection. You will have to remove the pins and replace the pins. The next common complication is muscle and joint contractures, basically knee flexion contractures, equinus, equinovarus deformity, and knee extension contracture. Preventing is the most important thing. Avoid muscle and tendon transfixation. Good physiotherapy, active and passive joint motion, and muscle stretching exercises from day 1 post-op. Proper positioning of joints, orthosis if needed, and extend the frame across the joint as and when needed. Preventing equinus is something that's quite important. Again, with active and passive ankle dorsiflexion and strapping of the ankle to prevent equinus, especially at night, as shown in the picture. You need to use a very simple thing like this. Once it has occurred, you need aggressive physiotherapy and passive stretching to reduce the rate of distraction. Sometimes you can over-lengthen and shorten. You may need to extend the apparatus across the joint and distract the joint, and occasionally tendon lengthening. Sometimes with passive stretching it may come, or you may need to extend the frame across the joint, or need to do a tendo-Achilles lengthening in very severe cases. Knee flexion contracture is again poor patient positioning, limb positioning rather, and a non-cooperative patient. Pin tract infections, distal femoral or proximal tibial wires can cause inadequate physiotherapy. Long femoral and tibial lengthenings can cause knee flexion contracture. Good positioning, active and static quadriceps exercises, and also knee flexion exercises, pin track care, and when long lengthening and non-cooperative patient, extend the frame across the knee during the lengthening phase, and of course this extension has to be with hinges. Knee flexion contracture, once it is developed, static quadriceps exercises, start with that. If it does not resolve, you need to admit the patient and traction with gradually increasing weight, like you do for a fracture femur. And static and active quadriceps exercises, pin track care, and extend the frame across the knee after soft tissue release in very severe cases. Knee extension contractures, especially during femoral lengthenings, the basic causes, impalement of the quadriceps during femoral lengthening and inadequate physiotherapy. Need good physiotherapy, and if the knee range of motion is below 45 degrees, stop your lengthening, get the knee range of motion back, and avoid impairing the quadriceps by lateral or posterolateral pin placement. And once the knee flexion contracture has occurred, good physiotherapy, active, you need to do, you may need to do some ultrasonic massage to break down adhesions. And if it does not resolve, once the lengthening is over, regenerate is consolidated, frame is removed, surgical treatment, that is quadriceps plasty. Axial deviation of the regenerate can occur due to muscle imbalance, excessive scar tissue, instability of the construct. Identify the potential causes and correct any instability. There are various methods of doing the correcting the axial deviation, like olive wire, conical washers, or in resistant cases with hinges. The other common complication is premature consolidation of the corticotomy. Many a time it's an incomplete corticotomy or excessive latency period, which means you have waited too long, or you have turned the nuts in the wrong direction, or children, oleus and achondroplasia, they have formed newborn very fast. They can have premature consolidation. So always make sure the osteotomy is complete. Keep in mind the latency period. Once it has occurred, increase the rate of distraction. Sometimes the patient may complain of a sudden pop. Then stop the distraction and go in reverse to relieve the pain. Occasionally, you may need to take the patient to the theater, do an osteoclasis or a reosteotomy. The other opposite is delayed consolidation, which can occur due to these factors. Whenever there's a delayed consolidation, identify and correct the underlying cause. You may need to compress, wait, and then distract. Resistant cases, bone grafting, or rarely fibula bypass grafting. Incomplete osteotomy, I've already talked about it. Vascular injury, commonly anterior and peroneal vessels are involved during pin insertion, during corticotomy, during fibular osteotomy. Always assess the limb vascularity pre-op, mark out the anterior tibial artery, refer the cross-sectional diagrams. And here I must say, if you're a beginner, get these diagrams, pin it on your X-ray lobby, refer these diagrams before you insert the wire. There is nothing wrong with in doing that. And during wire insertion or frame fitting, avoid tourniquet. And whenever it's a corticotomy, don't break the posterior cortex with the osteotome, complete it with the osteoclasis. And vascular injury, always recognize, inform the vascular surgeon. You may need to do a fasciotomy, angiogram, vascular repair. Sometimes many a time you may need to remove the frame. Other vascular problems, compartment syndrome, limb edema, hypertension, AV fistula, and very rarely left right sympathetic dystrophy. Nerve injury can be either per-op or during the distraction phase. Per-op, during drilling, the wire is drilled through the nerve, and corticotomy also can cause nerve injury. Whenever you recognize preventing the nerve injury is always tap the nerve after exiting the opposite cortex, avoid paralytic agent during anesthesia, refer cross-sectional anatomy, again avoid internal rotation of the distal fragment during osteoclasis. And distraction-related nerve injuries, gradual onset, patient complains of discomfort, hyperesthesia, especially in the first rib space, dorsum. Later on progresses to muscle weakness and paralysis. The moment you see the discomfort of the hyperesthesia, especially the hyperesthesia, stop distraction, wait for recovery, restart at a lower rate. If it's paralysis, compress the distraction, you may need to decompress the nerve. Joint subluxation, especially when there is a pre-existing instability due to congenital shortenings, already present contractures, especially in the hip and knee, can lead to joint subluxation. Prevent it by, especially long femoral lengthenings, extend the frame across the knee, active and passive physiotherapy, maintaining good range of knee motion and hip motion, prophylactic hip coverage in hip dysplasia. Mild physiotherapy traction resolves it, but when it's severe, extend the frame across the joint, and gradual or acute correction. Joint stiffness, many a time due to muscle tightness or impaling the muscle with the half pins. Good physiotherapy, you may need to shorten the region rate. So in summary, recognize the complications early, treat aggressively, teach the patient good frame care, spend time with the patient. Remember whether it's a circular ring fixator, your monolateral fixator, or the internal fixator, internal lengthening device. The post-op period starts with frame applications and ends with frame removal. Thank you.
Thank you, Cherry. We'll move on to the next talks about decision-making in limb discrepancy. May I invite Dr. P.N. Gupta, please?
Good afternoon, friends. I'll be talking about congenital limb discrepancy decision-making for reconstruction. Common causes of congenital discrepancy include congenital femoral and fibular deficiencies. I'll be discussing mainly about femoral, but somewhat about fibular as well. The goal of reconstruction is to equalize the limb length and have a normal function of the joints as well as a good cosmesis. In congenital femoral deficiency, before reconstruction, one must remember that the entire limb is involved, and one must appreciate the hidden problems, which include the acetabular dysplasia, the muscle contractures, the proximal femoral deformities, the distal femoral valgus, short muscles and ligaments of the knee. All these are impediments to lengthening. Soft tissue contracture at the knee is a hip flexion and abduction contracture, which is taken care of by the rectus release and psoas sternotomy. And if you do not do this, it can lead to a posterior dislocation of the hip during lengthening. The flexion abduction contracture at the hip is tackled by the iliotibial band release, and this iliotibial band can be used for ACL and PCL reconstruction of the deficient knee ligaments. Abductor slide is done only if required. For the proximal femoral deformities, if the coxa is there, and the proximal femoral recurvatum and external rotation deformities, they are corrected by a valgus, internal rotation, and extension osteotomy at the subtrochanteric level prior to lengthening. Acetabular dysplasia, if the center edge angle is less than 20 degrees or a upsloping high acetabular index, then additional Degas osteotomy is required. In the knee, the fixed flexion deformity is done by lengthening the hamstrings. The patellar martracking, the instability of the knee, and the distal femoral valgus are additional problems, and they are tackled by correcting the patellar tracking by surgery, proximal and distal realignment of the patella, a figure of 8 plate for distal femoral valgus, and ACL and PCL reconstruction using the iliotibial band. What will happen if you don't do this? It can lead to a subluxation at the knee during lengthening. So it is important that during lengthening, one must cross the knee joint with fixator, with hinges at the knee. Other factors to consider are that lengthening more than 5 centimeters is prone to complications, including regenerate bending due to muscle forces. So one must avoid more than 5 centimeters of lengthening in a single go. And if more than that is done, then one must protect the regenerate with the internal fixation device. Usually 2 to 3 surgical procedures are sufficient. However, in some cases, a third procedure at the skeletal maturity to take care of the residual limb length discrepancy is required. What one must avoid is repeated surgeries, what is called birthday surgery. If there is a severe limb length discrepancy and the contralateral limb is below the level of the mid calf, then poor outcomes of lengthening are there. So alternate reconstructive procedures are warranted. In fibular hemimelia, similarly, one must correct the ankle valgus either at the talocalcaneal level or at the distal tibia, where there is valgus and procurvatum, either at this level or at the talocalcaneal level. What will happen if you don't do it? It can lead to a gross deformity at the ankle region. So to summarize, one has to tackle hidden obstacles before lengthening and reconstruct unstable joint to prevent joint subluxation. Muscle forces, they tend to bend the regenerate, so small lengthenings are preferred. And if large lengthenings are done, then one must protect it with internal fixation. Thank you so much.
Thank you, Paramanand. Now, the congenital lengthenings always lead to complications, and Professor Hosni will be talking about salvage in after congenital problems after congenital lengthening.
Congenital limb length discrepancy. What's different? What's different from lengthening due to other problems? First of all, amputation is not an acceptable way of treatment of congenital limb deficiency. Like, this patient, he has 35 centimeter shortening and refused amputation. He just put a wooden block, but they refused amputation. We have many things to consider if you want to do lengthening in congenital or reconstruction of congenital lower limb deficiency. The etiology, classification and severity of the problem, predicted shortening, age of the patient, joint considerations, associated conditions, quality of bone and soft tissues, previous operations, development of infection, and patient expectations. The etiology can be a syndrome with disformity or tibial hemimelia, proximal femoral deficiency, or fibular hemimelia. Classification. You have to think about classification. In this patient, this is not the femur, this is the tibia. We have congenital absence of the whole femur and long-standing problem. The medial condyle of the tibia, the medial part of the plateau, takes the shape of the femur. So this is complete absence of the femur. The classifications, we have too many classifications. Sometimes they don't help. Like this patient, unclassified problems. Predicted shortening. You see, you have shortening now, but for the child, it's going to be the same. It's going to change with time. So in this patient with fibular hemimelia, you see shortening. We did CT scanogram to measure every 6 months. So we have predicted lengthening. Then we did lengthening. And this is a picture after 18 years of follow-up. You see, it's the same. In spite of, we did lengthening at the age 8. But you see now, we didn't do twice. It's just one lengthening. Age of the patient. You see this patient or 34 years old patient. Joint considerations. You don't have, you see the acetabulum is vertical. You don't have the head like this patient or that patient. You have subluxations. You have to think about the ligaments of the joints. It's located, dislocated knee. Look to the joints. So you have to think of the joint before lengthening. Associated conditions. It's not just shortening of the femur. You have this severe deformity too. The quality of bone and soft tissues. You see here you have severe osteoporosis, very small segment. Look to the soft tissue. Previous operation, this patient had super hip operation and ended up with fixed 70 degrees flexion, 70 degrees knee. So before lengthening, you have to solve the problems. We solved the problems. Previous operations, we have flexion deformity, stiff knee from previous operation, and the inability to wear a prosthesis due to knee deformities. Infection, we had severe infection, chronic osteomyelitis. Again, high expectations of the patient, as amputation is not an acceptable way of treatment. And this is an example. This patient was failure of previous treatments. You have no hip. We did pelvic support osteotomy, 2 osteotomies to solve the problem. So you can design the lengthening according to the situation. You see here. Management of congenital limb length discrepancy is not just lengthening. You have to consider these factors: the etiology, classification, predicted shortening, age of the patient, joint consideration, associated conditions, quality of bone, previous operations, development of infection, and patient expectations. Thank you.
Thank you, Professor Hosni, for the excellent talk. We will move on to the next session. We'll have questions at end of this session. So we'll go on to the session on the lengthening with internal lengthening devices. And I'll invite Dr. Mangal Parihar to give his talk.
I'm going to describe in short the operative technique for using the precise nail. Essentially, this is a regular nail. There are some particular steps in terms of the preoperative planning and the execution, which I will go through. So you may do this on the femur or the tibia. It depends on what is the entry that we use. For the femur, antegrade or retrograde is possible. There are also options for the antegrade, a trochanteric entry or a piriformis entry. We need to look at what's the overall length of bone, the diameter of the bone, and especially the diameter of bone at the isthmus in the femur. What is the limb length discrepancy that needs to be corrected in the femur and or the tibia? And also, what is the size of the soft tissue, because that has an effect on what we can use in terms of the remote controller that the precise nail uses. So usually you can do the preoperative planning by some form of digital planning software. This can be done even on a regular X-ray PACS system, because essentially we have to measure the lengths that are in position. The precise nail does the lengthening on the anatomic axis. One of the worries when you do the anatomic axis lengthening is that if you lengthen along the anatomic axis, you can cause medialization of the knee. But this does not really have an effect for less than 10 centimeters of lengthening. So for practical purposes, lengthening on the anatomic axis is not a problem. When you do the preoperative planning, we need good AP and lateral X-rays of the entire bone, along with some form of a calibration marker to mark the magnification. Personally, I prefer the CT scan because precise is specially imported into India, and only one size of the nail is imported. So you get one nail and one extra nail in case of problems as a backup. So with the CT scan, you can see what is the correct length without worries about magnification, whether there is a deformity, and most importantly, you can judge the diameter of the bone better. So you need to use the appropriate size of the nail, because if you use a very thin nail in a broad diameter of the bone, there is a possibility of the bone shifting and you having deformities. Also, you need to see what is the soft tissue gap. Again, in the CT scan, you can actually measure that much more accurately. So if you have a large soft tissue gap, there is a prescribed amount that the magnets can tolerate, because there is one magnet inside the nail, one magnet outside, and one drives the other. So if you've got very fat thighs or soft tissue, then the effect of the magnet to distract the nail may not be there. So as we have to decide what is going to be the osteotomy level. Normally, we say there should be about 160 millimeters, that is 30 millimeters, 80 and 50, a total of 160 millimeters beyond the osteotomy gap. So accordingly, you have to measure the length of the nail. This does not have to be the entire tibia or the entire femur in this case, unlike trauma, because you get a good hold with the nail and it just serves to distract. So usually what we do is we create vent holes, because the size of the nail is 2 millimeters shorter than smaller than the size of the canal, as you cannot hammer the nail in. It has to be just pushed in gently. So at the level of the osteotomy, we make multiple drill holes. These vent holes also, all the reamings come out through that, and they help with the healing. So you make 3 or 4 drill holes in different directions with a 4.5 drill bit at the intended osteotomy site. You can have various entry levels depending on what it is that exactly you're planning to do. Once you've got the entry into the canal, it's a standard technique where you put in a beaded guide wire and ream. So if your nail diameter is 8.5, you need to ream to 10.5 or 11, 10.7. Most of, not most, all the patients that I have done have been 8.5 nails, because I found that our tibia and femur are pretty thin in that sense. You can use markers into the proximal and distal end, thick K wires or Shan's pins, to mark the rotation, so that at the end of the procedure you are not mal-rotated. Precise nail is pushed in up to the osteotomy. The osteotomy is completed with an osteotome with gentle blows, and as soon as the osteotomy is complete, the nail is advanced in so that you catch into the distal fragment. Distal locking is standard as we do for trauma. When you're using the nail in large diameter areas, such as a retrograde nail in the femur or in the proximal tibia, you should use blocking screws to reduce the diameter of the bone and make that area more stable, less liable to have any deformity. When you're doing a distraction of the tibia, lengthening of the tibia, so you have to put in screws which hold the fibula to the tibia. For the heel, you can put in an extra articular Shan screw as shown like this. This will help to prevent equinus by holding the calcaneum in a particular position. Once the lengthening is over, the screw can be taken out. Soft tissue resection, especially when you are doing longer lengthenings, is very important. A division of the fascia lata, and in case of the tibia, of the gastroc fascia, will help to prevent deformities. Once the surgery is done, you need to locate the precise magnet under the C-arm, and that can be seen as this dark block, and that has to be marked with a K wire in the center. This marker is used for the what's known as the ERC, the remote controller, which drives the magnet inside. On table, we have to do 1 millimeter of distraction to confirm that the nail is working. If you notice over here, the distance between this thin line and the distal portion of the nail versus the same line and this portion of the nail, this has been distracted. On table, you can also see the osteotomy site opened up, but really what we are looking at is to see that this has distracted here. This confirms that the nail is working and you won't have trouble later on. The lengthening rate and rhythm, the biology is exactly the same. It's only the tool which has changed. So in case of the femur, usually we do 0.25 millimeters 4 times a day, or 0.3 3 times a day. In case of the tibia, it's always 0.25 3 times daily, because tibia tends to be poorer in terms of healing compared to the femur. If you're too fast, then you will have problems with regenerate formation. If you're too slow, you can run into premature consolidation. Post-operatively, like all lengthenings, we need to stress on a good therapy to maintain range of motion and muscle strengthening. We call patients, depending on how they're doing, every 1 week to 2 weeks, while they are doing the distraction, to monitor that their range of motion is okay, X-rays are fine. And once they're in the consolidation phase, usually I call for X-rays rather than the patient coming in. Once fully consolidated, the nail needs to be removed, because there is a lot of electronics and other moving parts inside. So unlike ordinary nails, I think what they recommend is around a year after insertion, it should be taken out. The post-op weight bearing in terms of the precise nail depends on what is the patient's weight, the nail diameter. All the diameters that I have used in terms of the precise 2 have been 8.5, and they don't allow weight bearing. So we only begin weight bearing once there is a reasonably visible regenerate in the gap. Otherwise, we risk the chance of a fracture. There is a newer nail called the Stride, which they claim can take full weight, but that's not available to us as yet. And as mentioned before, therapy is an important part of the lengthening, any lengthening, and it is equally important when you're using an internal device. Thank you.
Thank you, Mangal. And Milind will give the talk on case selection for magnetic limb lengthening.
Hello, sir. I have the PPT, I think, not the video.
Okay, Milind, if you have got the PPT, why did you share it?
Okay, so, all right, so give me a moment.
Yeah.
How do I share the screen?
Just go to that share screen.
Okay.
Yeah, and put it on full slide mode and slideshow mode.
Yes.
Yeah, that's great.
Right, so my presentation is on.
If you have already recorded the audio for the presentation, if you just play the presentation, it should run with the audio.
I have the video I can play. Let me play that.
Okay, yeah, please do that.
Okay.
Oh, that's great.
Just a moment.
Yeah.
Is it audible or is it not?
We are not getting audio.
You're not getting the audio.
We can have.
Is it not audible?
We can have
No,
live
it's
audio.
not audible.
I'll share again.
Good afternoon. I would like to give you a brief overview about case selection and a overall bird's eye view of the selection process of motorized intramedullary lengthening nail. For all the years after we learnt limb lengthening with the Elizarov method, we have been in search for the holy grail to perform an easy lengthening with an implantable device. Now let us see whether we have indeed found the holy grail and whether things are indeed as rosy as they seem to be. Currently, the most popular internal lengthening nail is the Precise. It uses a set of magnets which drive a gear train inside the nail, which is controlled by an external remote controller. Previously, the Fitbone was popular and it had an electronic stepper motor with an implantable receiver for which infrared signals were given with a special device from outside the skin. The important instruments that we need are, of course, the internal lengthening nail of the perfect length and diameter, The most important shift in our thinking we have to make is from that of flexible reamers to rigid reamers. Then the need for polar screws, a especially wide diameter of the C-arm to be able to, work in the lateral position, and perhaps entry point jigs for accuracy in the femur and tibia. High quality full length X-rays and full segment X-rays in AP and lateral planes are a must to find out hidden deformities, obvious deformities, and the status of the marrow canal and where to perform the osteotomies, etc. A wide diameter of the C-arm is one of the more important aspects of being able to work with ease. The most important, according to me, is being able to think of using rigid reamers to convert a curved canal into a straight canal. Whichever internal lengthening nail we use, the working part of the nail is always a straight part, unlike a trauma nail, which is a curved nail. And hence we have to convert the curved canal into a straight canal, which cannot happen with flexible reamers. Polar or blocking screws are more important than we may imagine, and they help us to correct a deformity or to prevent a deformity, such as this article by Rosbrook and Fragomen about the reverse rule of thumbs, where to place the polar screws with internal lengthening nail. Entry point accuracy in the distal femur, proximal femur, and the proximal tibia are a must, and we designed these jigs for the distal femoral entry at 81 degrees of ALDFA. This entire set was made available by Manman from Pune to help performing the lengthening using intramedullary nails. The precise nail now has several sizes, diameters, and lengths available and for different types of bones. But knowing the perfect length that you need to work on and the accurate diameter of the bone is a must. Therefore, high quality X-rays with magnification markers are important. Choosing the right portal for that particular bone is crucial, especially in combination with deformity correction. So here in this particular patient with a bowing deformity and an abduction contracture, a proximal entry would not be possible. In this extreme valgus of the proximal femur, again a proximal entry through the piriformis fossa would not be possible, and you would need a trochanteric entry and hence a special nail for the same. Given the presence of a patella baha deformity or a fish mouth appearance of the distal femoral, epiphysis, we will not be able to gain entry into the distal femur in such pathologies. Today, the precise nail has many variants, and it comes in diameters of 8.5, 10.7, and 12.5 millimeters. And these are the amount of lengths that you can achieve, 50 and 80 millimeters. Let us focus on the most crucial aspect of choosing a nail, which I think is the nail diameter. The recommendation of the precise people is that you need to ream at least 2 millimeters more. Hence, for the narrowest nail of 8.5, you have to ream the canal to at least 10.5, a fact that may not be possible in many cases that we see in India, especially those with poliomyelitis and other aspects of limb shortening. This lady is a physician with polio with a lot of limb shortening, and look at the narrow diameter of her femoral canal. A nail would be impossible to go in after reaming, so hence we had to resort to external fixation, and also we were able to perform 2 tasks. Similarly, 2 tasks in this polio patient with a recurvatum deformity and shortening could not have been performed with an internal lengthening nail due to a very narrow diameter of the femur. Very obviously, the most important contraindication to internal lengthening nails is the presence of a previous infection or a sclerotic medullary canal. Any risk of recrudescence of infection is a complete contraindication. The second main reason why we cannot perform internal lengthening nails in most cases is that there is usually a second level of deformity that we need to consider. This is a distal femur non-union along with bone shortening. So how do we perform both tasks with the internal lengthening nail? Using the double level fixator assisted nailing technique, we could perform correction of the deformity at the non-union site as well as a lengthening at a separate level. This prevents us from the need for lengthening at the level of the non-union, which may not throw good bone. So we achieved double level fixator assisted nailing to complete both the tasks. Maybe the same could have been achieved with a chipping and then nailing with an internal lengthening nail, I admit. Can we perform lengthening and deformity correction in this young child with a growth arrest and limb shortening like we do with the Elizarov fixator? I very much doubt it. Another limitation, of course, is the second level. In this post-tumor reconstruction young lad, could we have performed an internal lengthening nail and corrected the deformity with one single implant? Definitely there is a need for two implants and at two levels, which must be taken into consideration. The presence of a bowing deformity itself may pose challenges. In this young lad with poliomyelitis and a fixed flexion deformity of the knee, there is almost a bowing deformity of the femur which needs an osteotomy at two levels. Now perhaps we can perform an internal lengthening nail and perform two osteotomies and allow the osteotomies to decide which one will lengthen to what extent. Contrary to our belief, it's not just the nail that goes in and performs the lengthening. We have to take special precautions and use special techniques to be able to correct deformities and allow the passage of a straight nail in a curved or a crooked bone. We can of course use the proximal portal in such an instance. And in this diagram, the double level fixator assisted nailing is shown, but we can use the same method with self-lengthening intramedullary nails. There is no denying the comfort level that can be had with intramedullary nailing for the patient, as it corrects and prevents a deformity and allows early range of motion. We do have an experience with the precise nail, having performed them several years ago for deformity correction. This person had a varus bowing deformity with a mild amount of shortening in the left tibia. We insert a specially modified precise nail to be able to gradually correct the varus deformity as well as achieve a little bit of length. This is the programmable external remote controller which is placed accurately at the level of the magnets in the precise nail, and you can decide the amount of lengthening that you can perform. Definitely in a very short time with great patient comfort, the length and the alignment could be achieved in this patient with remarkable ease. To summarize, internal lengthening nails are a great advance but come with significant limitations, and one must have available all techniques to be able to perform the lengthening and deformity correction. Thank you for your invitation.
Thank you, Milind. Now this session is open to discussion.
Yes, I suppose. Yeah, go ahead, please.
For all the faculty, most of the lengthenings we do are with congenital deformities. And I'd like to know at the knee and at the hip, how many of you do prophylactic soft tissue releases to prevent contractures during lengthening for congenital problems?
Yes, I do always. Almost always I do, except in the very mild varieties where it is not required, as I highlighted. But if you don't do, you end up in a subluxation at the hip or the knee.
What are the soft tissues that you release, say for a simple congenital short femur?
Psoas tendon, rectus and psoas tendon. If there is a flexion deformity, and if it is still not corrected, then you correct it with the osteotomy. And for the abduction, you release the iliotibial band at the GT and use it for ACL PCL reconstruction. It's been very well described by Pele, and that will correct the flexion abduction deformity. And in case you don't, you're not able to correct that, you go in for an additional abductor slide. That means you raise the abductors at the origin. So that is going to correct the abduction deformity. And in addition, if the C angle is more than 20 and upsloping acetabulum, again, these are factors which lead to a dislocation of the hip during lengthening. And I have had patients who actually dislocated. So that is why it's always better to do a prophylactic.
May I contribute, Jerry?
Right, please.
I just want to perhaps draw some caution against relying on soft tissue releases as your guarantee against joint problems, because whilst they are important, particularly when you're doing congenital lengthenings, I rarely do them in post-traumatic or post-infective lengthenings. I think the more senior, the older
faculty among this group will remember a technique in the 90s, early 90s, called the Villarrubias technique. The Villarrubias technique was described by a Spanish surgeon to do multiple soft tissue releases so that the surgeon could just do mega lengthenings. And it was very clear when I was with Mike Saleh in Sheffield that although it allowed you to achieve huge amounts of lengthenings, this was at the cost of high complication rates. Because whilst the soft tissue fascial structures that we release, the tendons that we lengthen, the muscles themselves are a restricting factor to the amount of lengthening you can achieve. And in congenital cases, even more so than the other etiologies, as Gamal Hosni was reiterating, what the cause of the shortening can determine how much you can achieve at any one lengthening. So whilst, yes, I agree, soft tissue releases are important, please don't mislead yourself into thinking it's going to stop you from getting complications.
Yeah, Duran, thank you very much for bringing that out. I remember I attended a meeting in Milan in 2012, which was a meeting of invited 14 surgeons for achondroplasia lengthening. And the surgeons who had worked in the Villarrubias clinic did present their work. And they were definitely in a position to achieve much more dramatic length. I think it pertained chiefly to the achondroplastics who are less at risk of developing hip subluxation and non-unions at the regenerate lengthening side. But thanks for pointing this out. One of the things we've learned also is not only can soft tissue releases, they can also result in a lot of muscle weakness in as in difficulties in push off in the tendo Achilles. So one has to be wary. So perhaps like in CP, bony surgeries like say in congenital shortening, say like the Dega osteotomy, when you have an acetabular index or a center edge angle less than 20, you're much safer of doing a Dega. And judicious soft tissue releases, as you pointed out, judiciously.
Can I add something? Yes.
Yes, Professor Kamal.
Yes. Hello, everybody. We were together in this meeting about chondroplasia. Yes. This is before COVID-19 era. Yes. I never do soft tissue release for congenital problems, because who said that the soft tissue contractures will increase the rate of subluxation or dislocations? Who said so? What's the relationship? I don't know. I think it's part of the it's part of the pathology. So, or it's part of you have some sort of imbalance which may not interfere with the stability. The only thing which I usually do in cases of congenital short femur is the iliotibial band, just release the iliotibial band, but nothing more than this. And there's a lot of, I think there's a mystery about the stability of the joints while you do lengthening. Because sometimes when you do lengthening for just a short distance and you have instability of the joint, and sometimes if you do huge, distances or something, you don't have any problem. So it's just you follow up the joints, the knee and the hip during gradual lengthening. And if you have any, even any suspicion of the instability or the subluxation, you decrease the rate or you stop the lengthening without any soft tissue release. So I don't think there is a relationship between the soft tissue release and increasing the stability of the joint, or as a prophylaxis to prevent hip subluxation or dislocation.
Yes, Mandar, you wanted to add something?
Yeah. So I would like to ask the faculty that if there is a contracture of knee or ankle during lengthening, has anybody used Botox to relax the muscles and then give physiotherapy rather than releasing soft tissue? Botox has got reversible effect. So why can't we use Botox?
Mother, I would like to take that question. See, Botox basically works in spasticity and not in contractures. So I don't think so. Botox may have too great an effect on contractures.
And basically the contractures occur at the tendinous area rather than the muscle. So I don't think Botox really works. And it's not a question of spasticity like Permanent said.
So one of the key things during lengthening, which Elizarov showed very elegantly, if you read the first 280 pages of his book, there's a lot of valuable information in there. And essentially, as you are lengthening, you are effectively changing the resting length of the muscle. And for the muscle to add serial sarcomeres in response to that, you have to maintain that new resting length. So we do that by trying to get the physiotherapist to work to maintain the joint range, because by maintaining the joint range, you can keep the new resting length. If your physiotherapist does not succeed, sometimes you try and cross the joint to lock the joint in the extended position as another way to maintain the new resting length. So I discovered that when those of us who have obviously been to Kurgan or to Baltimore, many of the patients have daily physio throughout their entire treatment program. We're not able to achieve this in the UK. So at best, our patients return for outpatient physiotherapy twice a week. And our complication profile because of that is also different.
Thank you, sir.
Yeah, so, if I may add a little something about contractures of the knee and ankle during lengthening, at a much more simple level, at a low-cost alternative, is the posture. I completely agree with Durai. And well, Professor Gubin was the head of the Kurgan Institute. He emphasized and asked questions about physiotherapy departments in various international conferences when he was with us. So the posture in bed and the gait while walking have a dramatic effect on contractures of the knee and ankle, especially in tibia and femoral lengthenings. In femoral lengthenings, we can always cross the frame. But in tibia lengthenings, the way the patient walks, whether he walks with a swing to gait or a swing through gait, makes all the difference. And whether he's going to develop an equinus contracture or the ankle is going to remain supple. The positioning in bed, the way they sit, and the height of the rings forcing the limb into a flexion contracture. So it is possible to prevent by some education, even if they don't have access to continuous physiotherapy. I think one of the greatest reasons the Kurgan Institute succeeded initially was that the patients were in-house during the entire treatment, and they had access to daily and prolonged physiotherapy along with a host of other patients who had the same condition. But given the fact that we can't afford to do that and they can't do it these days themselves, an ounce of prevention could be worth a pound of cure by positioning.
I have got a question to Dr. Gupta. Dr. Gupta, which subtissue you release in the lengthening of the congenital abscess of the fibula?
Can you please repeat the question?
Which subtissue release for the congenital abscess of the fibula?
Okay. Classically, it's the everters, primarily the brevis and the tendoachilles.
And Permanent, one more thing also, the fibula analge also.
Yeah, fibula and as well, because that is actually a tether, which will, if you lengthen, that will actually regenerate into a valgus.
Yeah.
Yeah, agreed.
Another question regarding this Botox injection, I am not able to remember, but there is a paper for the Ponseti method. They give Botox to the gastrosoleus in the last part of without doing the tenotomy. I had seen the paper.
Yeah, it came in JBJS, and they had to do multiple injections, and it's a huge amount, huge cost to the patient, not to the patient, the system, whatever it is. I mean, the reviews for that are not so encouraging, rather.
Okay.
So that brings us to another question to all faculty. What pain management do you use, especially for children when they're undergoing limb lengthening, especially during later stages of lengthening?
Well, firstly, if I may jump the gun, if I may, in the later stages of lengthening, they when once the lengthening is over, they should not be in pain. We find that the difficulties in young children are at the very outset, because typically, say if it's a tibia lengthening we are performing, the fibula tends to want to heal up faster, and we have to keep a close watch on them, and sometimes over distract if we don't want to take them back into the OR, and that gives rise to pain. So that's in the early stages, and we need to follow them up much more frequently in the early stages. Once the lengthening is over and the soft tissue tension has reached its peak, and then they have very little pain. So obviously we can't use a lot of analgesics, but in general, except for the fact that when we are over distracting, if we can find a cause for the pain, that is soft tissue impingement around the pin site or loose pin, the children and the parents will not tolerate pain after the third or the fourth postoperative day. And the key is to be able to see a reasonably comfortable child. The exception is the child who is psychologically not adapted to the fixator. And that happens in my practice once in a while. And they cry and they're uncooperative, but they're not necessarily in pain. But pain is something we should not see by proper technique and fixator management after the first few days.
I think I want to complete this topic. If you exclude all the causes of pain, pin track infection, over length, whatever it is, there is a new entity, which is the neuropathic pain. Pain not related to any cause or not related to any etiology. And this entity now, which is, we are learning more about the neuropathic pain during lengthening. And the last few years, we realized that we have a real problem, the pain without etiology. And we asked the pain clinics to deal with the topic, and they start to give them anti-epileptics, gabapentins and things like that in children, because they use it in the young children in cases of epilepsy. And nowadays, if we have a patient, the child with pain not related to the etiology, we send him to the pain clinic. Usually they give them anti-epileptics and the patient improves. So I think now for the guys dealing with lengthening for large number of patients, they have to think about this entity, neuropathic pain. Even in adults also, this is a real entity. Especially if you do, in some patients, you already have something in the nerves. You have, you're lengthening a patient with common peroneal nerve palsy because of something. Neuropathic pain is there, and we have to realize that we have fair number of patients with this type of pain, and they don't respond to the pain management of nociceptive pain. So finally, I would like to say that we have to think about neuropathic pain during lengthening.
Dr. Hosni, can I ask you one question? Are you referring to reflex sympathetic dystrophy in what you said?
Exactly.
Yeah, because that's something.
This is another description of the neuropathic pain.
Yeah.
If you leave the patient with neuropathic pain, you are going to have trophic changes. You are going to have some sort of osteoporosis. You are going to have deformities of the joints. And you are going to, if you leave the patient for a few months with the neuropathic pain, is going to develop chronic pain syndrome. So people, they have to put the neuropathic pain in your agenda. The neuropathic pain, the incidence of neuropathic pain is increasing from 1% in 1999 to about 10% nowadays. And perhaps in the coming 10 years, it's going to be 20% of the people having some sort of neuropathic pain. So it has to be in your agenda if you are doing bone lengthening.
RST is something, once you experience it, it's something really horrible to handle, because you need the help of a pain palliative expert. You need alpha blockers. Sometimes you may need a lumbar sympathetic block.
usually if you discover it early, there is no problem at all.
Yeah.
In adults, you can give antidepressants, and you can give anti-epileptics, and now we give them many times. Sometimes the patients also, they have some sort of depression. And if you give them antidepressant, I know the dose is different. It's more if the patient has depression than have just neuropathic pain. But nowadays we have a protocol for the patients, especially in adults. If we suspect the neuropathic pain, we start giving them very early the treatment. We don't refer them to the pain clinic, because now we realize that we have many patients with neuropathic pain. We didn't discover it before. It was not on our agenda. But neuropathic pain is a real entity, and the people dealing with with limb lengthening. That's why if you look to the literature in the American and the Western literature, they always talk about the pain. They do few number of patients, and the patients talk about the pain, but they ignore the neuropathic pain. But nowadays, we know that this entity is there, and we realize we early diagnose the neuropathic pain, and we give the treatment ourselves, and it's easy. The problem with the neuropathic pain, you don't have rapid disappearance of the pain. The patient needs to take the treatment for 2 or 3 weeks before having improvement of the neuropathic pain. But you have to give them the treatment, and the results are good.
Dr. Muthukumar, does that answer your question? Yeah, Milind, one thing I wanted to ask you is this precise nail. I recently heard it's withdrawn from the market. What was the reason for that?
Tried stainless steel nail that they used for bilateral stature lengthening, and which they promoted as the nail that was the solution for full weight bearing. And they found that in the junctional regions of the nail where the telescoping end protrudes, there's a lot of osteolytic reactions taking place in the bone as a result of that. So, there's a couple of articles written up. One came in the JLLR, the Journal of Limb Lengthening and Reconstruction. Recently, Chris Obst also wrote about this in the British JBJS. It's an observation that they have, and what they're trying to do now is they're trying to go back to the drawing board, I think, to try and solve this problem. So the stride nail, that's the stainless steel variety of the nail, has been taken out. So, the entire evolution of the internal lengthening nail, and I think Professor Gamal Hosni will agree with me, I think it's not the last word, because if you notice the history, it started with the Albizia nail made by Jean-Marc Guichet, and it simply wasn't available to anybody to use. And it had this ratcheting mechanism that needed 20 degrees of rotation, which was painful for many patients. And Jean-Marc himself came up with some fantastic ways of, mentally programming the patient to accept that, but except in his hands, it wasn't available. Then came the ISKD nail, which worked on a worm gear mechanism, and the simple act of walking 9 degrees of rotation allowed the nail to distract. And there was over distraction and dislocation and subluxation going on. And then came so that was withdrawn. Then the fit bone was so very expensive that resulted in problems. Only a few surgeons managed to do it well. And the precise also in the first generation of the titanium nail had fractures at the junction of the at the junction of the bend and the straight part. And now the stride nail also has. So especially in the Indian scenario, or say in Egypt, in countries like ours, where the cost of these nails is exceedingly high, to end up with problems like this, when you can easily perform a 3 or 4 centimeter lengthening with the Elizarov or the TSF or the lengthening or a nail or lengthening or a plate method at really moderate costs. I think we still have to wait to see a generation of lengthening nails that are indeed reliable and are not hyped way above their true potential and true capabilities.
Thank you, Ma. Rajiv?
My question to Dr. Mangal, please.
Yes.
What is the advantage of this hexapod lengthening over the simple Elizarov frame lengthening?
No real advantage, except that if there is some deformity, you can correct it. So usually if we have to do a pure lengthening where there is no deformity, I would just use either monolateral, depending on how much length is required where. I would use either a monolateral or a regular Ilicerov. If at all in an Ilicerov, if a deformity does occur, then you can put on, there are systems, see there are two hexapod systems. One is the TSF, which has its own rings and things like that. There are also other hexapod systems which you can attach to the Ilicerov rings and correct that deformity. You can also correct the deformity by the use of hinges, etc. So for pure lengthening, there's no real advantage. For complex deformities where you want to correct angulation, rotation, translation, kind of all together, 6-axis systems have a big advantage.
Okay, thank you.
Dr. Hosni, one question I would like to ask all the faculty. What is your experience with achondroplasics? How is your how much is your complication rate rather?
For the achondroplasia, we start from the age about the age 5.
Yeah.
And it depends upon the deformity. If you have a severe deformity, we start earlier than this. And we start in stages. Usually with the first stage, we do tightening of the lateral collateral ligament. And we do 2 times the tibial lengthening and 2 times the femoral lengthening, and once for the both humeri. And we finish by the age 16. So when the patient goes to the college or to the university, the people will see him in the new shape. So they don't talk. So his presentation in the society is the new shape. It's 150 or 160 centimeters. The rate of complications in achondroplasia is far less than lengthening in congenital problems. Far less. I think the best results in limb lengthening is in achondroplasia. In spite of, we have many patients, perhaps in the same in India, with poor socioeconomic conditions. They cannot afford physiotherapy every day. They are coming from huge distances, 1,000 kilometers. They don't do regular follow-up. And in spite of all these problems, they have very good results, which means that in achondroplasia, lengthening, it's justified, especially in our patients. When I was abroad and they were talking about leaving the choice of the child at the age 16 between lengthening and or living like this, because they have facilities for short stature people. But this type of luxury is not in our community. We finish at the age 16. We don't start at the age 16. I think the tissues in childhood are lax and will withstand lengthening for more than once. And you can do bifocal lengthening. We have a lot of chances. And if you wait till the age 15 or 16, you are going to lose chances. So I advise, in my experience, that we have to start early in achondroplasia, and we can finish before the university with few number of complications. But of course, complications do happen. We cannot ignore the presence of complications. But by far, achondroplasia is a good candidate for lengthening.
Mangal, your opinions?
I agree. I mean, our situation is exactly the same. So we start early so that we have enough time for giving them adequate amount of lengthening, which is useful. That's number one. Number two is because of this pre-programmed relative difference between the way I look at it is achondroplasia is the muscle lengths have been programmed to be normal and the bone length has been programmed to be short. So they in fact have laxity, and rarely they have any issues with contractures and things like that. So compared to other lengthenings, achondroplastics, you can lengthen them quite a lot. And this is, in our situation, this is not a cosmetic surgery. It's an absolutely functional surgery, because all our infrastructure is made for so-called normal heights. So even if they reach the lower end of our normal height, that's a big advantage for them. So no question that I think it's the right thing to do for them.
Milind?
I mimic Professor Gamal Hosni's experience. I have also been doing for the last 30 years achondroplastics. I believe there's another aspect to starting lengthening early. That's before they reach school. If they are made, see, the sitting height of achondroplastics is normal because the spine height is normal. The anterior posterior diameter of the vertebral bodies is narrower. That's why they get canal stenosis. But when they sit in a chair, when they are in school, they're like their peers, they're normal. But when they stand, they're very short. So the problems in their mind and their problems, their complexes develop when they reach school and they get teased. So I believe I try to counsel the parents who will understand that for various reasons, start the lengthening early. One of the interesting reasons is that the facial features that are present with depressed bridge of the nose and extreme frontal bossing and all that. So the bone formation over here is somehow also influenced. Not only is there an improvement in their ability to, increase the length, but there also facial features improve if you start lengthening early at the age of 4 and 5 years. And then, as Professor Gamal Hosni has said, if we subject them to lengthening again, they have the chance of becoming short normals rather than remaining very short. So this conference that we attended in Milan was hosted by ISAC, which is the short people's support group from Italy. And we don't have such a one in India. And the Little People's League in America dictates, and many children and parents don't opt for lengthening. And we can't blindly follow the dictates given by the cultural norms that come from the UK and the US, because as Professor Hosni said, they have a lot of support systems. Our patients and parents don't. And what happens is that we find that the children who grow up with achondroplasia, and if they are told to wait until the age of 12, as Mike Saleh in a 1991 paper in OCNA wrote, what happens is that the children become obese, they become obstinate, they become inactive, and then the lengthening becomes very difficult. So, yeah. So it's really a cultural understanding of the problem that's going to help us to, solve the problem effectively for our cultures and for our society.
Durai, you have anything to add? You come from a place where there's a good support system for these people.
Limb lengthening with Mike Saleh. Yes, we were doing a fair number of achondroplastics. As Milind and Gamal have pointed out very clearly, is that the cultural expectations are totally different in the UK. The children with achondroplasia, the adults with achondroplasia now refute any form of lengthening, but they will have deformity correction. So even if you don't lengthen, many of these limbs are deformed and would benefit from deformity correction. Having said that, Milind pointed out support groups. What's also very pertinent in the UK, and maybe perhaps increasingly so, is that many of these achondroplastics and those with other syndromes are actively involved in the sporting events that support people who have not normal abilities, the so-called Paralympic events, and achieve incredible successes and become role models for their peers. So the pressures change with society. I can understand why in India and Egypt, where lengthening in achondroplasia is still very much in demand, but that's virtually ceased in the UK.
Jerry, can I add?
Yes.
Now, for information, Government of India has come for their rescue. They have classified it as a type of locomotor disability, and they can get all the benefits as like a polio or cerebral palsy, whatever, or amputation, whatever they get, they have same system, education, loan, whatever the scholarships applicable to others, it is applicable to them also. And this classified according to the height also, 100%, 90%, 80%, similarly. This is for the I can add.
Okay, that's a good news.
So I think that's excellent discussion. Cherry, I think it's 5 o'clock and
Past
we
5.
should, yeah. So
I think,
thank you.
Yeah, thank you all the faculty. And
Thank you all the
POSI
delegates for a very lively
very
discussion and
session.
your
And
participation.
Thank you, POSI, for allowing us to chair this session. Thank you.
Thank you. Thank you so much.
Just an announcement for the delegates. The Zoom link will remain active. You can leave and you can join back the same.
There'll be a 10-minute break. Join back by 5:25 to start the next question.
Yes.
Okay.
Thank you.
Bye.
Thank you.
Yes, Supriya, you can check Dr. Atul Bhaskar's presentation now. Let's see. The OI session.
Okay, sir. One moment.
Hmm. Just open the slideshow. Yeah. Okay.
Management of osteogenesis imperfecta, our experience.
That's fine.
The presentation of OI is highly variable. We get children.
That's fine, right, Supriya?
Yes, sir. It was audible, right?
Yeah, it was audible.
Okay, sir.
Okay, so it will play like that.
Excuse me, do we have a session now?
Yes, it will start in 10 minutes.
10 minutes. Okay.
We have a break in between, so it will start.
Next one.
Ashok?
Hello?
Ashok,
Yeah.
just put that other one also, no? SP Das ka next year ka screen.
Okay.
WhatsApp भेजा है, WhatsApp
Okay.
भेजा है.
Okay.
Ashok.
Atul bhai, all ready?
Sandeep,
हाँ बोल.
is this the session for OI or trauma? Or is this?
नहीं, here OI. This is Hall B.
Hello, Dr. Reggie.
Good morning. Do you hear me?
You're on mute.
I think. No,
I
you can
really-
hear it.
Do you hear me now?
Yes,
Yes. Yes.
Good morning.
Morning.
Or good afternoon.
Hello,
I
Sandeep.
think-
Hello, Atul.
Hi, Hitesh. How are you?
Fine.
I think
Yeah, got the volume.
we
Yeah.
have 2 minutes to go. So, Hitesh, can you welcome everybody and start the session at 5:30?
Yes. Okay. Sure.
Thank you.
Supriya, you all set?
Yes, sir.
Vijay around or Vijay is not participating?
I talked with Vijay. Vijay said he has got some function, so he's not going to join.
Okay. I think he had some commitments, you were saying. Yeah.
Yes.
So you can take charge as well.
No problem. I will hand over to you, and
No
I will
problem.
be here. I will be there.
Sure. It'll be nice to have.
Yeah.
Because I don't know how we can do the discussion part because either we answer the question on the chat or if somebody has any questions, we can take it.
No, like last session, what we are going to say that the question answer session will take a break and we'll ask the candidate or the delegates to ask the question directly.
Okay. All right.
Good morning, Dr. Andrew, and good morning, Dr. Peggy.
Reggie, you're there?
Yeah.
Morning.
Hi, morning. What's the time in Montreal?
It's 7 in the morning.
Oh, good. You're looking fresh.
Yeah, we are fresh. Everything is okay.
Good
What
morning,
time do you
Atul.
have there?
Hi, Andrew.
Hi, Andrew.
Hi, Reggie.
Good morning. Are you in Toronto?
Yes.
It looks like you're
The
in the
background
Bahamas.
looks nice.
I'm just switching it.
Yes.
Thanks.
So,
But I will call you. Thanks.
yeah, it's 5:30. Shall we start, Ashok?
You can start, sir.
Yeah. Good evening, all. I welcome all to the pre-conference workshop on the osteogenesis imperfecta. Due to the COVID crisis, we have to convert this into the physical conference into the hybrid and hybrid to the pure virtual. We are sorry for that, but we are going to cover the same topic with the same faculty, and we are fortunate to have the faculty from the Canada, Dr. Reggie and Dr. Andrew Howard. And the program has been finalized by Dr. K. Sriram and Atul Bhaskar. So without wasting the time, I will hand over to the Atul. We'll start the proceeding. Thanks, Atul.
Thanks, Hitesh, and I welcome all of you to the virtual session of POSI 2022. And we have a great session planned for treatment of osteogenesis imperfecta. I think Vijay is not there, but his first talk is on bone biology and types of OI. Is that talk being recorded?
Yes, yes.
Can we start with that, please?
Good afternoon. First, I'd like to thank the POSI committee for allowing me to speak. I'm going to speak on the bone biology and the types of OI in osteogenesis imperfecta, and I'll keep this brief. Sorry. Yeah. So, osteogenesis imperfecta is a genetic disorder of connective tissue. Bone fragility, especially of long bones, is a trademark clinical manifestation. There is a wide spectrum though. Fragility can be so severe that the affected infant is born with crumpled ribs, a fragile cranium, and long bone fractures incompatible with life. Whereas at the opposite end of the spectrum, an older child who otherwise appears normal may sustain only a few fractures after a reasonable amount of trauma. 90% of affected individuals have an identifiable genetic defect, producing quantitative or qualitative abnormalities in type 1 collagen. What is type 1 collagen? It's the major structural protein found in bone and connective tissue of dentine, sclera, skin, ear bones, vessels, and heart valves. It's a triple helix molecule made up of 2 alpha-1 chains and 1 alpha-2 chain. So this is what it looks like. We have a talk on the genetics of OI, and I'm sure it will be covered there in greater detail. The fundamental defect in approximately 90% of the patients with OI is an absolute reduction in the amount of normal type 1 collagen in bone, or its replacement with a poorly functioning mutant collagen, usually also reduced in quantity. Thus, the formation of endochondral and intramembranous bone is disturbed. This is how normal bone looks like under the histological picture, and this is how OI bone looks like. I'll come to the differences. The bone in OI, the bone trabeculae are thin and lack an organized trabecular pattern. Fractured spicules of trabeculae may be found. The spongiosa is scanty. Intracellular matrix is reduced, and as a result, there is a relative abundance of osteocytes, and that's what you see here. The osteoclasts are morphologically normal, although they seem to be numerous and have an increased number of resorption surfaces. Osteoid seams are wide and crowded by plump osteoblasts. This large number of osteoblasts, osteoclasts, the large size of the osteoblasts, and the plentiful osteoid tissue covering the thin bone trabeculae indicate an increased bone turnover, and this is what we see clinically. The lamellae in lamella bone are thin and tenuous. The compact bone consists of a coarse fibrillary type of immature bone without Haversian systems. Periosteum and perichondrium are generally normal. The physes are usually broad and irregular. The proliferative and hypertrophic zones are disorganized, and the typical columnar arrangement is lacking. The calcified zone of the growth plates is thinner. Metaphyseal blood vessels permeate the growth plate. Islands of cartilage are present in the juxtaphyseal metaphyseal region. The primary spongiosa and metaphysis is sparse, with the osseous tissue almost always of the woven variety. The secondary centers of ossification of the epiphysis are delayed in maturation, and residual islands of cartilage remain in the epiphysis. When a fracture is present, the endosteal fracture callus is primarily cartilaginous and the periosteal reaction is abundant and consists mainly of woven bone. Anatomically, what we see in severe OI, the long bones are slender, smaller than normal, cortices are extremely thin, there's a paucity of medullary sponge bone, and there's evidence of recent or heel fractures with varying degrees of angular or torsional deformities. The cartilaginous epiphyseal ends of the long bones in general retain a recognizable shape but are disproportionately large, and some have irregularity of the articular surface. That's it for the biology in brief. We'll move on to the classification. Lucer in 1906 classified OI into congenita and tarda types. Now, congenita is characterized by the presence of numerous fractures at birth, and tarda is characterized by fractures which occur after the perinatal period. And this was his original publication. Shapiro in 1985 recommended a further modification of Lucer's classification, and he classified them into 4 categories. It's congenita A and B and tarda A and B. In congenita A, they sustain fractures in utero or at birth. These children are basically incompatible with life. Congenita B have fractures at birth, but then long bones are more tubular, no chest deformity, and though severely affected, this type is compatible with life. Tarda A fractures occur before walking age, but the ambulatory status does not depend on the age of onset of fractures. Tarda B fractures occur after walking age, and all of them remain ambulatory. Though this classification is a simple one, it's an excellent prognostic indicator for both the parents and the caregivers, especially in an outpatient setting. Sillens and Danks in 78-79 delineated 4 distinct types of OI based on clinical and genetic characteristics. So in their types, type 1 and type 4 had 2 subtypes A and B. I'll just briefly go through all of them. In type 1A, the teeth are normal. Bone fragility is quite variable. It's less severe than the other types. This is actually the best type to have if you have OI. Growth retardation is only 2 to 3% below the mean, and sclera will be blue throughout life. In 20%, you get a spinal deformity. The only difference in type P is these children have dentinogenous imperfecta. Rest is all the same. Type 2, they all die in the perinatal period. They are very severe deformities, and they have crumpled bones in the perinatal period, and their death is usually in the perinatal period. Type 3, they have dentinogenous imperfecta. They have severe bone fragility. These children are the smallest of the OI kids because they have severe growth retardation. They remain non-ambulatory. Their sclera are blue throughout, and usually they die within the 3rd decade. Type 4, the teeth will be normal. They have moderate bone fragility, a little bit more than the type 1. The deformity is moderate. They have short stature. The sclera will be normal, and they too get kyphoscoliosis. The difference with type 4B between type 4A is only that these children have dentinogenous imperfecta, and the rest of the clinical features remain the same. In their original description, 4 types are described and identified as autosomal dominant, which are the types 1 and 4, and then autosomal recessive type 2 and 3. We now know that these have changed. In addition to collagen type 1 mutations, other gene mutations are found to result in OI. And this genetic classification has already increased to 18 types of OI now. That's 1 to 18. And more genetic types are to be expected in the near future. So 85% to 90% of the OI population have an autosomal dominant inheritance leading to the common OI types 1 to 4 due to the mutation in collagen 1, alpha 1 or alpha 2 genes. The rare OI type 5 has an interferon-induced transmembrane protein 5 mutation. All the others are autosomal recessive, that's type 2 to type 18, and these make up 15% of the spectrum. The defects in OI type 6 to 18 are not in the collagen type 1, but in genes that play another role in the process of bone formation. I'll briefly go through the other types. In type 5, there's hypertrophic callus after fracture, a radiodense band adjacent to the face of the long bone, and they typically have interosseous calcification between the radius and the ulna. These are the 3 key features of this type. There's also white sclera, absence of dentinogenous imperfecta, and radial head dislocation. In type 6, it's a histological diagnosis. The lamellar bone will have a fish scale appearance. There's absence of dentinogenous imperfecta. They'll have white sclera and moderate to severe deformity. Type 7, 8 and 9. Type 7 is associated with rhizomelia, moderate to severe skeletal involvement and growth deficiency. Type 8, the disease can be severe or lethal and is associated with rhizomelia. The type 9 disease is very similar to type 7 and 8 except for the fact that there is no rhizomelia. Types 10 and 11, type 10 is associated with severe bone dysplasia, blue sclera, dentinogenous imperfecta, transient skin bullae, pyloric stenosis and renal stones. Type 11 disease is associated with bone dysplasia, ligamentous laxity, platyspondyl scoliosis, sclera and teeth are normal. Now the other types between 12 and 16 are all just, they're autosomal recessive and a mixture of these. I won't go through them. Thank you very much for your patient listening, and I hope this workshop is really good.
Thanks. I think that was a great overview of the types of OI, and I think in future we may need an OI Bible, because it's almost impossible to remember all these various types with their various clinical manifestation. And over the last 20 years, there's been an exponential rise in the various types of OI with better advances in molecular biology. So now we move to the next talk, which is on the medical management. And I think that may be the mainstay of treatment in the future. So I invite Mahesh Kore to present the next talk on the OI medical management.
Good evening. I am Dr. Mahesh Kore from Nipani. I'll be talking of medical management of osteogenesis imperfecta. They have repeated fractures right from the early infancy, and they need lot of support surgically as well as medically. Type 1, 2, 3 will have blue sclera, and 4, 5 will not be having blown sclera. It's all about osteoclastic activity and osteoblastic activity. When osteoclastic activity is more than that of osteoblast, you can see bone reabsorption will be more than the bone formation, and that's why they become porotic or brittle, and they can easily fracture by some trauma. In this picture, you can see that osteoblasts are not working at all and osteoclasts are overworking. That's why there will be a brittle bone. So current treatment for OI is to suppress osteoclast, and that's why to increase they will increase the bone mass. The biphosphonates are routinely used, zoledronate or pamindronate. We use in our hospital pamindronate. They will suppress the osteoclastic activity and osteoblasts will be normally functioning, and that's why bone mass will be increasing. Stimulators, growth hormone and synthetic parathormone also are used, but they are not that effective. Bisphosphonates acts by suppressing osteoclasts. How they suppress? They are chemically stable analogs of inorganic pyrophosphates. Bind to the bone mineral surface. They are internalized by the osteoclasts and interfere with their action. They induce apoptosis, and that's why they inhibit bone reabsorption. And this is how bone reabsorption is inhibited and bone formation continues and bone mass is increased. Treatment of OI is by bisphosphonates, pamindronate. We have used pamindronate in this child, but one of the side effects of pamindronate is hypocalcemia. So we have to supplement these children with vitamin D and calcium orally. In this chart, you can see that he has grown well on the 3rd percentile, but he had a repeated fractures, and we have to supplement with bisphosphonate, that is pamindronate, 3 monthly. This is the second child we have having multiple fractures right since 6 months of age with minor trauma. She has multiple vertebral fractures, multiple long bone fractures, and she was a case of IVF pregnancy. Now we have supported her with vertebral brace, and support has been given for walking also. But typically this child has pronation and supination difficulty. So this can occur in osteogenesis imperfecta type 5. She has multiple fractures. That's why we have to start her on pamindronate. And OI type 5 has been confirmed by clinical exam sequencing. that is by genetic test. Pamindronate, initially we have to give 0.5 milligram per kg body weight on day 1, and it has to be infused in normal saline over 4 hours and look for the side effects. And on second day you can start with 1 milligram per kg for next 2 days, and this cycle is completed of 3 days. So every 3 monthly you have to give 3 days cycle, and we can continue this for 2 to 3 years or more if it is helpful. And we have to watch for hypocalcemia, supplement with vitamin D and calcium. Areas of agreement on bisphosphonates are: maximum benefits occur in first 2 to 3 years. Bisphosphonates more beneficial for vertebral compression than the long bones. Incidence of scoliosis is similar in treated and untreated children. Still requires intramedullary rods. Surgical intervention is still needed. Bisphosphonates are more beneficial for spine. There is no significant improvement on ambulation of muscle strength and pain, and chronic treatment can cause modeling defect, delayed healing, and deterioration of material properties because they interfere with the osteoclastic activity. What are the new therapies they are available? Monoclonal antibody can be used to stop disease-causing molecules. A sclerostin, TGF-beta, RNAKL, these are the monoclonal antibodies can be used like these. Denosumab is coming in a big way because it doesn't have a very prolonged half-life like pamindronate, and it inhibits osteoclastic activity. Sclerostin and antibodies to sclerostin, antibody to TGF-beta, these are also coming in a big way, but they are in an experimental stage. Anti-sclerostin antibody improves the bone built up by inhibiting osteoclastic activity. So bone formation will be more than the bone reabsorption, and that's how bone mass is increased. Denosumab. In recent decades, OI has moved from disease with unknown etiology to the disorder with a precisely described and mapped genetic background. We can diagnose them easily by clinical exome sequencing. Current available treatment options of OI try to prevent fractures, control symptoms, and increase bone mass. The most common medication used in OI treatment are bisphosphonates, denosumab, and synthetic parathyroid hormone and growth hormone for children therapy. The main disadvantage are they are weakly effective. So means they are not that effective, and there are some side effects which are intolerable. So experimental therapies of OI are bone marrow transplantation, stem cell therapy, and inhibition of osteoclast and promotion of osteoblast. The promising strategies for the future treatment of OI and other genetic bone diseases are based on stem cell transplantation, genetic engineering, and molecular chaperones usage. However, most of these approaches are still in the experimental stage. Consequently, further investigations are needed to confirm their therapeutic benefits in OI. Thank you.
Thank you, Dr. Mahesh. And I think there are a couple of questions, if you can take them, is how early can you start bisphosphonates in a child? And I'll also ask this to Dr. Reggie and Andrew in their practice, how early do they start bisphosphonates?
Yeah, hello. Am I audible?
Yes, yes. Please go ahead.
As soon as you diagnose that OI is there, and you have to type that, genetic testing has to be done. And if type 1 OI is a very milder OI, and if they get recurrent fractures and difficult to manage with surgery, then with bisphosphonate we should try, because we can give bisphosphonate for 3 to 4 years, maximum 5 years, because their role is very limited. Once you suppress osteoclasts, means your reabsorption has been hampered, and there will be minor cracks in a bone which will hamper again that strengthening of the bone. So you cannot go indefinitely on bisphosphonates. So unless your other management fails, then we can shift on bisphosphonates in a type 1. if type 5 like this case, you have to start as early as possible because it is very serious and supination pronation is hampered. They will have repeated fractures more often. Type 2 is lethal. Type 3 is moderate to severe, and type 5 is also moderate to severe. Type 2 is lethal. We cannot do anything for type 2. But type 1 we have seen, and we have put them on 2 to 3 years or 4 years of bisphosphonates, mostly pamindronate. I have not used jalindronate because there will questions on jalindronate. I have not used personally because it is more stronger, more superior, and but side effects of bisphosphonate pamindronate are they deposited in the bone, in a mineral. So their half-life will be very long. So their actions will be very prolonged. So now the dosanabab that one has come, antibodies. So their half-life is very short because they are not deposited in a bone mineral. I have very little experience about the bisphosphonate. That's all. Thank you.
Thank you. Thank you. Can I ask Dr. Reggie and Andrew in their own practice how early they would start and whether currently they're using denosumab as their primary treatment or they're still using zoledronic acid? So Dr. Reggie first.
Okay. In our hospital in Montreal, we have been using zoledronate now for a few years. The medical treatment, first I want to say that it's symptomatic really. Up till now, there is no actual treatment for OI, but we treat the symptoms. And you have a whole medical team that is taking care of this. It's not us, it's not the surgeons who take care of the medical treatment. However, as I mentioned, we have been using zoledronate in babies. In fact, it's few weeks born. The first time they receive the zoledronate, they are being admitted 3 days to the hospital to monitor their calcium and the thing. But we use them at a very early stage. We had a study, it was completed. Now it's a routine. We stopped using the oral biphosphonate a long time ago, like the pamindronate. We stopped this, not the pamindronate, the alendronate. We stopped using it. Then we switched to pamindronate, and then we switched to zoledronic acid. And what we do after a few years, according to the criteria, the bone mineral density, especially the vertebral bone density, we give the patient what we call a biphosphonate break or a biphosphonate holiday, and then you can start again. The indication for using it again, it's multiple fractures or pain, but the standard treatment is zoledronate. Denosumab, it's not a first line of treatment. We use it often in the type 5 that are cases that are not responding to biphosphonate. But the first line is always zoledronic acid.
Okay. Andrew, your thoughts on early intervention, medical intervention?
Again, can be early for the kids with multiple birth fractures, but that usually requires implantation of a subclavian port. So that's for the severe among the severe. For the less severe, they usually start when they're a toddler with intravenous infusions. Again, our mainstay is zoledronate. We still use some pamidronate, and that's for the kids who get pain, before the zoledronate dosage is due. So if pain is a big part of the presentation, the more frequent dosing of pamidronate can be helpful. There is some recent experience, again, this is through our endocrinologists, with the denosumab. They had a slew of patients on denosumab as a trial. It has some theoretical advantages. When it's off, so you think the bone might remodel a little bit better. The difficulty that they ran into with almost all of the kids is that we were admitting them post-trial with dangerous levels of hypercalcemia. They get this very hungry bone, very released osteoclasts, maybe 6 months after their last denosumab dose if you stop giving it to them. And so what our adult colleagues have been doing for years is capping the denosumab with some bisphosphonate or using the denosumab and bisphosphonate together. So just this caution about denosumab, there have been a lot of complications with its use as a single agent in children, and the children seem to be even more sensitive than the adults. I would work with the endocrinologist. I think there's probably still a role for that, and I would combine it. And then the final thing to mention is this romosozumab or the setrusumab, the new ones, the anti-sclerostin antibodies. This is probably the only anabolic agent that is actually going to work. So it would be nice to trial this one properly But as your colleague said, we don't have the empirical clinical experience with those ones. We've tried the growth hormone as an anabolic agent. It's not a good idea, certainly not as a single agent. It doesn't work as well as the bisphosphonates. So I think the mainstay is your zoledronate right now. I think that's where we are clinically. And if you move to, and we do use it fairly continually. This concept of a drug holiday, we tend to adjust the dose down a little bit according to the bone mineral density, but we'll use it until they've completed their growth and then wean them off.
Right, great. So I started using zoledronic acid about 15 years ago, and the endocrine guys, they still prefer pamidronate for some reason. I don't know why. So now we move to the next topic. There are some questions in the chat box, and if Andrew and Reggie, if they want to answer those, it would be helpful for the delegates. Hitesh Shah, I'll invite Hitesh Shah, who's got a lot of experience in dual rodding, and this is the meat of the matter, the orthopedic management of OI. And Hitesh, over to you on technique of double rush rodding.
Double rush rodding of the femur in osteogenesis imperfecta. The objective of my talk include the principle of double rush rodding technique, variables to be considered for such technique, preoperative planning, instruments requirement for such technique, surgical steps, complication, how to avoid the pitfall, and few cases. 6-year-old boy presented with femur shaft fracture with a trivial trauma. This is not an uncommon scenario with osteogenesis imperfecta. Few years back, when telescopic rod were not available, the option was non-elongated rod like rush rodding. Telescopic rod may be the Frazier rod or the Sheffield rod or double rush rodding. And double rush rodding would be a good option in a developing world. Each option will have merit and demerit. The single rush rod will have the poor longevity, easy to perform, but it doesn't last longer in a growing child. Telescopic rod elongate with the growth, however, it would be costly, and Indian-made implant would not be telescoping occasionally. Similarly, retrieval trauma happens if the telescopic rod bend, then the effect of telescopic would not be affecting after a fracture trauma or a bent telescope. Double telescopic rush rod is an effective technique in few of the developing world. However, there would be some technical points for double rush rodding and difficult to perform with the smaller diameter medulla. What are the variables to be considered for the planning of double rush rodding? The age of the child would be an important factor to consider for the double rush rodding. We generally do double rush rodding between 5 years to 10 years of age. In extreme, in children less than 5 years and more than 12 years, double rush rodding would not be effective because the canal diameter of the small child is too small to accommodate two rod, while elongated rod is not required in adolescent. Severity of disease would also be effective. It's very severely affected child with lot of osteotomy would be required. The double osteotomy, double rush rodding would not be a good option. The surgeon experience and availability of specific instrumentation would be also to be included for the variables. The aim of the treatment to correct the deformity and minimize the frequency of fracture. The principle of double rush rodding include the use of non-elongated rod with using a principle of elongating rod. Like the femur fracture treated with double rush rod, and after few years, both rush rod would be working as the elongating rod. How to do the preoperative planning of such cases? The tip of the trochanter to the distal articular surface must be measured in the both views, and the shorter the distance in AP or lateral wood should be selected at the length of the rod. We generally take the 2.4 mm or 2.3 mm rod for the preoperative planning. If it is not possible, you can do 1.4 or 1.3 or 2.3. As far as possible, we'll select the 2.4 mm rush rod. The rush rod, we should take it to the workshop, and bevel tip should be cut and with hacksaw and rounded with the grinding, because of the minimizing risk of the rod perforating the cortex of the femur. Typical instrumentation for double rush rodding include the reamer, that would be a 3 mm, 3.2, 4 mm and 5 mm, the hacksaw with the telescopic rod instrument set. Typically, the position of the patient would be semilateral in the spica cushion. We do the typical approach of the patient in a direct lateral approach with the vaster splitting at the apex of the deformity. We do the osteotomy just proximal to the bow, and very severe deformity, we tend to do the shortening. The overlap of the bony fragment at the osteotomy site should be shortened. We do the paraxial reaming, and that would be the key for the double rush rodding technique. Do the eccentric, the reaming to accommodate two rod in narrow canal. The proximal segment would be reamed retrogradely and temporary insertion of the proximal rod. After insertion of the proximal rod, we find the second track and ream on the secondary. We start with the minimum 3 mm and go with the 4 mm. Distal fragment was also reamed from the osteotomy towards the knee joint, and do the knee arthrotomy and find out the trochal groove and just anterior to the notch. We do about reaming and do the railroading with the proximal rod through trochanter and insertion of the distal rod through the knee. The reduction of the fracture or the osteotomy would be done, and the rod must be impacted till the hook is seated to the bone. Distal rod hook must be buried to prevent the back out. We generally keep the spica for the 6 weeks. The key points for minimizing the complication include the angular deformity should be corrected completely. A rod should be placed centrally as far as possible in proximal and distal phases. The angular deformity should be corrected, and proximal migration of the rod should be always kept in mind while doing non-elongating cases. 6-year-old child present with the femur fracture treated with the double rush rodding, the 6 weeks following the 3 months. And if you can see the telescopic effect after 1 year, 2 years, 3 years, and it went for the 7 years. And when the entire length of the bone was not protected, we advise for the revision, but it was not possible. So the child fell at the 7.5 year at the school and got bent with the bent distal rod. So we revised with the double telescopic, and because of the narrow canal, we couldn't insert the distal rod in the full length. The child had got this is X-ray after 6 weeks, 1 year, 2 years, and at the 3 years after the last surgery, child almost attained the skeletal maturity. There are few complications in such cases, might be having fracture, the proximal migration of the distal hook, the fracture with the band rod, the deformity might present with the trivial trauma. Conclude the IM nailing is a preferred as a gold standard for treatment of femur diaphysis fracture. Double rust rodding is a good option to treat the femur fracture. It is a cost-effective option for developing world. Considerable frequency of complication can be expected with brittle bone disease. Thank you very much for your patience listening. Any question regarding this issue would be highly appreciated. Thank you.
Oh, hi, thanks, Hitesh. We will take the questions after the other session. So I invite Dr. Reggie now, who will be speaking on the pre-op planning and surgical technique for the expandable rods. I think they are the pioneers in developing the rods, and I think of the most experience in using telescoping rods. So over to you, Dr. Reggie.
Yes, I'm putting my, that's the one. Good afternoon, everyone. My name is Rich Hamdi. I'm a pediatric orthopedic surgeon in Montreal and the Shriners Hospital and the Children's Hospital. First, I would like to thank the organizing committee, and specifically Rajiv Negandhi for having invited me. I'm really very happy to be part of this conference. The whole session is on osteogenesis imperfecta, and I'm planning to present 4 talks. That's the first of the 4 talks. Excuse me. Yeah, that's the recorded one. Can I go with the live one, please?
Can you do that, Ashok Sham?
Yeah, we can do that.
Yeah. Let's go live then.
Let's go live. Okay, so what to go?
Yes.
Yeah.
All right. Okay.
What? Do you okay? Do you see me now?
We can see you.
Perfect.
Yeah, we can see you.
Okay, thank you. Sorry for this. So first, thank you very much for having invited me. I mean, you heard what I wanted really to say. I have nothing to declare. So the goals of this treatment, we are going to talk the preoperative planning. It's well known. The first few slides will be a general small treatment for OI. So we are trying to prevent or minimize the fracture deformity, improve their mobility and overall function, and to render them as independent as possible. We cannot do this alone. We need a big multidisciplinary clinic. And here you will probably, if you can recognize that, Dr. Fassier, who was really a pioneer, and that's Dr. Gloria, who pioneered the use of biphosphonate treatment. I'm not going to talk this. We mentioned it already. There are many anesthesia considerations that have to be fulfilled. And just to mention here, the bleeding tendency that is present with all patients with OI. And as a routine, I don't use any tourniquet. You have intraoperative, but I never use a tourniquet in a child with OI. The indications for surgery are well known: multiple fractures, severe deformity, severely displaced acute fracture, and whenever you have pain but without an obvious fracture. What is the best time for surgery? It's everyone agrees on this. Once the child with multiple deformity or fracture starts to stand between the age of 18 and 24, then we can do the first rodding. First thing in the preoperative, after they're seen by anesthesia, we have to analyze the deformity like any other lower limb deformity, knowing that deformities in children with OI affect almost all the bones. They are multi-segmental, multi-planar, and multi-apical. Which type of rod? I was asked to talk about the telescoping rod. Specifically, the one we use, obviously, it's the fasciae duval rod. We stopped a long time ago using the Dubroveli or the Sheffield rod because there were too many complications. Big advantages of the fasciae duval rod is that you don't have to do an arthrotomy at the knee. The male and female components are introduced antegrade from one small incision or retrograde. However, all telescoping rods have complications. How to choose the diameter of the FD rod? We measure the isthmus, which is the narrowest part of the femur. And just to remind you here, smallest diameter FD is 3.2 millimeter. We ream to 3.4. Smaller than this diameter, we never over ream, but we switch to another type of a nail, probably straight nail. I'm putting this slide here specifically to show that never put the largest rod, because the larger the rod you put, the more it will take the weight bearing and the less stress on the bone. So really you have just to put the smallest one that you can put in the canal. And this rod will need revision because the bone is disappearing. So the surgery, now the standard, we do one side at a time, the right femur and right tibia. 1 week later, we do the other side. Doing the 4 sides in one setting, it's not recommended unless it is really a straightforward rodding. Positioning, as was mentioned in the previous lecture, it's in the semilateral position or supine, and you put a bump, and that's how we take the x-rays using this arm, AP, and lateral. You have to make sure that you have access to the whole bone. The technique of nail insertion, you have antegrade and you have retrograde. And personally, almost all the rodding now, I use a retrograde insertion. And that's what is really recommended by the manufacturer, by Pega. The antegrade insertion, this means that your entry point is at the greater trunk. The deformities have to be mild, otherwise it will be very difficult to introduce your rod through the greater trochanter. Usually using the antegrade, no bone resection is needed. You plan to do all the osteotomies percutaneously, and there is no need to expose the fracture site or the deformity site. Retrograde insertion, we use it, or it's recommended for severe deformities where access to the greater trochanter can be problematic, where you have to do a resection of the bone, where open osteotomies are planned. And as I'm going to show you now, almost all the cases of femoral rodding and tibial rodding, I also use a small plate to control the rotation. That's a severe example of a child. Will forget about the tibial deformities. Dr. Howard will talk about this. If you look at the femoral deformity, the planning, the usual planning, like where is the anatomical axis, where is the apex of the deformity, and then you calculate how much resection of bone you have to do, and how many osteotomies also. So to have a good preoperative drawing like this, knowing what you are going to resect and knowing where the osteotomy is very, very important. And here is your final correction. The antegrade insertion, we mentioned it is percutaneous over the greater trunk. You introduce your nail, and then you complete introduction of the nail. Every time the guide of the nail blocks, then you have to do a percutaneous osteotomy. And the percutaneous osteotomy, here we have done one, we continue, it blocks here, then you do another osteotomy, and first we drill, and then we use an osteotome. And this is truly 1 centimeter incision. Very quickly, that's the female, that's the femur, 2 osteotomies here, that straight. How do you measure the female from the tip of the greater trunk to about 1 centimeter above or proximal to the distal femoral physis? This is the special instrument that we use to cut the female rod. We use here the special type of saw because you want it to glide very well. And there are two things that are very, very important. Number one, which is the purchase of the female rod in the greater trochanter. If you don't see the greater troch, which is very common in these children, you put all the threads of the female up till the bony metaphysis. You don't go through this. That's very important because proximal migration of the female rod is a very common complication. Here, for example, we didn't screw it up. Therefore, proximal migration is very common because there are no threads in the greater trochanter. The second thing also that was mentioned, it was shown also in a most recent publication that if you don't put the male threads in the center of the distal femoral apophysis, then this can bring complication. That's the perfect positioning in the middle of the distal femoral apophysis. All the threads are in, and there are short and long threads. So usually we use the long threads. And this one, obviously, it's a wrong technique. It's a wrong position of the male rod, and most likely will need revision very soon. A quick word about the retrograde insertion, which is used almost all the time here in our institution. If you have a severe femoral deformity like this, to go antegrade, it's very, very difficult. So you do your planning, you plan here one osteotomy. We use the 3D scanning reconstruction and the 3D printing very, very often, almost all the time. And with this slide, this is where you have your apex of the deformity. You can see here the second slide in the middle. You remove your piece of bone, you retrograde, insert the guide wire, and here you do your drilling, and then you insert your male retrograde, and you continue distally the same way as you do for antegrade pinning. Take-home message is to pre-operative planning is extremely, extremely important, and attention to detail is very important. Thank you.
Reggie, thank you for that lovely talk. And I think one of the concerns we always have with femur rodding is the blood loss. And one must be very careful. Your anesthetic colleague must be really vigilant about doing about blood loss. And once the bone is aligned and the rod is inside, suddenly all the bleeding stops. And I think that is why you have to be really quick in doing the rodding. So over to Andrew now. Andrew's going to talk about pre-op planning, surgical technique for the expandable rods and non-expandable rods in the tibia.
Thank you very much for inviting me. I was really looking forward to being in India for this meeting and actually interacting with everybody. POSICON is such a dynamic meeting, and instead I'm sitting in front of my computer and you're all sitting in front of your computer, as we've been doing for the last little while. Well, we will get over this. And my first talk is about planning and technique for the tibia using solid and expanded rods. I'm just going to share my screen here and put the PowerPoint up. So what I think about when I'm planning for the tibia is that we're going to straighten this bone in two planes. I can plan that before, but I need to modify intraoperatively. I may need to shorten the tibia to keep neutral tension on the posterior soft tissues, particularly the vessels. The fibula may need a manual osteoclasis, or it may need an osteotomy of its own. The rod diameter, I can plan preoperatively, but I have to confirm that intraoperatively when I see the exact configuration of the bone. I've been thinking about using smaller rods for the tibia because of the stress shielding with growth that you tend to get. And then we'll talk about cutting the male nail, we'll talk about using the pins for distal fixation, and we'll talk about rotational alignment. So first off, we pre-op plan as we would for any sort of deformity correction, AP and lateral views. This particular tibia I chose because it's got a valgus deformity in two places, as well as sagittal plane deformity in two places. But we know how to plan that and how to make our osteotomies. And here we're clearly going to need two osteotomies, and it's nice that the coras on one plane correspond to the coras on the other plane. But as with every osteogenesis imperfecta osteotomy, what we're going to do is make our plan on the wall and then adjust intraoperatively according to what the K-wire and the drill tell us about how far we can get in each segment. But here I think it's pretty clear we're going to need an intercalary segment and not just a single osteotomy. Sometimes you do need two osteotomies just for a single plane deformity. But when you're looking at this, you look at this and say, is that actually two osteotomies, or am I really going to shorten? And so if you think about the soft tissues at the back of one of these severe deformities, you know, that anterior closing wedge has got to allow the posterior soft tissues to stay at neutral tension. And so I've marked where I think maybe the posterior tibial artery might be on that image, and you can see just how much anterior tibia you have to take away. So in this case, because I'm taking away so much tibia at that apex, I might be making two osteotomies, but only one of them has to heal. That's around an intercalary segment. So that's a pretty severe deformity. But shortening the tibia to prevent the muscle and vessel tension is always a good idea. Here's my little diagram of something that's happened to me intraoperatively a lot of times. That's a cross-section of a tibia. The tibia is not round, it's not even triangular, it's flattened and keel-shaped. And so I may look at the AP and say, oh, it's 6 millimeters wide. I may look at the lateral and say it's even wider, it's 8 millimeters wide, but it's not, that's just projectional. And when I open that bone and make an osteotomy in that tibia, I find out I can only put in a 3 millimeter rod. So I always confirm the rod diameter intraoperatively and have some smaller ones available. I also think a small rod in the tibia is probably better in terms of allowing the bone to load itself afterwards. So this particular rod has been in place for years and years. This girl's a teenager now, but her tibia is barely any bigger than it was when she was a 7-year-old. And that's, I don't think, just OI bone, that's stress shielded OI bone. I mean, it all varies, but I would prefer a little bit more loading of the bone and a little bit less bending loading going through that rod itself. And so I've started to downsize my tibial rods a little bit when I first put them in. The female rod can be cut preoperatively, or it can be cut intraoperatively. And if you're not sure what size it is, it's probably best to cut it intraoperatively, because, you know, once you've cut them preoperatively, they're only good for that patient for that size for that day. If you're doing the second size on a different day, of course. But I find that I can get them cut and polished and gliding just using a high-speed cutting disc and some mechanical tools intraoperatively to polish them. Two different ways of putting the unit of rods in. You can either put the male rod first and put the female rod down across it, or you can insert both rods as a single unit, and that tends to protect the male rod and also protect you from either pushing the male rod too far in with the female or pulling it too far out with the male inserter. So two different ways of doing that. This is something that can be a problem in the tibia. This cutter is quite bulky if you're using this design of rod, and so you have some difficulty getting a short enough cut in a small knee. Now, this is a fairly small knee that we did manage to do as described with the end cutter, but some surgeons prefer to do this in a different way and place the male rod almost all the way down, then make the cut, then advance the male rod with a needle driver or something, and then thread the female over it. So that's a way of avoiding having too much prominent male rod sticking up into the knee. And then this distal fixation can be fairly tenuous with a small number of threads and with that very thin bone in the distal tibial epiphysis. And that's why the little slot was designed to put a K-wire across and through. That's just like playing a video game on the lateral. It's more done by feel than by image intensifier. And if it becomes impossible, you can use a slightly larger K-wire and just jam it against the threads from externally rather than threading it, although those ones they usually take out after the bone is healed and the nail is a bit more secure. And then confirm the rotational alignment. As with everything, that is a clinical view, looking axially down the leg. And I usually control that with a cast rather than plating the tibia, especially for the smaller bones. So it's usually just a rod plus a cast to control the rotational alignment. So in summary, for a primary tibia, straighten the bone in two planes, plan that before and modify it intraoperatively, shorten the tibia as needed for neutral tension on the posterior muscles and vessels. The fibula may need its own osteotomy, or it may just go with a manual osteoclasis. The rod diameter is an intraoperative determination ultimately, and thinking about stress shielding often move down in size rather than up in size. Think about the details of cutting the male nail in the knee. You don't want that interfering, and with a smaller knee, there's less clearance and less room for getting that big device in, and it does leave a small gap. And then think about whether you need to supplement that distal fixation with a pin or not. Confirm the rotational alignment, and if you get it all correct, then your patients will have two legs to stand on rather than just one. Thank you very much. I look forward to questions when we can interact, and I look forward to interaction when we can be in India.
Thank you, Andrew, for that lovely talk and some very practical tips. I will start the ball rolling with one question. Now, sometimes in the tibia, what's your preferred incision for the entry point? But there is sometimes the patella comes in the way, and you can actually score the patella with the rod. So some people prefer using the suprapatellar approach. Do you prefer to retract the patella and then make entry? Any tips on that entry point, which can be very crucial in terms for the male rod cutting?
So that's a good question, and all of my fellows are asking me this now as well. And, it's because our trauma surgeons have decided that the easiest way to get a nail into the tibia is to make that suprapatellar portal. But the fellow who said it best said, all the trauma surgeons love that incision and all the sports surgeons hate it. I think the things that go on behind that patella and in front of that femoral condyle can be a little bit invisible to the operating surgeon's eye, and the operating surgeon is focused on what is going on in the shaft of the tibia. But as somebody who's a little older with knees that hurt anyway, I'm actually quite concerned about what's going on inside that knee where you're not actually seeing all that well. So my strong tendency is to make that medial parapatellar arthrotomy. The first one you make is fairly small. The next one sneaks up a little bit, and you snip, just at the bottom of the bony patella itself so that you can get over there, and you have to clear away a little bit of scar instead of some fat. And then if you're revising it a third time, you may even have to go all the way up the patella to move it out of the way. But it gives you better access to the entry point, that little bare area of the tibial plateau. The nail is starting exactly where you want it. And so I've still been doing that. I acknowledge that some people who are nailing a lot of tibias for trauma, if they're very meticulous, may be able to get it better with a suprapatellar, but I haven't converted to that yet. Reggie, have you converted to that? What are you doing?
Dr. Reggie, your thoughts on that, tibial entry?
Yeah, I've never used the suprapatellar. There is a very recent article that has been published on this. So I just do what Andrew is doing, a medial or a lateral parapatellar. And if I insert it retrograde the guide wire, you have a better controls and it tells you what to do. And regarding cutting the nail, I exactly do the second. Before inserting the nail completely, I cut it and then introduce it manually so that you don't have to struggle to cut the male rod inside.
Hitesh, any questions? Hitesh?
Yeah, Sandeep want to ask anything. First, Sandeep, then I'll ask.
Sandeep?
Yeah, I just wanted to ask Andrew, Excellent talk, by the way. If you have a large procurvatum and when you make your entry, sometimes you end up perforating the posterior cortex because this is not really a healthy bone, and your guide wire may not bounce off and you might end up reaming through the posterior cortex. When you try to do the second pass, you end up going back into the same track. So do you have any tip or any kind of a modification or a trick so that we can avoid going into that posterior perforated cortex?
Sandeep, I think that's that's a very common observation. Once you've got a big breach, it seems to attract any form of wire or any form of drill or whatever. Knowing that it's common, I think the first thing is K-wires are easier to redirect than drills are. And if you think that's the potential, then checking very carefully on the lateral before you ream. The other thing that Reggie mentioned is working retrograde. Retrograde is your friend. Not for the mildest deformities, but as the deformities get bigger and as the bone gets more and more fragile, you can think about placing and doing some of the drilling retrograde, even if you want to go antegrade a small distance to get your entry point precise. And I will work antegrade and retrograde together in the short proximal segment of either a femur or a tibia, because sometimes my retrograde shot is not going to come out far enough anteriorly in the tibia. It's going to come out in the middle of the knee. That's not a good place for the nail, but I'll do most things retrograde so that I avoid that perforation. And then I come down from the top and short drill, short K-wire, and then that retrograde drilled path will take the K-wire down, and then of course I have to refine it with one more drill pass from either way. Knowing where you ran into trouble with the last patient helps you to go slow for the appropriate part of the operation, and some of this is, there are parts of this operation that need to go very slowly. And then, of course, the patient starts bleeding and the anesthesiologist wants you to finish up, and there are parts of it that you can do expeditiously. And it's just, I can't tell you they'll all be easy, Sandeep. I think you've run into some of the same difficulties that we all face.
Jen, do you want to ask some questions?
Just a quick question. We get a lot of patients who have not had any treatment at all. No bisphosphonates, no surgery. I am torn between whether to give them some bisphosphonate and wait, or whether correcting the deformity and giving them some stability and start to weight bear them. What is your current approach, both Andrew and Reggie?
So I've had those sorts of patients, and patients who say immigrate to Canada with severe disease, 6 or 7 years old, never treated, never walked. My approach for that sort of patient is to say 1 year of bisphosphonates. It sounds like a very long time to an orthopedic surgeon. And you have these itchy fingers and thumbs that say, I think I can do this, I think I can do this, I think I can do this. But the degree by which the bone quality will improve with 1 year of treatment is immense. It's night and day. So if the patient and the family can tolerate it, get a year of bisphosphonates in, then do everything fairly quickly within a couple of weeks to get them weight bearing. And for that kind of patient who's never walked, if you have access to a specialized rehabilitation service, the way that you might use after cerebral palsy surgery or something else like that, this has been gold for some of the teenagers with osteogenesis imperfecta. And we even have the luxury of admitting them for short rehabilitation stays under very, very select circumstances. I'm talking about 10% of my patients. But that has been I think the difference between being able to get the advantage of weight bearing and not. If they're a milder patient who's never been treated, surgery first, that's fine. But if they're that very, very depleted bone where the reason that they haven't been weight bearing is that their bone won't actually do it, then I think the surgery would lead to a lot of complications. You'd be off the bisphosphonates because you're waiting for them to heal and so on and so forth. So get them medically treated and just be patient. Reggie, do you do the same thing?
We do the same thing. In fact, when they are seen, I'm talking about the type 3, the severe deformities. So I have to get the okay from the medical team that yes, go ahead with the surgery. I think it's a big mistake to operate on a severe, for example, type 3, if they have never received biphosphonate. I completely agree with you. And in fact, I had several patients that the bone can crumble, like the bone is like cheese. When you go in, the only thing that you want is just leave the operating room as soon as you can. So definitely biphosphonate treatment, and the protocol that we have, it's not followed by everyone, but before the surgery, you can give biphosphonates, no problem. After the surgery, we abstain for about 4 months without biphosphonate, and that seems to work well. But definitely, biphosphonates, should be part, in fact, of the surgical protocol.
Thank you very much. So we can move to the next session, and I think Dr. Reggie is going to speak on the proximal femoral deformity, the neck of femur, I think, which is the Nelson's.
Yes, I will put our talk.
Right. Okay.
So what to do?
You can go live if you want.
Yeah, I will go live.
Right. Okay. Okay. Great.
No, it's not this one. So it's 2. Which one here? Here? Yeah. Okay. Do you see the screen?
No, not yet.
Oh. Okay. Hold on 1 second.
Share screen.
Here. Here.
Share your screen.
2, right? 2. Okay, do you see it?
Yes.
Yes.
Okay, sorry for this. So our second talk will go more into a bit more detail, management of fracture neck femur and proximal femur deformity. No disclosure. So that's what we'll be talking, the predisposing factors for fracture neck femur, the surgical technique, mostly it's undisplaced, and then the proximal femoral deformity, coxa-vara, true and false coxa-vara, and complex deformity. Fracture neck femur, they are not common, but they are not uncommon. And the predisposing factor, we have the bone fragility, obviously, acetabular protrusio, which is present in about 50% of all children with OI, and 70% of type 3 is a definite predisposing factor, as well as coxa-vara. So here, just protrusio, it's a quick mentioning. It's when the femoral head protrudes beyond the ilioischial line, then it is called protrusio. And that's something very common. That's a common, well, I wouldn't say common, but it's a common type of fracture that you can see. The head is almost completely inside the pelvis. It puts a tremendous pressure here, and you have a transverse fracture neck. And this is really most of the fracture that you see in OI is this type of fracture, undisplaced transcervical. Usually it's a minimal trauma. Usually it's undisplaced fracture. Almost always there is already an intramedullary nail inside the canal. Almost always surgical treatment is indicated, and usually we put 2 cannulated screws or rarely DHS. Cases of non-union may develop, but they are not really uncommon. That's a common type, as I mentioned. The femoral head is almost completely inside the canal. There is an FD rod, and there is very little space here to allow any movement. So the surgery itself is the same positioning that we have used before, the supine position. We have to make sure with the C-arm that you visualize completely. We use a lateral approach, guide wires, the 1.6, and most of the time we use a 4.5 cannulated, partially threaded screw and the tension band that we are going to show. So the intraoperative steps, this is the femoral neck fracture transverse here, that's the EP and the lateral. And the first thing, we introduce the first guide wire from lateral, and we introduce it from anterior to posterior. In fact, it's the same technique as we are going to see for coxa-vara. The second wire from posterior to anterior. So it's one in front and one in the back of the already existing FD rod. These are the two guide wire. We ream over them, both of them, and then we introduce the 4.5 cannulated screw. Then what we do, we don't remove the guide wires, but we bend them over the screws, and then to use them really as a tension band that we use in the Coxa-Vara technique. So in that way, we protect the femoral neck, and we protected the femur, and we have the FD that is protecting the whole bone. And that's how we have been treating these fractured neck femur. It's non-weight bearing, no immobilization is needed. Rarely you can develop a non-union of the femoral neck, and we can see here the fracture line, it's almost vertical, which puts it at a mechanical disadvantage. How do we treat this? It's the standard way we treat a non-union of the femur. We use a valgus osteotomy to change the direction of the fracture line, cannulated screws, bone grafting. Some they use locking plate. There is no definite guidelines for non-union. We just have to use our experience with other type of non-union. The second deformity that I would like to talk is the Coxa-Vara, which is present in about 10% of patients with OI. Most of these have already a telescoping rod inside, and the common theory is that it's the insertion of the telescoping rod that is causing weakening of the femoral neck, leading to multiple stress fracture undisplaced that lead to Coxa-Vara. Anything less than 105, 110 degree is considered a Coxa-Vara. So here we'll go, the first thing, very, very important, because that's someone who's the first time who treat this resident or fellow, can be mixed up between a false and a true Coxa-Vara. If you look at this slide on the left completely, we can have a severe deformity of the proximal femur. And on the AP, it looks like this. And if you do a 3D printing, that's the deformity. So is this a true Coxa-Vara, or it is simply a deformity of the proximal femur that is reflecting as a Coxa-Vara? How to differentiate between these two? We have to extend the femur. And this is the 3D printing. If you look at this picture compared to this, when you extend the femur, then you can see the AP, the true AP of the femoral neck. Why is this? Because many deformities of the proximal femur, in fact, almost all of them, have this flexion deformity at the proximal femur, which mimic a Coxa-Vara, but it's not a Coxa-Vara. And this differentiation, it's the first step. It's very important. So you have a Coxa-Vara now, true Coxa-Vara. How do you treat it? You have your FD rod here. You introduce your two guide wire, one on each side of the FD through a lateral approach. You do your subtrochanteric osteotomy. You calculate beforehand how much valgus do you want to correct, and you use your 2K wire as a joystick for this. So here we go from 105 to 135, and you still have your two guide wire here. We remove a piece of bone here from the medial upper cortex of the distal fragment, and you reapproximate the two. You have your FD rod here. In case you have not, you don't have an FD rod, if you look at picture C here, with the drill bit, you drill, but it's in the lateral cortex. It's not here in the canal. You drill through the lateral cortex to obtain the degree of valgus that you are planning. Otherwise, it will be impossible. So after drilling here, you do your joystick. Here you have removed this piece of bone. You put the two bones together, and like any valgus osteotomy, you have to lateralize the femoral shaft. So you have this, and the next step, you bend your 2K wire and you apply your tension band technique. So that's the technique of Coxa-Vara, and it was published before by Fassi and our team, and it's an original modification from a French publication. So here are the intraoperative pictures and AP and the lateral. That's the first K wire that you introduce from AP to posterior. That's the second K-wire. Then that's the site of the subtroch osteotomy that you do. You do your osteotomy, we use the 2K wire as a joystick, and you can see how much translation laterally you have done. You introduce your intramedullary nail or FD rod, if it is not present, through the lateral cortex, as you can see here, and then you bend your K wires, and you have this picture, which is very rigid construct that we have obtained. One last slide on the proximal femoral deformity. As I just mentioned, we use the 3D printing. It's now easy, and there are simple machines to get you the 3D printing. It makes a huge difference in your planning. So that's a patient, if you look at the middle X-ray, that has this very severe deformity of the proximal femur. And that's what I was mentioned, to try to get this anti-grade to the tip of the greater trochanter, it will be extremely different. So what do? We have here your site of non-union. You do your planning. Where is the apex of deformity? And as was mentioned by Andrew before, you have to resect a bone here. It's part of the planning. You resect your bone with a towel clip very gently. You hold the proximal fragment, and after manipulation, correcting the flexion deformity here, you can see that now you have a true AP of your femur. And then you go retrograde. You put your guide wire, you do your drill bit, you put your male rod, and then you do the usual preparation distally, and you insert your FD rod. The last slide, can the patient be unlucky, and can he have both a proximal femoral deformity and a coxavara together? And the answer is yes. That's a child that was treated a few years ago with elastic nail, and you can see he developed both a coxavara and a proximal deformity. And if you do your planning, there are two apical deformities that you can see. How do we treat this? That's the initial patient. So the first thing, we corrected the proximal femoral deformity with an osteotomy and your FD rod. And then at the second stage, or the same stage if you want, you correct the coxavara. I would recommend both stages, otherwise you may have to deal with two osteotomies near each other. So the take-home message is, again, you need to do a detailed analysis of the deformity. You have to differentiate true from a false coxavara. And again, I very strongly recommend the retrograde insertion. The more retrograde insertion that you do, the more that you will love this retrograde insertion. Thank you.
Thank you very much, Dr. Reggie. And we move to the next talk by Andrew on complications of expandable rods.
Yes, so we will talk about this now, and then I will talk about this.
Good evening again. Complications are part of operating on patients with osteogenesis imperfecta. So let's spend a few minutes talking about complications of expandable and non-expanding rods. To summarize, complications and revisions are going to be part of what you're doing if you're going to be operating on patients with osteogenesis imperfecta, but complication and revision rates are going to be lower, a little bit lower, if you use elongating rods compared with static rods. The complications we'll talk about are rod migration, rod perforation, fractures, rotational malunion, growth arrests, and heterotopic bone. And I'll be giving examples and talking a little bit about how to prevent and how to treat. First, we did do a literature review and try and put together, with a meta-analysis, everything that we could find out about the comparison of complications between patients treated with an elongating rod and a non-elongating rod. On the one hand, an elongating rod should last longer because it accounts for growth. On the other hand, it's a more complicated device. You've got one moving part, and so 10 more different ways that things can actually go wrong. How does that balance out in the real world? Well, there are a lot of comparative papers in the literature, and if we combine all of the comparative papers in a meta-analysis, you can see that the overall complications are lower for elongating rods compared with non-elongating rods. And also the reoperation rates per year of rod in are lower and sometimes significantly lower for the elongating rods rather than the non-elongating rods. And this is true for the various generations of elongating rods, but the most recent generation, the Fassier-Duval rod, has probably the lowest reoperation rates compared with the non-elongating rods, and it's a simpler design with less to go wrong than the older designs of Bailey-Debeau and of Sheffield types of rods. So we know the reoperation rate is lower if we use elongating rods, but what is the reoperation rate? And again, combining the available data from all the papers in the literature, we saw that you can expect a reoperation rate per year of something between 6% and 9% if you're using elongating rods for patients with osteogenesis imperfecta. And other than a few outliers in the series, that revision rate is fairly similar, irrespective of which generation of elongating rod you're using. So expect a 6% to 9% chance per year that you'll have to do a revision, and recognize that if you're using a non-elongating rod, slightly higher rate of revisions and slightly higher rate of complications over time compared with using elongating rods. Rod migration, by that I'm referring to it doesn't stay where you put it. It's actually fairly common. I would say about a quarter of the rods will eventually grow away from the epiphysis, distal epiphysis of the tibia, weakest bone, smallest number of threads, most common place for that to happen, but it will happen anywhere. Biologically, keeping the bone in good shape with medical treatment, with weight bearing is important. You can add some K-wires to anchor. And in terms of treating this, you can tolerate it if you've got an intact bone that is straight, that doesn't have protruding implants, and that's comfortable, because you can't actually make that patient better. You can just make their x-rays look different, but you may need to revise it if the bone is too crooked, or if the rod's sticking out, or if it's becoming symptomatic. Other forms of rod migration here, femoral rod, this patient has grown off very considerably. We're tolerating this one because that distal end of the metaphysis with good bisphosphonate treatment is going to be fairly strong and is going to stay fairly straight, but you can see that this patient has been revised for other reasons. So rod perforation is what I talk about when the rod starts out in the trochanter and in the bone, and after a number of years, has the bone moved or has the rod moved? But this has happened gradually. It's failed gradually into varus. It's still an intact bone that moves as a single unit, but now the rod has completely migrated outside it. The prevention, again, can be thought of as biological optimization, weight-bearing medical treatment, and mechanical optimization, which I don't think you can do with a straight rod. I don't think a straight rod in a femur is actually biomechanically natural. You're always in some varus if you put a straight rod through the trochanter, and so you're always going to have that varus ligates varus. Again, do you tolerate this or do you revise it? It depends on what it means to the patient, but at a certain point, this is going to collapse and be painful, and you're going to end up revising that sort of rod perforation. The rod can perforate into the joint as well. This is obviously not a good situation for the knee, and this is an old example, but revising that to something that's going to have a better grip in the epiphysis is probably a good idea. Fractures, the prevention is again biological plus mechanical, but you will see patients come in with acute fractures. This is an example in a femur or in a tibia, and the treatment here is to straighten the bone and revise the rod if you've got a displaced acute fracture, because that's just going to keep happening in the same place. These sorts of fractures are the sorts of fractures that I will leave alone. We wrote these up as atypical femoral fractures because they look like the atypical femoral fractures that older people with osteoporosis get. And these will actually appear spontaneously and also heal spontaneously in the subtrochanteric region of the femur as long as the rod has remained straight. And those often don't present as an acute fracture. They may, or they may just present as a radiographic finding. Rotational malunion, prevented by inspecting carefully intraoperatively, comparing to the other leg and using either a cast or a little plate to control the rotation. If you do see a rotational malunion, that can be treated conservatively, or you can decide to revise it with an osteotomy. And if you're doing that, then controlling the rotation with a plate is probably a good idea. I've only got one example of a growth arrest, and it was in this situation where there was obviously a fair amount of motion with this failed rod construct that had protruded proximally. And I think it's this motion at the upper site that traumatizes the growth plate. I've not seen a growth arrest with a static rod in a growth plate, but I'd be happy for people to send those to me because I'd like to see them. We did shorten that to a non-elongating rod and get the metal away from the growth plate, and then did a CT scan and demonstrated that particular bar there. And in this case, a physiolysis was attempted and was successful, just due to the age of the patient. But of course, with an older patient, you could just fuse that. Heterotopic bone is particular to some genetic subtypes of osteogenesis imperfecta. So the IFITM5, the so-called OI type 5 people, were the first group that this was described in, but this particular patient with a similar amount of heterotopic bone is actually a SERPIN gene patient, and I find that they're also susceptible. Anything with heterotopic bone, I think, is about soft tissue handling. And to me, you know, this is where the surgeon's fingers were when the surgeon was doing something clever with this. And so the surgeon needs to be very gentle with that muscle if they want it not to turn into bone, and treat it with NSAIDs either prophylactically or if it gets into one of these very inflammatory phases. So complications and revisions are going to be part of OI surgery. Complication and revision rates are lower with elongating rods. The complications we've talked about are migration, perforation, fractures, rotational malunions, growth arrests, which are rare, and heterotopic bone, which accounts for certain subtypes of osteogenesis imperfecta, but not the usual collagen types. And remember, you know, sometimes their bark is worse than their bite, and they're all part of the way that osteogenesis imperfecta is going to naturally unfold. Thank you for your attention.
Thank you, Andrew. And I think the next topic is going to be on revision rodding of the femur. Now, revision rodding is part of OI. And I think we must counsel our patients that this is not one-time surgery. As they grow older, they will need rod revision, and that should be considered as part of the ongoing treatment. So over to Dr. Reggie on your experience of revision rodding of the femur.
Yes, I'm coming. Yeah. Okay, do you see it?
Yes.
Okay, thank you. So there is quite a duplication between this talk and Andrew talk. Probably we were given both talks just to show the importance of the revision rodding. 1 second. Okay, so the most important thing I will mention here is, can we identify some risk factors leading to failure of revision? And if we can we decrease the incidence of these revision? So that was mentioned quickly by Andrew again. The average survival rate for the facile duval telescopic rod is about 3 to 5 years, We have patients who have 10 years. That's where we started the fasciival here. The average, however, is 3 to 5 years. And it would be good, what I tell here, all the families and the parents, that most likely within 5 years we need a revision. About 50% of all the telescoping rod will need a revision at one point. And as was mentioned also, all telescoping rod have complications. Some have less than the other ones, but all have complications. So the causes of revision femur rodding, and these have been reported several times. We have the implant-related failures, and that include bending, breaking, pull-out, stopped telescoping, or proximal and distal migration. I put the bending here in red because we know now, and there have been articles on this, is that once the rod starts bending, really it should be revised. Because if there is a bending at the rod, this means that there will be no more telescoping. If there is no more telescoping, this means that the rod will pull out either proximally or distally. And once they pull out, they expose the part of the bone that is not protected by the rod to fracture. So bending of a rod is just have a red light to consider revision. The second big cause, it's bone-related failure. Like we have fractures, non-union at the osteotomy side. Sometimes it's simply weak bone that you cannot do anything, and there is no really strong anchoring, like a popcorn, for example, appearance of the rod. So these are related to the bone. Then we have the iatrogenic, like it's our mistake, the surgeon mistake, wrong placement of the distal mill thread in the distal femoral epiphysis. And we have seen that that should be in the center of the femoral epiphysis. Wrong placements of the proximal part in the greater trochanteric area. If we are not really careful about the size and the length of the rod, or if we do too much dissection of stripping of the periosteum or a rough handling of the bone, that can lead to non-union or delayed union. And that's one of the main reasons we switch to the percutaneous osteotomies whenever it is possible. The other thing that have been identified, a patient who is not walking, severe deformity, and then you straighten the bones and you put the rod, and they are on biphosphonate treatment, their bone density increases, then they are more active. It increases their motivation to be active, and being more active, it exposes them to more fractures. And the other thing is they can also, the male and the female component can be disengaged. The rod came at the end of its life, and both of the rods have disengaged. What to do also. So these are these cover most of the causes of failure. The big challenge is, can we identify these or any one of these before really they become a catastrophic failure? And by catastrophic failure, I mean that a rod bends or fractures, and then you have to change it. Because what we started to do, and that I would stress this point, is that once the rod have disengaged about 50 to 75%, even if the rod is straight, we will revise it, because it's much easier to do a revision on a rod that is straight and the bone that is straight than a revision on a bent or fractured bone. I will go through some cases that will really show proof what I'm saying. This is a 7 months old, started to fracture, developed here in non-union. She was too small for rodding. Finally, we did a rodding at the age of 23 months. As you can see, it looks a very nice X-ray. However, there is still this persistent non-union. Many non-union in OI are asymptomatic. So we really didn't do anything. At the age of 3 years, continue to distract or to telescope that you can see here. But still, the non-union, even though asymptomatic, we said, oh, okay, we'll just follow. And what happened is this, a complete fracture. That's quite unusual to have both the male and the female. And by the way, the male rod stops here. So that's what happens because there was a persistent non-union for 3 years and nothing was done. And obviously here it needed a revision. And there was one question from the floor, what do you do to control rotation stability? Now we do it, I do it routinely, is to add a small plate. That's a 2.7 screw. Most of the time it's unicortical screws. It was described originally by Richard Cruz from the Nemours Clinic to add this small plate just for rotational stability. And then it should be removed once there is fusion. I find that it's a beautiful thing to add. The only thing is that you have to open it and do it. But I strongly recommend it. So to go back, what was done wrong? I think it's here. If you look at this X-ray, when we put the FD rod, while there was a non-union that persisted probably since birth, we should have added here a small plate or make it stronger, but nothing was done. And then finally, there was this catastrophic failure. The second thing that I want to show, that's a rod that was inserted an FD, beautiful picture. Then you have this, it's almost perfect. The only thing is that if you can see the male from the female, it's almost disinserted completely. Now we know from our experience that we revise that rod. I know that some people will not agree on this, but here it's a straightforward revision just from here, the small incision, and you don't need to do any osteotomy. What happened, we kept observing the patient. Now we have two risk factors here together. The first one is that the rod distracted almost completely, and you can see here the contrast between the male and female, that the male rod is just here. And on top of this, we get a fracture minimally displaced at the subtrochanteric area, which is very, very common because that's on the tension side. So what was done here, again, there was a mistake, is that we addressed one of the risk factors only, is that I put a plate here, a small plate, hoping that the non-union will heal. However, I did not change the rod. And in retrospect, that's probably what should have been done. Oops. So what happened is that simply this, despite the presence of the plate, that was a very, very weak area at the junction of the male-female when there is almost no male rod. And that's end up with a complete fracture that we have to revise to a solid nail because the patient was near or almost skeletal maturity. So we put a solid gap nail. So the lesson from here also that that's a case, that's a case 3. The third case, if you have a similar thing, and if you have a undisplaced fracture that happened at the junction of the male-female, it's almost an emergency. And you should revise the rod before this happens ultimately. Do not wait, and you should not say, oh, the patient is asymptomatic, is doing well. Case 4, we have here 2 complications. The first one was the proximal migration of the female component, simply because it was not inserted well into the greater trach. The rod stopped telescoping. As I mentioned, once it starts telescoping, then the bone distal to this is unprotected. And what happened, it breaks through the cortex because there is no protection here. Could this have been prevented or delayed? Yes. First, it's a good insertion of the female component, and the same thing, it was inserted peripherally. So obviously that what will happen. And revision of the rod once you have diagnosed this complication. The case 5, we have several complications here. Coxavara that developed, the rod was too large, there was proximal migration. So what was done is we revised the rod, but to a smaller one. Can you revise to a smaller? Yes, you can. And that's what was done here, simply to offer more stresses to the bone. And the last case that we see this very often, and there was a question on this, if the bone stopped telescoping, what do we do? Do we put a straight rod? Do we put a solid rod? What do we do? Very often we say, well, the patient is completely symptomatic, the bone is straight, just leave it in place. Our recommendation is that change it to a solid rod and you leave the patient with the protection of this solid rod. Thank you. Oh, I have this. It's the same thing. So my last slide is, can we identify the risks? And these are the things in red. That's the first slide that we saw. There are things that you cannot do anything. The other things in red, yes. Correct technique, correct placement of the male and the female rod. And number 6, once there is a disengagement of the male, revise it. Once there is a bent rod, also revise it. Thank you.
Thank you, Dr. Reggie. And I think the next talk is by Andrew on revision of tibial rods. Over to you, Andrew.
So we've rodded the tibia. We know we get complications. So we're going to now have to work out how to do a revision rodding of the tibia. We'll take a look at this presentation in order to go through some of the things that I think about. The main thing about revising any sort of rod is to plan for the rod extraction and also to have a backup plan for how to get the rod out if plan A doesn't work. The osteotomy to rectify the tibia is straightforward, just the same as with a primary, and sometimes you'll use an elongating rod the majority of the time for a revision, but there are some situations where you may choose a non-elongating rod. So how can you extract a rod? Well, this one here is offering itself up, as they sometimes do from the tibia, and that one isn't going to require a whole lot of planning. But if you think about it, you can go antegrade. You often need a drill to get down to the proximal end of the female rod. You may need some trocars to get around the male rod in particular in order to get the extraction set in. If you're not able to do everything antegrade, you may require an osteotomy, and you can select your level of osteotomy so that you can take out the rods intact, or so that you can cut and replace the rods, depending on what your anatomy is. You may be able to reach a protruding nail and leave the tibia intact. So this one here is a good example of that, but there are others coming up. Or you may be able to access the rod through a bone window and still leave the tibia intact. So there are a lot of different ways of getting a rod out. Here's one that's going to be a little bit more difficult. We can't get conveniently to the top end, and there's no need for an osteotomy here because this is a straight bone. And in fact, this is one of the few examples I've got of a rod with some inflammation or low-grade infection around it. And so what we want to do is ideally get the rod out by leaving the bone intact. So that's where this bone window technique can come in. And here we do have a distal window near where we had some inflammatory process. And by expanding that window, we were able to tap the female rod up until it was accessible from the top, and then use a straight shot with a nail extractor to get the rest of the nail out to the top end. So there are all kinds of ways of wiggling a rod out, even if it's in the middle of bone, and sometimes working through a window is the correct way if you want to keep the bone straight and intact. Most often you're going to want an osteotomy at some stage, and you're going to work through that instead. Here is an atypical direction for the rod to be sitting. Usually the rod is protruding anteriorly, but this one is protruding almost in the midline posteriorly. Well, plan A was to reach behind and see if we could dissect around there. But recognizing that we're going to have to rectify this bone, we need an osteotomy somewhere, and an osteotomy is going to actually bring that rod into much easier access just by tipping the tibia forwards. And that's what we ended up doing in this case in order to revise that one. Here is a bent rod with an acute fracture. And extracting a bent rod is a little bit more difficult. Really, your options are either to straighten it, which works, or to cut it, which also works. And I will gently try and straighten it first, and that was successful in this case. I don't think we got the female completely straight, but because we're working through a little crack here, there's just enough wiggle room to get that out. And because it's bent, the female is often fused to the male. And so if you take the female out, the male kind of comes with it. And here we didn't have to complete this osteotomy in order to access this bent rod from the top, just with a little bit of gentle unbending. But plan B is going to be to exaggerate that deformity, turn it into a fracture, and cut the rod, and then take them out separately. The osteotomy is as you would plan any other osteotomy, the same way as you plan it for a primary. Think about both planes, but most often it's recurrent anterior bowing, and most often with a tibial revision, you're just doing a single cut in a single place. I threw this one in for the planning because I think this is the most trivial of the rod removal. Here you just shake the patient upside down and those little rods will fall out. So there's the result of that osteotomy and revision. And again, we're talking about the male cutter coming very close here so that we can keep those ends short inside this very small knee. Elongating rods, really for most cases in my practice. The static rod has, I think, 2 indications. One is we're at the end of growth. And so here's a girl who is 15 and whose growth plates are all but closed at the time that we do the surgery. She doesn't need an elongating rod, and I tend to use a static rod with a threaded end for a little bit more immediate stability. The other reason for using a static rod is if I want to be away from the growth plate and not crossing this growth plate. And I think I showed this in the complications talk as well. This one is the only one that I've seen with a growth arrest. And so we used a static rod just to stay away. Recognizing that there are all kinds of different ways of actually getting the rod out, what tools do you have on hand? Well, I think probably way more than half of the rods I've ever taken out have been taken out with just a simple heavy needle driver, whether it's the female rod or the male rod. This is actually the workhorse of getting those rods out. Sometimes you need to cut them, again, with a fancy tool or with a simple tool, and then use this to get them out. But other times you're very happy to have the extraction set on hand. And I really do like using this tool when it is indicated. This allows you to leave much more bone intact if you've got a straight shot at a male for a more straightforward revision. So have plenty on hand, plan A and a backup plan. The osteotomy is planned exactly the same way. And the implant choice is typically elongating in my hands, but can be non-elongating if you either got a mature patient or a growth plate that you wanted to protect. So go ahead and make as many things perfectly straight as you want to, and nature will go ahead and make as many bends or double bends as nature wants to make, and for whatever nature's purposes are. Thank you very much for listening. It's been a pleasure doing this virtually, but I can tell you it would be even more enjoyable to actually come and see you all. We'll have a little interaction over the Zoom soon.
Thank you, Andrew. And I just have a couple of questions before anybody else wants to ask. So one is there any role of prophylactic tibial rodding as well as prophylactic neck fixation, knowing the fact that these children, when they become older, they may come with stress fractures? So when you're doing rodding for, say, a child of 10 or 12, for the femur, would you prophylactically fix the neck of femur and the tibia? And the second question is, all of us are not very technically proficient. Sometimes we may perforate the cortex or we may cause some complication. Do you keep allograft handy? Because I find sometimes that the distal femur is really ballooned up and I pack them with allograft. So any tips on using allograft in your own practice, Dr. Reggie, and then Dr. Andrew?
For cortical perforation, as you mentioned, no. Have I used allograft, specifically the DBM, in cases of non-union or defects of bone? Yes. And specifically, we have cases everywhere where bone cysts, especially in the proximal femur. So whenever we do a initial rodding or revision, I always fill with the allograft demineralized bone matrix as a routine. And as I mentioned, in non-union, it should be used, but only for perforation of the cortex, no.
All right, okay.
And to answer, sorry, to finish your question also, prophylactic pinning of the femoral neck in adolescents, if you do a revision of this, yes, we do it. Do the Coxa-Vara technique, like the two guide wires, tension, band, yes, we do it. Thank you.
All right. What about tibial rodding? Do you do it prophylactic when you're doing the femur? Would you put a rod in the tibia when it's straight?
No, when it is straight and no fractures, we don't do the tibial rodding as a routine.
What about Andrew? Andrew, do you follow something different or the same principle?
No, I tend to divide the patients into deforming osteogenesis imperfecta and non-deforming osteogenesis imperfecta, or you can think about, maybe type 3 and then maybe everybody else. But this is a difficult classification. All the classifications are difficult because very good medical treatment will take what would have been a very severe phenotype and turn it into a much milder phenotype. And what I would say over the years, I've collected a few examples of people whose only bad tibia is the one that I operated on. I might have rodded it for a fracture with a growing rod, and then that side has the stress shielding, that side has the complications, that side has the pain, that side has the repeated fractures that develop in the middle and plague you. And you're looking at a perfectly normal tibia on the contralateral side that is straight and is strong and has better bone biology because it doesn't have the stress shielding. And having seen 2 or 3 patients like that, and just with my general, thoughts that I can't make an asymptomatic patient better, and that there aren't a whole lot of operations that come at 0 cost of complications, especially in osteogenesis imperfecta. I like to know that the patient is actually having a problem, and I like to know that my anatomical maneuver will solve that problem. And that very much sets a threshold for anything that you might consider prophylaxis. And then I think it's hugely challenging to incorporate, the wisdom that you hear from people like Reggie about the proximal femur. The proximal femur still plagues me, I still look at it and say, what am I really supposed to do here? And some of those patients are difficult because the biology of the bone is difficult, and the more you revise them, the less you're working with, the more you treat them, the more it's this very brittle China cup stuff. So less is more, but once you start going, you'll still find some difficulties with any of these patients. And I think that's normal for OI.
The one more challenge which I face is when we try to revise these rods. So sometimes you have an internal kind of cortical formation, cortical bridge formation within the medullary cavity. And the real challenge is to find the true cavity and not the rod entering the wrong part of channel of the bone. And especially when we're revising the solid nail to a telescopic nail. And in our practice where children really don't follow up until they have a complication. And when you try and revise this, there is always an internal cortical bridge or internal cortical sclerosis. Any tips on kind of breaking that? Do you have any special tools for that, so that the rod can be placed more central in the native canal?
I use cannulated drills in that circumstance, and sometimes you're looking at it and you say, I'm leaving the rod in as a blocker, or putting the rod back in as a blocker, and I'm working through the osteotomy and using a combination of retrograde plus antegrade, and then a cannulated drill to start the thing exactly where you want it, and a K-wire that goes up first with a blocking rod where it's still polite, and then eventually there's probably somewhere that the blocking rod has to come out and you have to replace those things. So, but those are individual problems to solve, and I think the retrograde antegrade technique is the way to do it.
Any tips, Dr. Reggie, on that, on the internal corticalization?
I did understand the last thing, but I completely agree. A combination of retrograde and antegrade, and that you will develop your own experience. And the other thing also that I learned is that at some time, number one, you cannot open the canal simply because there is no canal. So you have to make a small canal, whether the tibia that is completely flat or the femur. The second thing, introduction of guide wire, very often it's not helpful because it's bending. So I use the drill, which is a solid drill, whether cannulated or not, and I use it to open and direct me the canal. It's a bit dangerous. You have to go slow because you can easily perforate the cortex. So you have to use your CR, both AP and lateral. But drilling and preparing the bone with a solid drill, I find it very, very useful. And the other thing also, Andrew mentioned, we are using now blocking screws more and more in the femur, as you do it for limb deformity correction and acute correction. And it will guide your drill, your guide wire, and the insertion of the nail. So these are small tricks that you learn as you are going.
Right. Any questions, Hitesh, from your end?
Yeah, I have a question, both of you, because you both told that medical treatment, you are not following the holiday for the medical treatment. Would you consider for the non-union or atypical non-union because of the bisphosphonate treatment?
Well, I can say quickly, the atypical fractured femur, we don't see it usually said in children. In OI, yes, it's the subtroch area. The indication for biphosphonate treatment, again, it should be with discussion with the medical team, and it depends on the bone mineral density, the vertebral fractures, the pain. Yes, these are indication. And as Andrew mentioned also, very often you can continue with low doses of biphosphonate till skeletal maturity. Whether you take a holiday break or not, that's a new development coming from the medical team. But personally, I would prefer to continue with low doses of biphosphonate treatment.
I would say that, we used to talk about drug holidays much more, maybe 5 or 10 years ago. I think we probably need a few more meetings with the people who are very close to us, our colleagues from Montreal, because, some of our patients go back and forth, some of the ideas go back and forth. But we are more inclined to do continual treatment, but just adjusting the dose. And the endocrinologists talk about a treatment dose, a maintenance dose, a half maintenance dose. And I've posted something in a Word document in the chat here that you can download. Don't take any dosing guidelines as some kind of as some kind of truth. Just take them as what they say is a guideline. But that's what our endocrinologist does, and she's given you a few other things in terms of what she looks at for kidney function and everything else before doing it, and how to optimize with the vitamin D and the activated vitamin D, and look at the calciums and so forth. So there's a little Word document that helps you with that. I don't stop them ever. And if they have one of these biological and mechanical in combination delayed union, non-union, chronic non-union things, we ask the medics to optimize. We ask the patient to optimize, which means walking on it. And biomechanically, if it's a little bit bent, you have to straighten it. If it's perfectly straight, you don't have to. But if it's a little bit bent, you have to straighten it. And then you have to think about, do I want more metal or less metal? Those are really the only decisions that an orthopedic surgeon can make. And it took me a little while to come around to thinking, maybe I really want less metal here. Maybe I want less stress shielding with a straight rod and actually make this patient weight bear with good drugs. But you may heal one and another one shows up in the same patient 2 centimeters away. And we've seen that many times.
One last word, which was mentioned many, many times. If the rod is bent, Don't wait, change it.
Right. So with that, I think we, Hitesh, you have a question, Hitesh?
For the Dr. Raggi, that you have said a couple of things for coxa vara and protrusio. Can we prevent protrusio, and what will it do for the treatment of protrusio? That's a very burning question.
I read this question. I did not answer because I do not have an answer. I don't know. I am not aware of anything that can be done for protrusio, unfortunately. And I keep asking my colleague, my other colleagues, my total joint arthroplasty, they don't have an answer. I don't know if in Toronto they have an answer.
It's the same answer. I don't think there's anything you can do with that acetabulum. And we mumble something about medical optimization, but I don't think that there's a surgical adjunct.
What we see in a long term, the OI type 3 may have few issue, and they may lose the ambulatory capacity in a type 3 particularly. That's very severe one. Because
but one thing to finish here, you will be surprised how this the protrusio acetabuli does not affect really the whole thing. And few of them have a fracture, not all of them. It's very common in OI, but fracture neck femur are not as common as this. So surprisingly, it looks horrible or catastrophic on the X-ray, but it does not reflect really clinically. I don't know if that was your impression, Andrew, also.
Yeah, I think losing ambulatory capacity, Hitesh has mentioned, and this is the same discussion that we have with all sorts of parents with all sorts of children who have significant disabilities, whether they come primarily from the musculoskeletal system or whether they are neurological in their origin. You go down and look at a group of 8-year-olds outside of school and they're climbing all over the things. 16-year-olds don't do that, right? You sort of hit your peak mobility around 8 or 10, and then it's going to go down in terms of how much and how often and how far and power to weight and all of those sorts of things. It's still worth being able to stand up when you're an adult. It's still worth being able to take a few steps in your kitchen, in your bathroom, in the household as a sort of a minimum. And if the parents understand that, attaining a peak in order to maintain the highest plateau, but that for most people with disabilities, walking is not their number one aim. Yeah. And walking is kind of used as a surrogate. Oh, how early did he walk? It's a surrogate for gross motor, which is a surrogate for how is his brain. These kids with OI have a fine brain. The walking is a way of helping them in the world, and it's a way of maximizing the plateau they get for adult function, irrespective of what nature gave them as a set point. And then if the parents and the surgeon can help them to elevate that set point as high as it can be, we've done our job, and the child will be happy.
Thank you. So that we move to the next talk by Dr. Reggie, and that is on management of fractures and deformities of the upper limb. Again, a huge challenge in these patients. Yeah.
Yeah. What do we do? 4. Yeah. 4 here. 4. Yeah. You see that? Okay. Do you see?
Not yet.
Okay. Here.
No. Yes.
Okay.
Okay.
Thanks. So we are here in another very interesting session. Just one word on upper limb function as the continuation of what Andrew was just saying. In many musculoskeletal conditions and other conditions, really the main determinant of quality of life is upper limb function. It's not lower limb function. So just to put this on the background. And a background is that for so many years, we have almost neglected deformities in children with OI. And you are simply saying, oh, that's not important. It's not weight bearing. Who cares about this? But more and more, we are now really recognizing and realizing that upper limb function is extremely important. And if you improve the deformities and correct them, you are improving the quality of life. So I will just go this. So the impact of upper limb deformities on function quality of life has been reported in at least 2 excellent studies. We are going to go through humerus deformity forearm and then few things about fractures. So the impact of upper limb deformities, whether in the humerus or forearm, it's not only a cosmetic problem. That's now well recognized, but they significantly impair functional activity of daily living. Realignment and rodding decreases the fracture rate, and it's definitely indicated if these deformities affect the function, it is recommended to correct them. And these are 2 studies, one of them most recently from Richard Cruz team at the Nemours Clinic. What are the options do we have? Conservative treatment, well, forget about it, because we know fractures, for example, will not remodel in children with OI. So the surgical treatment, and what are the options? We have the non-telescoping rod, K-wires and slim nails, or rush rod, and that's mostly in the forearm, because as a rule, we don't use telescoping rod in the forearm. We have the elastic nails, and then we have the telescopic approach that I will mention for deformities of the humerus. And again, it's both the antegrade and the retrograde approach. Something that I want you to pay some attention is the presence or absence of a varus deformity of this distal humerus. If you look at this humerus, an OI, there is a fracture here, and the distal humerus looks normal. In all these, which are pre-existing deformity, there is a varus deformity of the distal humerus, which is very common in many children with OI. You can see here one, you can see one here. Why is it so important to recognize this? Because if there is a varus deformity of the distal humerus, then you can put a retrograde insertion of straight nail or a retrograde insertion of a telescopic nail. If you don't have this varus deformity, then you will have to go antegrade. So having said this, we have 2 techniques, antegrade and retrograde. Antegrade insertion, it was and is still the main approach for putting a telescopic nail in the humerus. However, you have to go through the rotator cuff, and obviously it's causing injury to the rotator cuff. Therefore, now our approach is that we try to avoid as much as possible going anterior. If we can put an FD through a retrograde approach and there is a varus deformity, that's what we do. And I will show this in 1 second. The retrograde insertion is obviously ideal for elastic nails, like any fracture humerus that you want to treat in this way. However, you have to have this varus deformity, as I just mentioned. So we'll go through a few examples. That's a 7-year-old type 1 on biphosphonate therapy. It's the 3rd fracture that she has. So it was decided finally that we have to rod this. What type of rod can you put here? You reduce, number 1, the fracture, and then we decided to go retrograde insertion. This retrograde can go, you can use anything. You can use elastic nail or you put a solid nail. We used an elastic nail, which is standard approach, like using any fracture that we have. And it's a beautiful healing here with the callus. Humeral fracture in diaphysis and upper heel superbly. It's the distal third of the humerus that is notorious for delayed union and non-union. So the first thing, fractured humerus in an OI, you can just go with elastic nailing. What about non-union now? That's a non-union that developed in the distal third. And as I just mentioned, it's a very notorious place for development of non-union in OI because fixation is not easy. What was done in that case, the non-union was exposed, it was debrided, bone grafting. We put a slim nail, which is one type of solid nail. I really like it because it anchors the proximal part in the bone. And then, as I mentioned also, I always put now a small plate. It's a 2.7 plate. You can go unicortical, you can go bicortical, but it controls the rotation, and in that case is healed. So non-union of the humerus, you need stability, you need bone grafting. Even if it's a hypertrophic one, I would put a bone grafting. The third case now that we commonly see, deformity of the humerus. You do your pre-plan. Number one, does it need to be rodded? And if it affects function, definitely. How? Ideally, it should be an FD nail. And what is the standard in most centers up till now? It is still an anti-grade insertion of the FD. You calculate, you do your anatomical axis. These are the apical deformity. This means 2 osteotomies here. Obviously, you have to be careful about the radial nerve, and you put your FD insertion through the rotator cuff. You can insert male and then female, or as Andrew mentioned, you can insert both the male and the female at the same time. And here we needed 2 osteotomy. It healed nicely. That's a beautiful result, except that it goes through the rotator cuff. What we have been doing recently is a retrograde insertion of the FD. A case like this, there is a severe varus deformity of the distal humerus. You calculate your apex of the deformity, you do your osteotomy, and a retrograde insertion of guide wire. Another osteotomy was done here. You do your drilling retrograde, insertion of the male, insertion of the female, all retrograde. You don't go through the rotator cuff, you don't touch it, therefore it should give good result. There is a small bump here. We try to insert it as much as we can. Initial results in these techniques are excellent. One word about complication, like the femur, like the tibia, everything is possible. And the message here again is once the rod, telescoping rod stops telescoping, then it will not telescope and it will cause problem distally. Therefore, you have to do a revision of this rod. I will not go through the technique simply because of time. Forearm deformities, the same thing. Correction of forearm deformity, it's much, much more complex. We don't use telescoping rod. We expose the fracture site, we correct deformity as much as we can, and we introduce simply K wires. That's the most commonly used. However, the failure rate is huge. That's 3 years afterwards. And this is a common appearance after correction of forearm deformity. It's complex, a high failure rate. The answer, what to do, there are no definite guidelines regarding this, except that severe correction of deformities can help. That's how we show it as my last slide. A fracture olecranon, transverse fracture olecranon, typical in OI children. Do you do a tension band wiring or do you put a screw? The answer was by these people, they answered it, they compared both groups, tension band wiring 100% success rate, while screw 50%, therefore the message, use a tension band technique. So to summarize, severe upper limb deformity have a negative impact on function. Consider retrograde insertion of in the humerus if it is possible, and the correction of upper limb deformity has a positive effect, and don't hesitate to do them. Thank you.
Thank you, Dr. Reggie. And I think next is my talk on the Indian experience of OI, and it has been really a journey over the last 15 years. I remember when I was doing my fellowship in Toronto, I was working with Bill Cole, and at that time I saw OI patient being treated with the Williams rod, and that was my first experience using the Williams rod. I'd seen a couple of Sheffield rods when I was in the UK, and then when I came back to India, we started the OI clinic, and over the years we've been using various techniques. So we have huge challenges in terms of patient presentation, and I will just share our experience over the last few years. So I think this is a recorded talk and I can take questions later on. the management of osteogenesis imperfecta, our experience. The presentation of OI is highly variable. We get children and newborn where we can do a genetic testing, as well as children coming at adolescent where they've had no treatment and present to us with severe deformities and everything else in between. Despite these terrible looking x-rays, the children are always very cheerful, and this really motivates us to correct the deformity and try and achieve some function, either ambulation or improving the mobility. We also see a lot of variability in fixation. So we see solid nails, flexible nails, Ender's nails, rushed rods and plates. At the same time, we see a lot of innovation in fixation, like this child underwent surgery at a different center using rushed rod, which were inverted in the femur and put anterior in the tibia. Anything that aligns the bone and prevent refractures is the key to the success of osteogenesis imperfecta. So we looked at our own data of 34 children. There were 30 patient femur fractures, 24 tibia, 8 in the humeri. The mean age of 12.6 years, 18 boys and 16 girls. Four types were mainly severe to moderately severe, type 3 and 4 with 8 mild. To assess ambulation, we have used the Hofer and the Bullock grading system, where grade 1 is community ambulation and grade 6 is recumbent. A is without aids and B is with some kind of walking aid. We also assess the muscle power in these children, and children who had household ambulation had a power of mean power of grade 4 MRC. The ones who were physiological ambulation had a power of 3.3, and 18 of children who were wheelchair bound or carried by parents had a power of 2.7. We mainly tested the hip abductors, the quadriceps, the hip extensors, the hamstring. We performed stage surgeries for the femur and the tibia. Occasionally, we would do the femur and tibia together because there's high risk of bleeding when we combine two femur surgeries in OI patients. The mean follow-up was 34 months, and the mean time to healing of osteotomy was 8 weeks. 20 children had received intravenous bisphosphonate in the form of zoledronic acid at least on more than 3 occasions. Various implants were used as seen in this chart. Predominantly, we used the rush rods and the locally made FD rods. In some cases, we used the K-wire as the canal was very, very narrow. And in some cases, we used a slim nail, especially in the humerus. We used also supplementary fixation in some of these cases that had rotational malalignment or rotational problems. These are the rod variability. Example of a child, 12-year-old girl with bilateral femur fractures, operated almost 3 times with wires and plates. You can see the scar on the thigh, and she underwent rodding of both the femur in a staged fashion. We use a rush rod. You can see the canal is very, very sclerotic. And here she's a 1-year follow-up. She's able to ambulate with orthosis, and now currently she ambulates without support. This is a 7-year-old boy who underwent plate fixation for his first femur fracture, then had the second femur fracture, underwent bilateral plating, and then he fractured below the plate. This child was diagnosed to have a rare type of osteogenesis imperfecta, and he then underwent FD rodding for both the femur as well as a solid rod for the tibia. It is not unusual to see plate fixation of OI bones, and this child had a deformity of the femur below the plate, and this was then revised. We did a pre-operative planning to mark the level of the osteotomy and also see the canal size. Then we used a plate as a buttress until the rod was inside, and once the rod was in, we did a neck fixation as well. And this was the X-ray at post-op. We also needed additional osteotomy at the lower end, which was fixed with wires to centralize the rod. His tibia also was rodded, and you can see the supplementary plate fixation, and subsequently he was given an orthosis. Use of supplementary fixation is required, but don't overstuff using metal, otherwise you will get a failed fixation. So I like to use simple wires to align the bone so that the rod can be inserted in the central part of the canal. But never use plates in OI because the bone will get deformed above and below the plate. So we always prefer some kind of intramedullary solid or a hollow rod. This is a 7-year-old boy with multiple fractures, and you can see his deformity. He was unable to walk because of pain. Initially we had done his femur. Subsequently he was lost to follow-up, and when he came, he fractured at the tip of the rod, both in the femur and the tibia. It was then revised to an FD nail, and you can see on the left side he got considerable growth. Again he came back at 7 years, and we had to revise his fixation. We used an FD nail. This is the left side nail. This was his post of function. He recovered very well, started walking, and this is subsequent rodding was done as he grew older. Both the femur were rodded. His tibia also was rodded, and you can see the bone is well aligned. One of the worry in these children, they tend to develop these neck of femur fractures, and now we have started fixing these prophylactically to prevent this kind of coxa vara. This is what he developed later on, but he refused surgery and was treated in a hip spica until the fracture healed. This was his humerus fixation, and then he outgrew the fixation, and this was the deformity. He came up for revision. This is the follow-up at 8 years. He ambulates with support. This is his father holding him. His gait pattern. He uses a walker to walk. This was the older child, 21 years of age, who had more than 20 fractures. His sibling had died of basal invagination, and he was really concerned about himself. He had significant spine deformities and leg deformities. His canal was very narrow, very sclerotic, and only could take a 2mm rod. So he did his femur as well as the tibia in a staged fashion. Again, we have used derotation plate. This is a very thin rod because the canal is highly sclerotic. This was the subsequent follow-up at healing. This was a spine deformity which we have left it alone for the time being. And this child, who was almost a young adult, achieved great ambulation, and you can see him walk here. He can also ride a two-wheeler, and he was really grateful once he could achieve independence. This was a 5-year-old girl with Brooks syndrome, having severe deformity in the femur as well as the tibia. We did a femur rodding as well as a tibial rodding, and subsequently we did the humerus as well. We revised the humerus rod, but till date we haven't revised the femur. She hasn't grown much in height. She is unable to ambulate because of the knee contracture and uses the wheelchair. This is an 8-year-old child. He was a horizontal ambulator, and we did his left femur using a rush rod, and subsequently when he came back after 2 years, we did his right side. We used the FD nail, and he's now awaiting revision on the left side. I prefer to do these open so that we can mark the osteotomy and at the same time get a good alignment of the bone. But there are some unusual situations which we have faced. This is a boy who had a subtrochanteric non-union for many years, and this is the first time we had used BMP7 for augmenting healing. His canal was so narrow that we had to use a 2mm slim nail. The central part of the femur was extremely narrow and would not accommodate an FD nail. This is a girl who we had done when she was age 7. She came back fracturing at the junction of the rod, and the rod had migrated out of the bone, and she was subsequently revised. We had one case where we had distraction of the osteotomy, but subsequently this healed very well. We had to keep her in a spica. Again, I'm really concerned about these very narrow segment of diaphysis, which cannot accommodate an FD nail, and so we had to use a slim rod. Another situation where the child had a rodding done 3 years ago and he fell down, the rod had migrated and had come out of his skin. So again, you revise to an FD nail. So looking at the results, we had 8 children who had household ambulation, 4 of them improved, 8 had physiological ambulation, 4 had achieved community ambulation, and 18 that were wheelchair bound, 7 became physiological ambulators, and 3 could ambulate in the community. We had our share of complications, refracture, asymptomatic union, as well as delayed union and non-union in cases of humerus. Ultimately, the prognosis for walking depends on the muscle power, the pre-op walking ability, the joint laxity, and also the recurrent fractures. Once the bones are aligned, there's a chance for the muscle power to improve, and hence the potential for improving the child's walking ability. In conclusion, rodding is mainly done to prevent refractures and this vicious cycle of refracture, stiffness, weakness, and refracture. Parents reported greater satisfaction as children didn't need to get repeat plasters. Post-op physiotherapy is extremely important and perhaps more important than the rodding, and most of the children will need some kind of lightweight orthosis to control the joint laxity as well as the abnormal joint position. And I'm grateful to Dr. Peter Smith, who initiated us for the first time in 2015 to hold the first OI meeting in India, and subsequently we had Dr. Ren from China who visited us the subsequent year. Thank you very much.
Thank you, Atul. Thank you for the sharing the Indian experience. Okay, so I will have one question to both of the Andrew and Raggy. What Jayant has asked, how would you address the two important issues, the scoliosis, deformity of knee joint, and limb length discrepancy? Yeah, you are muted. Unmute.
Okay, I was just answering them. So scoliosis, and I'm not doing any spine. I was going to say unfortunately, but I would say fortunately. Here we have 2 of my colleagues. If you want me, I can send their coordinates, and they are doing all the spine, including the complicated spine there. So that's for the spine. Regarding the limb lengthening, I have never done a limb lengthening. The only paper that I'm aware of was one by
Sheffield.
the people in Sheffield by James Fernandez. And that's the only paper that I'm aware of. I must say, however, that we have here quite a bit of children with OI. How many of them really need their limb length discrepancy to be corrected? It's none. Okay, many of them have a limb length discrepancy. However, because of their functional status and how much they are doing, that can be adjusted with simply a lift, with braces, with orthosis. So I would not personally take the risk of putting an external fixator on a child with OI. He will not tolerate this. With the precise lengthening now with the intramedullary device, I don't think it's a good idea. However, it may be a good idea with the plate internal lengthening device. I don't have experience with this also. Regarding the knee flexion deformity and gross modulation, I have never done an anterior hemiepiphysiodesis of the distal femur for this. I have done it, all of us have done it for coronal deformity, and it works in these. By the way, here I must mention that I've done it twice, a complete epiphysiodesis in children with OI, and that works also, but not lengthening procedure. In knee flexion deformity, it's either said like soft tissue or bony. If it's bony, with the bone resection that you do, femoral, it corrects the knee flexion deformity. How often did I do like a CP, a lengthening of the hamstrings, almost, well, so it's not an issue. We should be careful with aggressive physiotherapy in these cases because it can break the femur. It is part of the overall deformity and usually it's addressed when you do a femoral shortening. So that's my quick answer. Hopefully it's okay.
Thanks. Another issue I want to address that, as you said, not the fixed flexion deformity, but it would be very commonly seen in BRUC, and that is the most difficult issue, that osteogenesis with the MCC. It's one of the most challenging.
That's a different story completely. And I've had 3 patients with the BRUC syndrome, which is a combination of OI and arthrogryposis. And again, there was a paper published by Richard Cruz, I think only 4 patients. I treated both of them, and one of them, if you have a severe knee flexion deformity in arthrogryposis, you do a femoral shortening, you can do I do also a supracondylar osteotomy, I put a plate, and both broke, fractured that femur proximal or distal to the plate. The bone was so thin that cannot tolerate this thing. So in retrospect, I don't have a full answer to this, but these are soft tissue contractures and it's a different story than a simple OI. We should be very careful. And I think if I have to do it again, I will not use plates, which plates alone are contraindicated in OI, but I will do a big femoral shortening and I would put an intramedullary nail in both of them. That's what I would do in BRUC syndrome.
One more last question, but it is out of way. You have published on hip dysplasia on the OI. So would you comment, like to comment on that hip also?
Yeah, it's a special, there is a genetic component that we identified, a special mutation in a collagen. And I think up to now we had 6 patients like this. I think the main issue is a very severe ligamentous laxity, which is also common in children with OI. And the last one had 3 times revision of OI subluxation. We left it out at the end after 3 times. So maybe that's what we should be doing. She's asymptomatic, she has good range of motion, the hip is out. And the last thing that we said, should we use the adults when they do a revision several times, they use a artificial capsule, a sort of a mesh that they can use. That's probably what is being used, but I have no experience with this. It's not, and definitely it's not an easy problem.
Yes.
Show some cases?
Yes, sure.
Let me share the screen if I can. I'll just start with the case 1, and I think we've answered some of this question about how early one would do the rodding. And if I can ask Dr. Reggie as well as Dr. Andrew, what would be the minimum size of the rod you can use in a child of 20 months of age that comes with bilateral femur fractures, child is unable to stand and achieve milestones? Would you rod it at this stage, or would you give them some medications and wait before you start fixation?
I can answer this quickly. The standard is that we wait until the child is pulling to stand. However, nothing is black, nothing is white, everything is gray like anything else, like in life. And if this girl had repeated fractures in the femur, just to immobilize her would be very detrimental, because you want to break this cycle of immobilization, osteoporosis, and all these things. So I would rod her definitely. And I was always able to put a 3.2 FD rod in the femur, not in the tibia, but in the tibia. So and the decision, as it was beautifully said by Andrew again, the decision is made intraoperatively. If, however, I see that the canal will need lots of reaming of the thing, I would not hesitate to put a slim nail here. The smallest slim nail is 2 millimeters. And it's very easy to, I love the slim nail. I mean, it's a beautiful rod, and it helps when you have an anchoring system in it. So we have the proximal threads will be anchored in the greater trochanteric area. 2 millimeters, you can insert it, definitely, in the femur. So it will be either a 2 millimeter slim nail or a 3.2 FD rod. If not, just put an elastic nail or a K-wire. But I would rod them, definitely. I don't know what you think, Andrew.
Andrew, what about you? Would you rod them so early, or would you give them some medication before you do the rodding at this age, at 20 months?
I like to treat them medically first. Sometimes they come to you without that, and in the Indian situation, it may take a little while before this patient comes to medical attention and gets treated. Here, she would have been treated already, and so we wouldn't have to make that decision. Looking at this bone, this is not terrible bone. This bone will support rods. You can do it anytime. And I look at the parents and I say, has she worn you out by fracturing yet? And I look at the fracture cascade and I say, has she worn me out by fracturing yet? And I also tell the parents that you've got a patient with severe OI. She is going to fracture. She'll fracture with rods in, but they'll probably be easier and she'll probably develop better. And I also tell them that, she's growing at her fastest now, other than in utero. So this is the shortest duration you're going to get out of a rod. This is a very early revision. And the billiard player approach to surgery, setting yourself up for your next shot, says make the revision easy. So a rush rod that's easy to pull out, or that threaded slim rod that's easy to pull out. The last thing you want to do is turn this into a femur with a Williams rod in the middle of it somewhere that's bent on the top and hard to revise in a girl who's 3.5. So you're going to be revising a 3.5 or a 4-year-old, make it easy for yourself.
This girl, actually, when she came to me, she had the one fracture, and the mother-in-law was blaming the mother that didn't look after the child. And then she came with a second fracture. And then I told the grandmother that this child has a fragile bone disease, so don't blame your daughter-in-law. She's not the culprit here. And then we did her rush rodding, both sides in stage fashion. And this is my oldest patient. I've been seeing her for the last 15 years. And then we've done subsequent roddings. The last surgery was done 3 years ago when I did the femur. And this is where the real challenge was. She actually had a significant ballooning of the distal femur, where I put allograft inside. This was at age 16. So 3 years earlier, I rodded both the femur, the tibia. She subsequently underwent a spine surgery because of the deformity. This was done by an American team that was visiting India. And then here she is at age 16. She's really ambulatory. And this is my longest follow-up. So I've been really pleased to see her, that she comes for follow-up regularly. And I've been able to maintain her ambulation and prevent refractures. So, I'm a big fan of supplementary fixations, especially in the femur, where the canal is very narrow in the diaphysis. We don't have not much control, putting the FD nails. And I'll just share one more child. This was a child.
Just make it full screen. Full screen.
Sorry. Thanks. So this was an interesting case. This child came at age 10 years to me, and he had multiple fractures, and he had gone to several doctors who told him that you must wait till adolescent before you get an operation. So he had about 5 or 6 cycles of bisphosphonates, which was seen as per these Harris lines. But when he came to me, the real challenge was the canal here. And Dr. Reggie, what would you do for these very narrow canals where you can't, say, insert an FD nail? We had the minimum nail at that time in India was 4 millimeters, and this canal would not accommodate it. So have you ever used any other technique besides the FD nail in your practice?
Well, yes, definitely. They said it's very, very unusual. However, this case, it seems there is a very no canal or no canal at all. So I would still try to do a canal. As I mentioned, you can use the tiny drill bits to open the canal. If 3.2 is not fitting, I would try the smallest slim nail, which is 2 millimeter. If 2 millimeters cannot work, then I simply use elastic nail, it's 1.6, or a K-wire. Sometimes the K-wire is a 1.2, 1.6 is the only thing that you insert. Sometimes also, and that's I learned it by François Fassier, is that you put your small nail, whatever it is, proximally. Sometimes there is nothing in the middle, and you have to go out of the canal and then back in the canal distally. It's in and out and in technique. And we have here some patient like this. It's perfectly acceptable because, I mean, there is no other solution. So I would not hesitate to use this. You have in the proximal part the canal, you have a canal distally. So simply go in, out, in. And as you just mentioned, I would supplement it also, if you can, with any plate. And sometime at the site of the osteotomy, you cannot put a plate simply because there is no place. So just put a locking, a very, very locking plate. That we have a special company here, EVOS. I don't know if you have it in India. It's beautiful size and plates. So I would put a very long locking plate there. But I would fix it even if it goes to a K-wire.
Right. So that is what we did. That was this canal, and this was the earlier days where we did the classical shish kebab surgery, opened this canal, put the bones on the table, and the sisters were aghast that how can I remove the bone, and kept in the table. And this canal was very narrow. We used a 2 millimeter K-wire. I put him in a spica for 6 weeks. This was his X-rays when he came out of the cast. And then we subsequently revised his rodding. Again, there was no canal in the center. I just revised him by changing the rod before he actually fractured. Here he was standing with the help of orthosis, and subsequently he continued to walk with an orthosis. So he became heavier in the top part. So I didn't want to remove the orthosis. And this was his final imaging. And here he is now without the orthosis. He's had several cycles of zoledronic acid, and he continues to maintain ambulation with the help of a walker. Occasionally at home, he walks without support. So again, he's been one of my longest follow-ups. He's now doing BSc physics, so extremely clever boy. And this is the type of children you really want to treat them and try and keep them as mobile as possible.
That's a beautiful result. I just want to say one thing here, and again, Andrew mentioned it before. Lots of decisions in OI are done intraoperatively. It's very, very difficult to plan every step. So it's very important to have every type and every size of nail that you can imagine. FD, slim nails, rush rod, K-wires, Anders nail, because you don't know which one you are going to use. So it's very, very important, this the intraoperative decision making.
Right. Hitesh, you want to share some cases? Hitesh?
Yes, Atul. Should I share my screen?
Sure. Go ahead.
Is it my screen is visible?
Yes, it's visible.
Okay,
Yes,
I have one case that is the both of you, and that the 8-year-old child with the known case of OI, he was on disbursement treatment, and he got the history of the femur fracture, and that is 2 months old. So as Regi has said that you will do only retrograde in very severe deformity, what would you plan for such cases when they presented late?
What I was saying about the retrograde is specifically for the proximal femur.
Yes.
Because the proximal femur, they have the severe flexion deformity. It's very, very difficult, if not impossible, to reach the greater trochanter. But the diaphyseal fractures and deformities here, you can put antegrade, retrograde, it doesn't matter.
Okay.
If you have to open it, like here, probably you will need to open it. Then once it's opened, I find it easier to go retrograde. However, as I said, here you have both option, retrograde or antegrade. You have a canal, a big size canal. So I will open it. Probably you will need another osteotomy in the proximal fragment because it looks like there is an anterior angulation at the junction of the proximal and medial third. So again, both antegrade, retrograde. and it will take an FD of 4 or 4.8 even. And I would put a small plate, like it's either from the mini fragment or the distal radius plate, a 2.7. I will add it to this thing. It's healed, so are you going to use bone graft or not? I will not use bone graft on a fracture like this because it looks healed.
Okay. Andrew, you want to have any comment?
I think Reggie's covered it. Yeah, that probably is going to need an osteotomy to my eye as well. And I think it's going to be very difficult to do that antegrade and closed, but you could make your first osteotomy closed and see if you are able to mobilize that fracture. The likelihood is that the gentlest way to mobilize that fracture is going to be to open it. I think it would be very difficult to get the length if you're trying to do it closed.
Yeah, both of you are correct. Actually, there is a proximal bow is there, but what we did it a little on the proximal aspect, we went and passed the one rod on the proximal osteotomy and passed the two rush rod, one from above and one from below. And we didn't do the osteotomy, did not do the plate fixation, but it's correct. If it is rotationally unstable, the advantage of the double rush rod, it will be a little bit rotationally better than the telescopic.
Yeah, I think double rush rods have actually a lot of advantages in terms of the rotation and the canal fill, and also a little bit of flexibility to them. I think they probably load share better than a cylindrical steel rod. So you may get a better biology of bone. I don't use them because we have access to this other stuff, but you know, that's a pretty minimal intrusion into the knee cavity as well. And as long as they're staying there, it looks like you've got a path to revision. And now you've got, yes, exactly. Now you've got a much older child. And now you've got a little chest problem, haven't you?
Yes, it's exactly that. It was telescoping through the length of the entire femur, but it was not supporting, and he got another fall, but he did not come at that point. So we thought it's an adolescent, will revise only the proximal part. So we did only the proximal, the revision of the proximal part. But what happened that it's the distal rod migrated, as is mentioned that, but it's the skeletal mature is ambulant. It's the longest follow-up, 15 years follow-up, and he's totally independent ambulator.
So there is still a stress riser there. Your last x-rays prove that you can't predict when they're going to fracture, and you can't predict where they're going to fracture either. I think if you had asked everybody in the audience to point to where the next fracture is going to occur, you would have had votes for anything along the entire length of the femur. And I think this is the issue with revisions as well. You know, he's got a bone that's slightly crooked. He's got a rod from the proximal end that is going to be accessible and easy to take out. He's got a rod from the distal end that's going to be a little bit of a beast to remove. But he's only better if he's either having pain or problems or progression or something in the real world. And for him to have 4 slightly easier operations, any of which can give him complications, or for you to do 1 or 2 that are more difficult, what's actually better for him? And that's some of the difficulty of looking at the x-rays and trying to figure out what to do for a particular boy or girl. You need them in the room with their parents to say, are we doing anything here or not?
Yeah, he is skeletally mature now, and he's independent ambulator. The both growth plates are fused. So would you like to do anything? Because he doesn't want any surgery, and I did not actually advise the surgery as well.
I think here you can offer, but I think you can give him the advantages and the disadvantages. The advantage of getting a single straight rod that controls much more of the bone is that if he does have a fracture at the tip of that the more proximal nail, then he's going to be older. He's going to be out of your practice. Maybe he's in the adult world. If you leave it, that fracture may never happen. And if it fractures right there, it's an easy enough revision anyway.
Yeah.
So it's pros and cons. You can weigh it up. I don't think this one is one that I would say, oh, we have to do something now because it will be a disaster later. I think this is one where you can say, might never happen, might happen, easy to treat if it does.
Yes. Yes. Dr. Reggie, you want to have any comment?
No, I agree with Andrew. I think you should take every case individually. In this one, it's a gray zone, but I agree. We'll tell him you may need a revision, you may not need a revision, and if you need a revision, we don't think it will be complex, so I would wait.
Okay. I will move on the next case. This is the 16-year-old boy. It's not presented with anybody has got the multiple fractures of the both lower limb. He presented with the severe deformity of both the tibia, and his X-rays was like that. It's very, very difficult to take the hygienic care from the posterior aspect of the calf. So the Andrew has already covered these topics, but then what will you do for such cases?
I think we have cases, all of us, we have cases like this, maybe not as severe. Number one, it's the decision to operate or to not operate. I mean, I haven't seen him, I don't know much, but I will operate. You cannot leave him, I think, like this. You will need quite a bit of bone resection here. And definitely, how much? It's almost a third of the tibia, but you will do your resection on both sides. So it will not really affect him. So I think it's bilateral big resection, both the tibia and the fibula. And I think there is a canal. As I said, the popcorn appearance here, it makes the anchorage difficult, but it takes whatever it takes. Again, this decision will be made in the operating room, whether a slim nail, I think, how old is the patient?
16 years.
16, okay, so there is no point putting an FED. So I would put any type of solid rod, but the most important is the massive bone resection that you need.
Yes, Andrew, you already covered in his talk, but would you see such kind of the anterior bowing? And if you see the clinically, it was the both side. It was something new for me. We have seen a distal and proximal and popcorn type appearance, but not at the fracture side.
Yeah, I think that's a pretty extreme example with the bone immediately subcutaneous there. And so you are going to do these open, and I think you're going to be fairly careful of the skin. And you just think of that as being really a lot of extra tibia. And sometimes that extra tibia can be cut off and placed in the pocket between the tibia and the fibula, because these are both very wimpy bones. And if you can get some kind of a cross union going, I don't think the fibula is big enough to rod in this case. I sometimes look at them and say, am I going to get something supplementary if I rod the fibula as well? But that's just the wispiest little K-wire. So I think tibial rod only, and it's going to be small. And take the bone that you're resecting, or at least some of it, and place it around, especially under the muscle between the tibia and the fibula. And look where the foot is now. The foot is not going to be much further from the knee than this, because it never has been.
Yes.
So as long as the patient understands that.
Yeah, thank you. Actually, it is that, as you mentioned in your talk, also it required the extensive the correction, and as you say that we did it the proximal and distal, still there was an overlap, and that also we need to cut that, and we did it. That's it. So the both side actually we did it, and it was reasonably looking okay, and he was fine. He was very happy.
Well, this is the beauty of coming to a meeting in India. If I've got something tall, you've got something taller. If I've got something bent, you've got something more bent. If I've got something that smells really good or really bad, every dimension of human experience goes on an Indian scale instead of just that kind of rest of the world scale. And I love these meetings for that reason.
And I think Andrew has summed it really well, and I think it's a great experience. We've got just last 5 minutes remaining. Any last minute thoughts, suggestions? I just want to know, has any one of you used the gap nail? I know Pega makes these fancy nails for proximal femur. Any experience with those nails, Dr. Reggie and Dr. Andrew?
We have used the gap nail in the femur and in the tibia. And my personal experience, I have one of my colleagues also here, is that the proximal part of the gap nail is quite large in diameter, and it causes really not destruction of the bone, but it's a big hole. It's a big hole, and if you come to revise it or do something, you have really nothing. It's really a problem. So my question, if you go back, the gap nail was designed by it's called Galvez or Gavilan. Anyway, they're from Latin America, and it was designed to serve to fill the gap between the FD maximum, which is 6.4, and the smallest solid diameter, which was 8 or 8.2 before. So used to fill this gap. But now we have more and more solid nails with a small diameter. If I have anything that can replace the gap nail, I would use it. The gap nail really is at the bottom of my armamentarium, as you mentioned. But it has nice proximal holes that you can put the screws to protect the femoral neck, to go into various amounts. So there are positive things about the gap nail, and yes, we have used it. But we should be careful about the amount of bone that it destroys while introducing it.
Andrew, what are
And
your
you can
thoughts?
lock it proximally and distally also.
Right. Yeah.
Yeah, I saw some gap nails in Reggie's talk. I use it as well. It's a very nice bailout. The child with OI who's got that massive bulbous bone fits a gap nail best, or my patients with fibrous dysplasia who are young and falling apart. That's probably where I use it most commonly, and I get much better grab into the cephalomedullary piece for those fibrous dysplasia. Mushy bone keeps falling apart. In the OIs, sometimes I've got some patients who are so slim up there that even the top end of an FD rod is too much, is eroding the lateral cortex, is breaking out, is blowing out. Those ones I still don't know what to do with. And a gap nail is no help. And if the rod is so sparse, then the more traditional techniques that Reggie is showing you are still what I fall back on with the K-wires. And I think somebody went and proved that with the olecranons as well, right? A little wire is sometimes more biologically appropriate compared with a big solid screw. So the gap nail is great fun. The instrumentation is great. You'll get it in the right place with their little templates. Like, it's supremely well designed, and operating is fun, and we love this stuff. But it's not good for our patient whose primary problem is that there isn't enough bone proximally and the bone is too weak. So look for your fibrous dysplasia patients and then play away.
Thank you very much. So I think we've just come to the end of our session. I'm really grateful to Dr. Reggie and Andrew for sharing their experience and their thoughts. And it's been a wonderful 3-hour journey. I thank my co-panelist, Hitesh Shah. Vijay is not there, but he's sent me his cases. So hope to see you all in Toronto sometime and in Montreal. And I will just hand over the mic to Sandeep Patwardhan, our secretary, to just give concluding remarks.
Thank you, Atul. So it's been an absolutely enthralling and brilliant 3 hours. And let me thank Reggie Hamdi and Andrew Howard for their brilliant talks, as well as insights into a very difficult problem. And we do see a lot of neglected cases, and you have highlighted it beautifully, that medical management first, and put any kind of linear intramedullary device as early as possible, as soon as the child learns to stand. because that is going to go in a long way, even for a short period of time, so that your revisions are better. And eventually we need to follow them up to improve their quality of life. And as Atul said, because they are usually cheerful and highly intelligent, they deserve a shot at being part of society. So with those words, I thank you all very much. I thank all the delegates, and I will see you all tomorrow at 8:25 in the morning for a very interesting session on congenital pseudarthrosis of the tibia, followed by the best paper session. So see you again tomorrow.
Thank you, Andrew.
Thank
Thank you,
you.
Reggie.
Thanks, Andrew. Thank you. Thanks, everyone.
Thank you.
Thank you very much. Great to see you guys. Great to almost see you guys.
Yes.
Bye, Andrew. Good night.
Have a good day.
Bye. Thanks.
Thanks.